Kamera dia berikan. Tes.
So, boleh dengar tak?
Video buat ni.
Anu, video. Ada siap?
Video.
Siap.
Video lama. Bayangkan, yang tak nampak. Videografer.
Tes. Ya. Jom.
Nanti dia akan bawa
Ijan, bilik Mr. Azmi boleh mute dulu.
You can reach me many ways, it don't matter how and when. Simply make the time for the best time of your life. Think of what you always dream, think of what you want to see. Simply make the time for the best time of your life. Truly Asia, it's the place with it all. Malaysia, truly Asia. Why wait for the best time of your life? For the best time of your life. Malaysia, truly Asia.
Finger dia. Mic dekat sini. Dia boleh.
Send invitation. Salam, boleh dengar?
Clear tak kita dengar punya suara?
Clear?
Clear lah. Okay. Dia punya suara macam slow sikit. Tak tahu kenapa.
Macam slow
Suara air macam slow sikit.
Sebab ini phone kot.
Oh, okay. No wonder. Ya, okay lah. Okay.
Komputer punya diorang dah set up ni. So saya tak nak usik. Okay, so kita
Jangan rasa
tak ada pula jangan usik S2, tapi saya rasa macam saya dah terkeluarkan dia daripada ni je. Anyway.
Jangan ada. So kita teruslah. Ada lagi berapa minit ni? 3 minit. Boleh rekod. So macam sekarang I ni start first.
Saya start dulu.
So nanti I akan saat ni biasa macam malam kita pilih-pilih rehearse lah.
Tak rehearse? Jom rehearse. Okay. So Nadia dengan co-host dia akan introduce semua benda. Lepas tu saya akan masuk lah. So saya akan cakap good morning to everybody. So today is our second day of the webinar. My name is Ailani. Moderating with me is Mr. Azhari, Head of Neurosurgery Department in Hospital Raja Permaisuri Baino Ipoh. So overall for today's session, there will be 5 speakers presenting topics related to congenital, hydrocephalus and infection related in neurosurgical patients. To start off today's session, let me introduce you to our first speaker, Dr. Chapupoy, a consultant neurosurgeon in Hospital Selayang, a member of Neurosurgical Association Malaysia. She's also a member of AASNS and Asian Society of Pediatric Neurosurgery, among others. Without further ado, let me welcome Dr.
Cuba try Jo.
Good morning.
Mikrofon dia jalan ke?
Jo. Okay dah pun. Dah. Cuba try. Okay dah tu.
Good morning, Miss Chia. How are you? So thank you, Professor, for your very interesting and informative talk. Our next speaker is Dr. Fatisha Abbas, a consultant neurosurgeon with special interest in cases, as well as a writer on hospital rasa sesuai tak nak cakap yang pasal yang writer tu? Ke nak tak payah cakap? Sebab Chia tak nak yang overall tu, Chia tak.
Dari
So either focus on this spider emergency.
Hello.
So let's focus on how we form.
Hello,
Therefore, the voice yours.
Thank you, Prof. Azizi, for your very interesting talk. Next will be Dr. Rohazli binti Ismail, a senior consultant pediatric radiologist currently based in Hospital Tunku Azizah, Kuala Lumpur. She is a medical graduate from University of Manchester before pursuing her radiology specialty in National University of Malaysia and subsequently her fellowship in Hospital Kuala Lumpur and the Royal Children's Hospital in Melbourne, Australia. Dr. Rohazli has been gazetted as a pediatric radiologist since 2012. Please welcome Dr. Rohazli with her talk on radiological findings on brain trauma.
Okay, thank you very much, Dr. Rohazli, for the very excellent lecture. Now we should go to the Q&A session. So nanti I ada few question I ada prepare. Mungkin ada question daripada box.
Okay, saya senyap je lah masa tu
Good morning. Good morning, Ailani.
Morning.
Good morning.
You can hear me?
Can. Hey, we are going to start on time, ma?
I think so.
Yeah, we are going to start on time now because the difficult to time the lecture, the presentation.
Okay.
I just get overshoot little bit or.
You overshoot.
Should be ngam-ngam lah, should be ngam-ngam.
Okay, so tak apa, your introduction I pendekkan sikit lah kalau macam tu.
Yeah, you pendek as much as possible. The simplest.
The simplest lah. Okay. Alright lah, kalau macam tu N6 dengan eospine semua tu I potong lah.
You just kata I'm one of the neurosurgeons here in Malaysia.
I just
So it is my great pleasure.
Potong the one that you asked me to potong tu lah.
Potong as much as possible lah.
Okay. Ada. Mr. Azhari, boleh dengar ke? Mr. Azhari? Syah, my voice okay tak?
Okay.
Sorry, okay. Mr. Azhari, video lag lah.
Yeah. Mr. Azhari, the macam lagging.
Oh ya ke? Sekejap, I check. Takut ada orang lain pun on internet.
Cia, your topic is CSF flow disruption kan?
Yeah.
Okay.
Actually, I just realized I talk more about obstruction sebab I thought I'm presenting on CSF outflow obstruction.
Okay. Tak apa.
Yeah, tapi essentially essentially is about the same lah.
Okay.
Yeah. The content is about the same lah.
Alright.
Still lagging eh?
Can see you.
Still lagging eh? Lenny? Chia?
Yeah, a little bit.
A bit.
Ah.
Oh, because I already off other people punya Wi-Fi. Can use my hotspot tapi I takut tak okay. Very good morning. Still lagging.
Okay, so far okay.
So far okay eh? I hope it's okay.
Sudah share screen?
Wah, it's good.
Share screen? Okay, keluar ni kenapa ni?
Dia macam
MC siapa? Boleh mancun on the way. Kalau tak saya yang start dulu bos.
Kita ubah sikit boleh tak?
Boleh?
Beli negara.
Boleh.
Dengan
Boleh.
kalau doktor boleh dengarkan video.
Okay. Terus start dulu.
Okay, Alani, all the best. Good luck.
All the best, Ustazah.
Oh, dia bilang jelas. Dia orang kata jelas tadi.
kita akan buka dengan lagu negaraku.
Okay.
Okay.
Masa tu jangan berdiri.
Masa negaraku jangan berdiri.
Okay.
Tapi nampak perut.
Okay. Tak nak nampak perut. Okay.
Lepas tu moderator tu.
Yeah, I mute mine now.
Okay. We are waiting for the participants to join and then start at 8 o'clock sharp.
Yeah.
Okay.
Hai, morning. Assalamualaikum, Mas Ari.
Assalamualaikum, Mr. Azmi.
Sehat?
Ya, Alhamdulillah, Mr. Azmi.
Okay, bagus. Thank you for joining us. Pupui okay ah?
Also.
Yeah, okay.
Okay, very good. So everybody sharp. So we will start sharp 8 o'clock. We will play Negaraku first and then visit
okay.
Malaysia here. Cuma during Negaraku, don't stand. Because if you
Okay.
stand, then the camera will show your belly.
Okay.
You just sit down and just respect the song. Don't stand when the lagu Negaraku. For
Okay.
webinar, you just stay. If you stand, then it will show your tummy. Okay, then followed by visit Malaysia, then pass to moderator kick off. I think the first speaker dah ada.
Yang lain slowly coming lah. So moderator have to lead the discussion. Give priority to the chat box question. If not, you kena ada one or two, at least one question to each speaker. Because they will show respect to the speaker, at least some response and stimulate the session. Our technical akan control timing. Dia akan bunyi ting bell lah. Kalau tak, sebab kita cross the room, we will beritahu you lah. And then we boleh, kalau session tu very lively, you can drag 5 minutes. Okay, then kita akan catch up balik sebab kita ada 20 minute Q&A. Actually, we use that to buffer any overshoot lah. Tapi try not to cross the other session. And usually, like today, we don't have any lunch break compared to yesterday. Yesterday we have lunch break another 20 minutes. So actually we buffer tau. So we finally we overshoot 10 minutes. Because the speaker, especially international speaker, they have their commitment. So they already arrange their time accordingly. Yeah. So overshoot mean not what they call it acceptable to them. So you kena jaga sikit the speed of the speaker. But important thing is actually the discussion part. Kalau boleh discussion to make it lively lah. Speaker, all the best. We got 57 countries joining us. Yeah, we are live on YouTube and Neurosurgical TV. So as attendance, like yesterday, peaked around 160, 170 at one time. But the composition changed. You know, from time to time, some continents start to join at certain hours. You know, even though you see the numbers like not change, but the composition of the audience change. So this is very dynamic, and audience actually from different part of the world. So you use a language that they understand and we can understand. Yeah. Okay. All the best. Thank you very much. So we'll be live in probably 4 minutes. Thank you.
Yes, thank you.
Morning Zam, Assalamualaikum.
Assalamualaikum.
Alhamdulillah, thank you for joining us.
Oh ya, boleh dengar? Okay,
boleh, very clear. Alright, very good, very good. Thank you. Kita akan start shortly dalam 2 minutes.
Okay.
Okay, thank you.
Yeah.
Good morning, everybody, and welcome to the second day of the joint AASNS educational course and second KL Neurosurgical Emergencies online course. My name is Louis Manchun. I'm representing the Department of Neurosurgery, Hospital Kuala Lumpur, which is headed by Dr. Azmi Alias. I welcome you all for the second day. I'm sure everybody had a lot of fun on the first day. We've learned a lot. We have very distinguished speakers, but today our topics are lined up in a few sections. The first section in this morning is on congenital hydrocephalus and infections. The second section will be on functional neurosurgery, including epilepsy and DBS surgery. And the third section before lunch would be vascular surgery, followed by the second session after the lunch break. So without further ado, allow me to introduce today's moderators for this morning session, Dr. Muhammad Azhari bin Omar and Dr. Ailani binti Abdul Ghani. They will be the moderators for this morning and they will introduce the speakers for this morning, and we will proceed without further ado for the second day of our conference. Please enjoy, please learn as much as you can, and please visit Malaysia.
Hi, thank you, Dr. Lui. Good morning and good evening to everyone, depending on where you are. So overall, this morning first session will be covering congenital hydrocephalus and infection related in neurosurgical patients. To start off today's session, the speaker is Dr. Chia Poi Poi, a consultant neurosurgeon based in Hospital Selayang. She's a member of Neurosurgical Association Malaysia, AASNS, and also Asian Australasian Society of Pediatric Neurosurgery, among other associations. Without further ado, let me welcome Dr. Chia Poi Poi with her topic, CSF flow disruption. Please, Dr. Chia Poi Poi.
Thank you. Good morning, everyone. Good morning, everyone who are in Malaysia now, and good afternoon or evening to everyone else in other parts of the world. First of all, thank you, Dr. Ailani, for introducing me to this presentation. And I would like to take this opportunity to thank Mr. Azmi Alias and his team members for organizing this teaching course and webinar. And also, I would like to congratulate his team members and team for bringing this webinar to a success today. Today is already the second day of the webinar, and we can see that there's overwhelming responses from all over the world. There are a total of 57 countries, participants from 57 countries joining us, and also there are a lot of active, lively discussions in each session. Okay. My topic for today is actually CSF flow disruption. Okay, let me share my presentation first. Sorry about that for the technical problem. I would like to take a minute. Okay. I'm going to present now on CSF flow disruption. I'm Pui Pui from Malaysia. Okay, today my topic is quite wide. Actually, yesterday itself, during the afternoon sessions by Prof. Damendra, Prof. Misra, and also the Prof. Sel, they have already discussed something about like surgical strategies to manage hydrocephalus and caused by cellular tumors and posterior fossa tumors, as well as intraventricular tumors. Today, part of my discussion is also going to talk about this. There's not much difference, but of course, in terms of managing hydrocephalus caused by CSF flow disruption, regardless of where the obstruction is, actually there are still a lot of debate issues until today. Okay, I would like to start off my presentation with some simple recall of the basic sciences like CSF flow, CSF production, and the CSF circulation. Lastly, we'll talk about the types of hydrocephalus and its treatment options. Okay, hydrocephalus derived from the Greek word with hydro means hydro means water, cephalus means head. Hydrocephalus simply means excessive accumulation of cerebrospinal fluid, resulting in abnormal widening of the ventricular spaces in the brain, which inevitably resulting in raised intracranial pressure, such as symptoms of headache, nausea, vomiting, diplopia, double vision, blurring of vision, occultation, and so on. About the formation of CSF, most CSF is formed in the ventricles. Okay, possible sites of origin include the ventricular correct plexus, where 80% of the CSF is actually produced by the correct plexus, and about 15 to 20% of the CSF is produced by the brain parenchyma. Nucleus around the CSF actually produced by the ependyma. It is believed that the CSF is an ultrafiltrate of the plasma that enters the basal site of the correct epithelium, and by active metabolism, it is transformed into the CSF and secreted at the apical or ventricular site of the epithelium. This mechanism of CSF formation, however, is largely speculative. I'm sure that my subsequent speaker, who is going to speak on the CSF dynamics, maybe will enlighten us more about the CSF dynamics. Okay. Clinical studies have shown that the formation rate of CSF is about 20 mL per hour, or about 500 mL per day in adults and children. The total CSF volume in the ventricles throughout the subaortic spaces is age dependent, and it reaches the adult volume of about 150 mL for all adults and children with 5 years and above. That means at any one point of time, with children, older children with age more than 5 years and above, and adults, there will be about 150 of ml of CSF in the brain. The rate of CSF formation is normal or slightly reduced in children with hydrocephalus. Okay, this diagram to show the flow of the CSF. Okay, to start off with, okay, CSF is secreted by the correct plexus in the lateral ventricles. Number one, CSF is secreted here at two lateral ventricles by the correct plexus. And the CSF here flows to the third ventricle via the interventricular foramen, or rather known as foramen of Monro. Thirdly, there is also correct plexus in the third ventricles. The correct plexus in the third ventricles secrete more CSF. For the CSF to flow from the third ventricle to the fourth ventricle, it has to bypass the aqueduct of Sylvius. In the fourth ventricle itself, there is more CSF produced by the correct plexus in the fourth ventricle. And at the level of the fourth ventricle, the CSF flows out through two lateral apertures and the one medial apertures, which are the foramina of Lukács and the foramen of Mackenzie. And at the level of the infratentorial spaces here, the CSF fills the subaortic space and bathes the external surfaces of the brain and spinal cord. After that, the CSF will circulate throughout the surface of the brain. At aortic villi, the CSF is resorbed into the venous blood of the dural venous sinuses. After CSF is being absorbed, there's always an absorption. Okay, there are three theories to postulate how CSF is being absorbed in the brain. Firstly is by bulk flow. Secondly, by aortic villi absorption. And thirdly, there are accessory routes to help to absorb the CSF. The only proven force responsible for bulk CSF absorption is that of hydrostatic gradient. In this bulk flow theory, it is believed that at any one point of time, there should be about different pressure gradient about 5 millimeter mercury in the intracranial compartment and the ventricles. Therefore, this 5 millimeter mercury of the pressure difference can force the pressure in the intracranial compartment to flow in the ventricles. Secondly, aortic villi helps to resorb the CSF. It appears that the aryanoid villi drains CSF from the subaryanoid space into the major dural sinuses by unidirectional flow after a critical opening pressure is exceeded. Okay, there are also other ways where CSF is being absorbed. CSF drainage may occur through accessory routes at the mucosa of the paranasal sinuses, nasal mucosa, cranial nerve root shafts, and the cervical lymph nodes. Okay, how hydrocephalus is formed? There's always because of an imbalance between the CSF production and CSF absorption. In most of the cases, the usual scenario will be there is reduced CSF absorption after an insult to the brain, or after that an obstruction occurs in the pathway of the CSF circulation, or on the other hand, CSF overproduction can also cause hydrocephalus. They are only one of few causes of excessive CSF production. For example, the most commonest causes of excessive CSF production in the brain is actually correct plexus papilloma, and this is a very common pediatric tumor. Okay. On the other hand, when there is an impact of CSF absorption, there will be excessive CSF accumulation in the brain. Okay. Sometimes when there is obstruction at the basal cisterns caused by tumor at any level of the flow of the CSF, or because of there's a hemorrhage or post-infective insult, there will be obstruction of the basal cistern, causing there is reduced drainage of the ventricular CSF into the subaryanoid space, causing reduced CSF absorption. Okay, occlusion or atresia of the aryanoid villi can happen. Occlusion of example of occlusion of aryanoid villi occurs when there is a thrombus formed in the cerebral venous sinuses, where it will occlude the aryanoid villi to help to absorb the CSF. Atresia of aryanoid villi is rather very, very rare among the pediatric population, but it does occur. It is postulated that there is congenital atresia or slightly hypertrophy of the aryanoid villi in this group of the patient. Thus, they have a decreased capability of the CSF to be resolved. Thus, they have hydrocephalus. Another entity which can cause a reduced CSF absorption is when there is increased sagittal sinus pressure. Okay. It is believed that what I've mentioned earlier, there should be a pressure gradient between the intracranial compartment and the sinuses. This should be at least 5 millimeter mercury to facilitate the CSF absorption. However, in cases where there is an increased sagittal sinus pressure, in cases where there is a vein or gallon malformation, or when the patient has congenital heart disease, where there is an increased pressure in the right atria, or where there's instances where the patient has a syndromic or asyndromic cranial synostosis or achondroplasia, the skull wall itself, or the pressure in the sagittal sinus itself is increased. Thus, in order to help to absorb the CSF, actually the pressure in the intracranial compartment has to be higher. Eventually, there's a disruption in this balance, causing reduced CSF absorption and thus excessive accumulation of the CSF and hydrocephalus form. Okay. When we talk about CSF flow disruption, I have divided this into different levels of flow disruption depending on the pathway of the CSF flow. First of all, we look at the first level, when after the correct plexus in the lateral ventricle secrete the CSF, it has to flow to the foramen of Monro, flow through the foramen Monro into the third ventricle. So if there is any obstruction at the level of the foramen Monro, hydrocephalus will form. Okay. Secondly, from the third ventricle, the CSF will flow into the fourth ventricle by aqueduct or sylvius. If there is any obstructions at this level, hydrocephalus will also form. Lastly, okay, at the fourth ventricle, CSF has to go out to the subaryanoid spaces via the outlet foramina of fourth ventricle, which is the foramina Olushka and McEntee. If there's any obstruction at this level, then hydrocephalus forms. Okay, usually all the obstruction occurs here will result in obstructive hydrocephalus. Okay, this will be the last pathology of the CSF flow disruption. When there's a CSF flow disruption at the level of the arachnoid villi, actually what happens, reduced CSF absorption at this level usually results in communicating hydrocephalus, which is in contrast with other types of CSF flow disruption. And usually the hydrocephalus happens here is due to post-infection or post-hemorrhagic. Okay. Now, when we talk about CSF flow obstruction at the level of foramen of Monro, there are multiple causes. Among all these causes, tumors are very common. Okay, the common pathologies causing CSF flow obstruction at foramen of Monro include craniopharyngioma, optic pathway glioma, colloid cyst, germ cell tumors, pituitary tumors, dermoid cyst, arachnoid cyst. Okay, this is a classification of the foramen Monro lesions causing obstructive hydrocephalus according to the etiological classification as well as pathological classification. Okay, in hydrocephalus at the level of foramen Monro obstruction, the types of hydrocephalus can be univentricular when only one of the foramen Monro is obstructed. Of course, the hydrocephalus can also be biventricular when both foramen Monros are obstructed. And lastly, they can be multiseptated hydrocephalus in also CSF flow disruption at the level of foramen of Monro. Etiologically wise, okay, congenital lesions at the foramen of Monro, inflammatory process, infection, tumors, neoplasm, or trauma or hemorrhagic insult can cause obstruction at the foramen of Monro. The lesions, according to pathological classification, lesions are largely tumor or stenosis, adhesions, exudates, blood products can also cause foramen of Monro obstructions. Among the third ventricular tumors that are common causing obstructive hydrocephalus are colloid cysts and maybe some cellular tumors that cause the outflow obstruction. Lateral ventricles have been mentioned by Prof. Misra yesterday. Among them are ependymoma or subependymoma, and then they can be central neurocytoma or septal lesions also, such as central neurocytoma, can also cause obstruction at the level of the foramen Monro. Extraventricular lesions such as thalamic tumor or chiasmatic tumors can also cause obstruction at the foramen of Monro. Okay, now we move on to obstruction at the aqueduct of Suez. Moving on, when the CSF can successfully flow from the lateral ventricle to the third ventricle, the CSF has to flow from the third ventricle to the fourth ventricle via the aqueduct of Suez. When there's an obstruction here, obstructive hydrocephalus will occur. Okay, common causes leading to obstruction at this region are congenital aqueduct stenosis, pineal region tumor, and tetraglioma. Okay. I will talk a little bit about the X-linked hydrocephalus here. It is only 4% of all hydrocephalus. Okay, in this aqueduct stenosis, it is usually congenital. It is an inheritable form of aqueduct stenosis that have been described, occurs only in males and is transmitted from one generation to the next by a female carrier. Thus, it is called X-linked hydrocephalus. It only constitutes about 4% of all hydrocephalus cases. However, among the hydrocephalus in boys or in the male pediatric group, this accounts for about 8 to 15%. Okay, the abnormal gene is actually located on the XQ28, and its effect is the deficiency of the L1 sub-adhesion molecule. And usually patients with X-linked hydrocephalus will present with mental retardation, corpus callosum hypoplasia, abducted thumbs, and lower limb spasticity. Okay, other causes can cause aqueduct obstruction at the aqueduct level is actually this aqueduct stenosis. The best to diagnose aqueduct stenosis is actually by doing MRI, T2 weighted image, looking at the mid-sagittal view, when we cannot find any other apparent cause such as tumors, lesions elsewhere. And when we look carefully into the equator, and there's just a very, very thin like membrane field with dilatation of the third ventricle and lateral ventricles with preservation of the fourth ventricle. And most likely, this patient is having aqueduct stenosis. Okay, pathological lesions in this region also include pineal region tumor, which has been discussed yesterday, and tectal plate glioma. Tectal plate glioma is a very slow growing, low-grade glioma in pediatric age group, where the tumor usually grew to obstruct the aqueduct series by expanding the tectal plate at the midbrain region, thus obstructing the CSF flow from the third ventricle to the fourth ventricle. Okay. Lastly, now we talk about hydrocephalus in fourth ventricular. Okay. Obstructions occurs at the fourth ventricular level is usually obstructive in nature also, and it is due to obstruction at the Lusca or McKenzie. Okay. Common causes are medulloblastoma, pilocytic astrocytoma, ependymoma. Okay. These are only among the cause fourth ventricular outlet obstruction. Okay. Having understood all the physiological CSF flow and then the CSF disruption at each level, now we look at what are the pathological effects to the brain when there's hydrocephalus. The hydrocephalus can cause atrophy to the white matter, can cause damage in the ventricles, and also abnormalities in the surrounding brain structures. So first of all, how atrophy of the white matter can happen? A primary destruction of axons, a secondary loss of myelin, and a chronic astrogliosis are found in hydrocephalus. Neurons seem to spread because of more luxury blood flow to the gray matter. So when there's more luxury blood flow to the gray matter, eventually the flow to the white matter will be reduced and causing atrophy of the white matter. Okay. Also, hydrocephalus can cause multiple anomalies within the ventricles. Fibrosis of the choroid plexus and stretching and denuding of the ependymal epithelium can along with diverculum within the ventricles. The septum pellucidum eventually can be fenestrated. This will cause multiple septated ventricles. Other anomalies can happen to the surrounding brain structures caused by hydrocephalus are spongy edema in the brain and causes thinning and elongation of the interhemispheric commissure. So therefore, the hallmark pathological features from the radiologic point of view will be thinning of the corpus callosum in chronic hydrocephalus. Okay. After knowing the pathological effects to the brain, not only to the white matter, to the ventricles, and to the brain structures, so now it is acceptable to discuss the CSF diversion procedure, because we want to reverse the damage to the ventricles, to the brain, and also to alleviate the symptoms of the patient. Okay, among all, EVD, VP shunt, and ETV are the common CSF diversion procedures. EVD is a temporary external ventricular drainage whereby we can insert the EVD not only for therapeutic and also for diagnostic purpose. In cases when we suspect there is an obstruction and patient came in with acute hydrocephalus, EVD can be easily performed, and not only by draining the CSF, but we can also measure the intracranial pressure, thus guiding the further treatment of the patient. Okay. In contrast to EVD, VP shunt will be a more effective way of CSF diversion. Okay. However, there is the difference will be we are putting hardware into the patient's body parts to help to drain the CSF. Okay. And lastly, with the newer technologies and advances, ETV has become one of the options as a CSF diversion treatment. Okay, ETV itself involves the endoscopic the fenestration to create a stoma at the floor of the third ventricle to divert the CSF at the lateral ventricles and third ventricle into the prepontine cisterns. All these are conventional methods of diverting the CSF. Okay. However, When we look back on the CSF flow disruption at each level, at the foramen of Monro, at the aqueduct of Sylvian, or maybe in the posterior fossa at the level of the fourth ventricle. So is there a best treatment option for treating the hydrocephalus in all these situations? Is it EVD, or is it better to put shunt, or is it better to do ETV? However, I would say there is no single best treatment for all. In situations whereby sometimes we might need to do EVD followed by a BP shunt in cases of infection, or in cases of emergency when there is a acute obstructive hydrocephalus caused by a large tumor. Okay, we may want to put an EVD and later on a shunt. Okay, in cases where there is a facility, there is a luxury to have the facility of having an endoscope, we may want to perform ETV in order to avoid the shunt hardware to be implanted in the patient's body. Okay, so, and if CSF diversion surgery is really indicated, is it better to do before or after the tumor surgery? Okay, control of hydrocephalus prior to tumor surgery actually allows the surgeons to avoid damaging the brain en route to the lesion during the tumor surgery. Surgery performed on the brain stressed by a marked hydrocephalus actually lead to poorer results. Resolution of the hydrocephalus and the subsequent decrease of intracranial pressure may lead to some recovery of the neural tissue. One of the neural tissues I mentioned here, for instance, the optic nerves. The optic nerves can be properly tolerate the surgery better in cases like there's a CSF flow disruption caused by cellular tumors. After CSF diversion, the tumor surgery often becomes an elective matter that allows the surgeons to have a more balanced and careful treatment planning about the tumor surgery. With all these benefits, actually most of the surgeons will go for doing a CSF diversion procedure before the tumor surgery. However, in some 80% of the patients with craniopharyngioma and 70% of those with optic papiglioma, the hydrocephalus may be cured after tumor surgery. And even if we are talking about the posterior fossa tumors, only one third to 1/4 of the patients with posterior fossa tumor will eventually need a VP shunt. So the disadvantages of putting a VP shunt is placement of the foreign body with its potential sequelae of the shunt failure, with an average risk of 40% to 60% in the first 5 years. Shunt dependency, the agony of multiple revisions is probably unnecessary in the major primary tumors of the cellular region or posterior fossa, since the number of patients requiring shunt is not that many. Similarly, endoscopic procedures, although rendered relatively safe, also carry about 1% to 2% of risk of significant complications and about 30% risk of failure at the long-term follow-up. In addition, shunting prior to tumor surgery may be associated with a higher risk of intratumoral bleeding. With all these mentioned the reasoning, some surgeons would think that if the patient is relatively stable, they would not want to do any CSF diversion procedures before the tumor surgery. In special circumstances, like cystic craniopharyngioma, okay, cystic craniopharyngiomas are often hard to control with irrigation, local aspiration, endoscopic fenestration, and injections of bleomycin. In such patients, shunting of dilated ventricles becomes more practical. Eventually, the cystic craniopharyngioma is a keep recurring pathology in the cellular region, which potentially block the foramen of Monro. Not only shunting might become practical, but sometimes septostomy is also needed in order to avoid putting 2 shunts in the patient. Okay, and now we move on to managing hydrocephalus in the when the patients had an obstruction in the level of the aqueduct of Sylvius. Okay, so if in congenital aqueduct stenosis or acquired aqueduct stenosis caused by infection, inflammation alone, okay, ETV and VP shunts are equivalent option treatment in this kind of situation. In pineal region tumors, ETV and biopsy is preferred, or VP shunt is more preferred if the radiological features more favor teratoma or other types of pathology other than germinoma. So in this special situation, when we are talking pineal region tumor, also in the presence of obstructive hydrocephalus, when the radiological features suggest more of a pathology of geminoma, usually ETV and biopsy will be the preferred option. Okay, however, if the radiological features favors teratoma or other pathologies in the pineal region tumor, maybe vision will be a more preferred method of CSF diversion. Largely, tectal plate glioma seem like aqueduct stenosis. Usually, ETV and vision has equivalent results. Okay. Lastly, management of hydrocephalus in posterior fossa tumors. That means when there's a CSF flow disruption at the level of the fourth ventricle. The management of hydrocephalus associated with posterior fossa tumors in children has always been problematic. Even yesterday, we have discussed about this and have active discussion. Okay, while the majority of patients will not require permanent CSF diversion, those patients who do so appear to suffer a stormier post-operative course and are subject to the well-recognized problems associated with these devices. Although in the past, it was often appropriate to shunt all these pathologies pre-operatively, technological advances and changes in the availability of neuroimaging have allowed earlier diagnosis. Consequently, most pediatric neurosurgeons
hi, Dr. I think in terms of time, we need to finish the presentation within, I think we can give you another 2 minutes to finish your presentations.
Yeah, no problem. Sorry about that. Okay, so consequently, most pediatric neurosurgeons today use a combination of corticosteroids, early surgery, and AVD drainage when necessary to treat hydrocephalus and posterior fossa tumors. This has been mentioned by Prof. Dhamendran yesterday in his presentation. In the literature, approximately 1/3 of the patients overall will eventually require a shunt. The factors associated with shunt placement have been retrospectively analyzed. Okay, these are the factors predicting shunt placement. Okay, patients with a posterior fossa tumor younger than 10 years old, who have a midline tumors in the posterior fossa, who have an incomplete tumor resection, CSF infection, or persistent pseudo-meningocele post-tumor surgery will eventually require a CSF diversion. And usually vision is still very appealing, given that the obstructive nature of the hydrocephalus in these tumors causing obstruction at the fourth ventricle. So the take-home messages are, okay, there are different etiologies that may cause CSF flow disruptions. Okay, CSF flow disruptions can be caused by tumors, can be caused by congenital lesions, can be caused by infection, trauma. Okay, so treat the underlying cause. Okay, in cases of infection, treat the underlying infection by putting an EVD and then later maybe followed by a shunt. Okay, in cases where the obstruction is due to the tumor, then treat the tumor and see whether patient still requires CSF diversion. Okay, in terms of managing obstructive hydrocephalus in the presence of tumors, there's always an issue in deciding whether to divert first or to plan for early surgery in order to avoid extra shunt placement procedure to prevent long-term shunt complications. Whichever decision-making is, there are pros and cons. Okay, so lastly, this is my last slide already. Okay, so the important determining factors in deciding whether the patient needs a CSF diversion or whether to do the CSF diversion before or after the tumor surgery, or whether which diversion is better, is more superior than the other option, is all depending on all these factors. Firstly, is patient factor. How well or how ill is the patient at presentation? When an ill patient presents to us with a large tumor, so I think we wouldn't want to take the chance to continue observe and then to get the MRI any delay of this will cause a coning of the patient. Eventually, the patient can succumb to death. Okay, and the next will be the size of configuration of the ventricular system and whether the compression is caused by tumor. Okay, so usually at in the acute emergency, a CT scan should have been done at presentation. So we look at the configuration of the ventricular system and look out for whether there's any compression elsewhere and is it caused by tumor. If really this is caused by tumor, then how large is the tumor and the extent and the degree of compression by the tumor. When we are dealing with a large tumor and there's also the extent and the degree of compression by the tumor is very, very severe, then we shouldn't take the risk. Maybe CSF diversion before the tumor surgery will be a better treatment option. Okay, in this situation also, it is debatable whether you want to put an EVD for temporizing effect or whether you want to shunt straight the patient. Each method has its pros and cons, as I've mentioned earlier. Okay, followed by environmental factors. How soon we can get the organize an urgent MRI or OT, and availability of the endoscope. If you have the availability to do the endoscope, you may want to do ETV or biopsy in the same setting in cases like binary region tumor. Okay, lastly, surgeon factors. Whether it's to prefer to do ETV or VP shunt, it depends on whether the surgeon is well trained and the surgeon's preference. How well one can handle or remove the tumor maximally and safely without no minimal morbidity or no morbidity also is another factor to decide whether you want to temporarily divert the CSF and eventually you want to refer this case to another center with a better facilities or with a more senior surgeon who can handle the tumors better. Okay, so among all these determining factors, I will put patient factor at first because eventually how well or how ill the patient present to us is the most important factor whether we want to treat the CSF diversion or not. So without further delay, I will end my presentation here. Thank you.
Thank you very much, Dr. Chia, for the very comprehensive talk. So just a reminder, the QA session will be discussed after we finish the whole 5 presentation. And as a reminder again, each speaker are given about 20 minutes to deliver their presentations. Thank you again, Dr. Chia. So I think now we shall move to the second lecture. It will be given by Prof. Zamzuri Idris. Prof is currently the head of Neuroscience Department, University of Science Malaysia. He used to be under prominent neurosurgeon like Prof. Jack Kamat during his fellowship training. He's actively involved in giving lectures either at local or international conference. And as for today, Prof. Zam will be given on CSF dynamic and its neurosurgical emergencies. With that, I would like to welcome Prof. Zam to continue with his thoughts.
Yeah, thank you, Mr. Chairman. Mr. Muhammad Azhari, can you see my slide now?
Yeah, we can see a slide, Prof.
Okay. So thanks to Mr. Azmi alias, thanks to the organizing committee for inviting me to give a lecture today morning. Dr. Chia has extensively covered the CSF flow and its pathology. So I'm going to skip some and probably just give some tips or important points here. So my lecture is about CSF dynamics and its neurosurgical emergencies. Okay, yeah, you have seen this. How to put this? Hold on. Okay, you can see here all the CSF flow, and probably you know about this Lushka Magandhi. And if you see in the real picture, this is a Lushka, right, left, and it's a Magandhi one. It's an endoscopic image. Patient with a cystic lesion, and then scope down to the fourth ventricle at the outlets. Very nice picture. And then go on, talking about absorption of the CSF. Yeah, talking about production and CSF absorption. So Chia Pupi already mentioned about this. And then interestingly about glymphatic system, probably going to emphasize more a bit on glymphatic system, brain lymphatic system. So this is a pathway for CSF absorption as well. It's also called the paravascular pathway. The paravascular, that means the CSF flow around or surrounding the blood vessel, the arteries, and then flow through the parenchyma, interstitial space, and then go into the venous sites and drain to the heart. So basically, it's like lymphatic from arteries to veins. And the words glymphatics, basically because of the glia, important role played by the glia cells. That's the key word here, the glia cell. This is a convective flow from arteries to the vein, carrying the CSF fluid waste product as well. Probably this glymphatic system play a role in perilesional edema and also in hydrocephalus. This picture here, just a picture showing a cartoon showing that the production of the CSF, and then there's a flow there, there's absorption here. This is a glymphatic system or parenchyma system for the CSF flow. So as I said, glymphatic the word glia is the astrocyte. Is the most important here. It's play bigger role compared to the others supportive cell, glia cell. So this astrocyte has hemostasis of ions and water. I will emphasize on this as well. It's going to be very interesting. It's like plasma physics. It's by third energy of the brain. Because of these aquaporin 4 and then the astrocyte. We're talking about the plasma energy. It's not talking about the plasma blood, but it's talking about the mole of the ions inside the parenchyma. So this the word plasma for physics also derived from the medical words of plasma. That means once you remove the corpuscle or the blood cell, then you have all these fluids. Same if you remove all these metabolites, then you have plasma like in the brain. So that's going to be interesting. Okay, before that, as mentioned beforehand, talking about the obstructive hydrocephalus. So you have anywhere along the pathway get blocked. Then normally what I did is remove the lesion if there's a lesion there, just like Dr. Chia said. If no lesion, then you do ETV or shunt, and try to remove re-establish the CSF. That's second objective. So try to remove all safe surgery. Total removal with safe surgery, and also second is to re-establish the CSF flow. Again, I agree with the previous speakers, yesterday's speakers, talking about a fast technique in removing a large tumor. That's my way of doing it. With huge big tumor deep inside, I go very fast. So I not play around with too much buzzing. But I take care of big vessel, and then I did it very fast. And then yeah, CSF diversion, as you all know, ETV. That's you know the site of the ETV. That's standard for you all should know by now. Sometimes you cannot do ETV because of big lesion covering the foramen of Monroe, but sometimes you can do something else. So you can re-establish the CSF flow to behind, like here, the supracerebellar system or quadrigeminal system, where sometimes you can see there's elevation here, a thin membrane at the splenium of the corpus callosum, between the splenium and the pineal region. So we did that in many patients, then we published that in GNS. And lately we had one case referred by the neurologist. Don't know what the lesion is. It's a multiple ring-like lesion. They're not sure what the lesion is, so we did biopsy. At the same time, we open up the quadrigeminal system from behind, and this done under IGS, image guided system, to locate the best burr hole to go there. Normally for this type of surgery, you need burr hole like 3-4 centimeters above the eyebrow, to the pineal region. That's the tip for the pineal region. For this patient, it turned out to be a fungal lesion. So the patient cured with the IV antifungal. And at the same time, we established CSF because of intracranial hypertension at that time. The thing further is about the ETV or biopsy. You all know about 1 centimeter anterior or to coronal suture, 2 centimeter away from the midline. And then for sometimes you need to do this septal pulsadotomy to make sure the communication happen between right and left ventricle, so about 4-5 centimeters away from the midline. As I said, this pineal region talking about 3-4 centimeters above from supraorbital reach, and then about away 3 cm away. Again, IGS is helpful. And then sometimes you fenestrate behind, sometimes you want to fenestrate, you can fenestrate from the front as well, because of the TV cannot be done because of blah, blah, blah. But another change is fenestration of lamina terminalis. That's another option, where you do it commonly in aneurysm surgery, but in some CSF obstruction, you can do that as well. But your angle and the scope slightly behind. So you have to take care of the motor and premotor cortex. Okay, just like this case example here, dangerous to the ETV. I thought it's because of very small and then very compact area here. So I abandoned the ETV because I saw it, lamina terminalis is easier. So I opened the lamina terminalis, and then you proceed with the surgery. Surgery go fast surgery. And then yeah, this is another interesting case with perimesencephalite syndrome, or diencephalite syndrome. This patient, pediatric case, presented with a perimesencephalite syndrome. With a thick arachnoid cyst. Normally, the thickened portion is the posterior part. And the one at the top sometimes can be very thick as well. So I use laser for this case to cut the thick one because it's all this important structure. Right and left is the hypothalamus. So laser is very helpful sometimes. So laser the thick membrane open up and then go down to this area here, basilar artery, and open up the downstairs one. This is another case of a cyst that obstruct the aqueduct, compress the septum. So endoscope again useful. You can see here endoscopic view, which is very nice. Habenula commissura, this is the splitting of the posterior commissura. This is a pineal region. Is a velum, interpositum. You can see here again, thalacroidal roof of third ventricle. You can scope up when you do burr hole at the front, about 3 cm above the supraorbital ridge. You can go through the foramen magnum and down there. And left habenular nucleus here, where you know is important for this limbic schizophrenia psychosis, which is very interesting about this psychiatric neurosurgery. Okay, then picture here, you see the interesting endoscopic anatomy. I show it here, the tuber here, and then you see the tuber of the third ventricle, and then the clivus, the basilar. Here you can see another view is a pituitary gland stalk. Pituitary gland, this is a pituitary gland, this is a stalk, another patient. This is an endoscope from behind where you can see all this venous system from behind, vein of Galen, and so on. It's a thick interthalamic adhesion connecting between the right and left thalamus, which is very interesting. This is endoscopic view for middle cranial fossa arachnoid cyst. So you can use endoscope for 30 degrees endoscope. Then you can see all this striate vessel. This is anterocoroidal above the PCOM below the anterocoroidal, and you can see the striate arteries. So that's why I think you have to take care when you do this aneurysm surgery, not to injure them. Very beautiful picture. Now shift to the next is the communicating hydrocephalus. Yes, people talking commonly about the arachnoid villi, impairment of the arachnoid villi. It commonly due to infection, hemorrhage, and so on. Uric fistula. This is a subarachnoid hemorrhage, and then later on, some of them develop hydrocephalus. Communicating hydrocephalus. Sometimes you have IVH with the subarachnoid, then you can remove it at the time a clip and then wash this subarachnoid hemorrhage. That's another way of reducing the chances of having communicating hydrocephalus after the aneurysm surgery. That's commonly done by us. Yeah, the dural AVF is a venous hypertension. It's a signs of venous hypertension. This is a venous ectasia. It's a venous hypertension. It's a break. It's a break because of the venous hypertension from the surface vein. And then as a training here, you all should know the brain topography and also the skull topography, the brain part and the skull part. So you should study this before coming to the exam, okay? Which is very important to know the Crocus point, Frazier point, King's point. If you don't know this coming to the exam, you for sure fail. Okay, this is another fundamental for trainees. You have to know this shunt, because communicating hydrocephalus normally deal with the shunt. You have to know type of shunt system. You have differential pressure valve, which is thick, and then the programmable one, and the flow control valve, the Cordis Orbis Sigma one. So why the flow is not been so attractive? Probably because of the flow, the cranial flow control is not. People not really know well compared to the pressure control inside the cranium. Yeah, talking about this management, talking about shunt and so on, your scary part is infection. So once you have infection, then it's a headache for all neurosurgeons, I think. You see all inside subtension like this, then you get pissed off. Another way of doing a shunt is a VA shunt or VS shunt. This is a VS shunt. Start with a VS shunt. To do VS shunt, you put it posterior 1/3 is opposite. Is a laminar flow, same flow with the venous flow. to make sure there's no thrombosis. And then the key thing is to open the dura knit a crochet like, and then once you put the catheter inside, make sure you put it under stretch so that it's elastically recoil, so it fits nicely to the dura, so there's no CSF leak around the catheter. So that's the key thing about this VA shunt. Make a small neck and then elastic, put a tube inside to make it elastic, and then put it inside, then it coil just nicely fixed to the dura. About the VA shunt, you doing all blah blah blah. The tip is here. When you connect to the tubing, then you can see the flow of the you can see the pulsation because of the cardiac phase. You have diastole and systole, so you can push in and out so that you know where you are. When you are inside the ventricle, you can see the pulsation is very high. When you pull it a bit, then it's dropped. When you pull out to the atrium, then it's very nearly flat. So you know where you are. No need for the II or fluoroscopy. Okay, now you know the obstructive and communicating type of hydrocephalus. Talking about these, people talking about the ETV for the young age, whether should do ETV or not before a certain age, like 6 months or 4 months. So again, the consideration is about this flow, this part, and also this glymphatic or the parenchyma CSF flow system. So in embryo, probably this one is not really well developed, and then this part not as well, or more developed. And then talking about aqueduct, obstructive hydrocephalus in young children. If you do ETV, if here is a problem, then you have failure for the ETV. Okay. And then if this I have no problem, then ETV should be okay. But what I'm trying to say here, sometimes you have problem here, but the ETV is working probably because of this. The lymphatic system, the glymphatic system was optimal doing their job. So because of that, I think you should try doing ETV even in young patients, because you try to avoid from putting the foreign body inside the patient's head. So that's my practice. If successful, then that's very good. Okay, shift back to the communicating hydrocephalus. Probably here is a problem, and also here is a problem. So two sides here, or suboptimal here, or here suboptimal. Okay, going back to the lymphatic system and aquaporin 4. So talking about this, is dealing with the hydrocephalus, as I said before, but also, as I said at the beginning, it's something to do with the ions and gases. So research shows that this area, this parenchyma space, or we call it parenchyma space, you have wet and dry extracellular space where you have these ions and so on. So this space is very important because the study shows it could be plasma happen here, molding of the ions and gases. So this comes the plasma physics for this area, which is I think going to be very interesting and new horizon for brain. So when you study here this supposed cell astrocyte, then you have the plasma-like features. Then you notice that the temperature of the brain is different. There's a gradient between hot and cold. This is the thing about the brain. So it's not just probably classical anatomy of the brain with the physiology of the brainwave, but maybe it's more energy to it. It's not just only conventional electromagnetic field, but probably plasma brain field or quantum field as well. So talking about this, the gradient, which is I think very important for CSF flow as well. If you have hot here, you have cold here, it promotes the proper CSF flow. And this confirmed in one of our awake patients where we have a very huge craniopharyngioma. We remove it, and then we have the sterile probe for temperature. Then we measure the temperature intraoperatively. Then it turned out to be the center, the craniopharyngioma, the brainstem, have higher temperature compared to the cortical subcortical region. So this is going to be very interesting about the brain thermodynamic. And to add on it, temperature control is not just on the to do with the blood and so on, but base of the skull also. remember the base of the skull, as Chia Pupui say about the flow of CSF at the base of the skull. And then this is very important. And in trauma patient, this area might be hampered or hindered because of the intubation. Summary so far, you can see severe heat injury, you can see the accumulated heat because of the distortion, impairment of this flow. And then you have no gradient in heat. So you have hot and hot. And because of that, CSF not flowing well. So you might, so that's why probably some patients have hydrocephalus, some patients don't have. So impaired, there's no gradient between two. And talking about this gradient in severe heat injury, you need to open and then cooling the brain, just like what we did. And then the study shows cooling the brain is good for the patient with severe heat injury. And then the study going to proceed further with a cystinostomy versus direct cooling of the brain. And then about the CSF production, about the due to this plexus, you can give a laser on it. And then my second part, talking about CSF flow and then this ICP, I'm gonna give a tips on this Monroe Kelly, you know about the compensatory phase and decompensatory phase. Whereas the acute one, you have a very fast increase in ICP, chronic is a slow increase in ICP. But the key point here is this one, this graph here. You have compensatory phase here. You have compensatory to decompensatory phase, and here the exhausted compensatory or total decompensatory phase, where you see the pulsation is nearly flat, and where the P2 higher than P1, and then wave become flat and flat. And then here the pulsatile index is going to be is much higher compared to the compensatory phase. So this pressure volume curve is very important to understand about the brainwave and also the compensatory and then decompensatory phase. So this graph also shows the compliance here, low compliance at this region and high compliance at this region. And then you have low elastin here and low elastin there. So this elastin and compliance is very important for our understanding about the normal pressure hydrocephalus and pseudotumor cerebri. Because in this condition, what happened is normally small pseudotumor cerebri happen in middle age, where the elasticity and compliance at the best, compared to the elderly with NPH, the brain parenchyma compliance is not good as the early age newborn. Yeah, so elastin and compliance, I think, very important to understand it. Then some people measure the compliance and ICP. If less than 0.7, something wrong happened. The cutoff value normally 0.7 to 0.8, and then this can be measured with catheters, and also you can measure the pulsatile index or Gosling PI pulsatile index using the transcranial Doppler. So because of that flow in ICP, then you should know about the normal values for the ICP. This is the data from the literature, say the cutoff value for this and this. For the adult, normally is 20-24. For pediatrics, up to 7. For the up to the infant children, 7 to 15, and so on. But the key point here I want to mention about the ICP for the pediatric head injury. The pressure volume curve is shifted to the left, and it is very steep. That's a key word here. The break point occurs earlier. The break point occurs earlier, and sharp increase in the ICP, and the compliance is impaired in young patients. And because of that, you must be careful. You must beware that you must watch out for this condition, brain swelling and sudden deterioration in pediatric case. The second point, CT evidence of ICP, state of perimesenchymal system in children can be normal. So you cannot exclude raised ICP with a normal PMC or perimesenchymal system. And the third point, you must note that the large head to body ratio. So the positioning of the head to the trunk, you must make sure the body is not high up. Then otherwise there's a net flexion, which further obstruct the venous flow. Okay. Again, at higher risk, the fourth point for subdural hematoma compared to extradural in young patient because of the enlarged extraaxial space, and because of the head is heavier. Okay. So the third part or the fourth part is talking about CSF and microgravity. I think this is more research need to be done on this, because CSF is not just only protection. I think it's provide gravity, and if it provide microgravity, just like when you're pregnant, the amniotic fluid provide the microgravity environments. Always brain need microgravity. So what happens when you open up the skull? Then you have this sinking circumflex syndrome. And patient becomes symptomatic, and the pressure difference, you see the ambulatory pressure very high, and the pressure inside is about 10 to 15. But remember, this is not absolute pressure. The absolute pressure is compared with the vacuum. So the absolute pressure for ICP is 1006 kilopascal, and the atmospheric pressure is a 107, so slight differences there. So when you mention about this, is 15, 14 is the gauge pressure between this point and this point, between this when you zero it, so between 0 point and your cranial point, but it's not the vacuum one. Remember that point.
Prof, can you please summarize your presentation? Sorry.
Okay, so this is the last one. So the last point today is about the ICP and CSF. ICP and hydrocephalus brainwave. So when you have raised ICP, then you have effect on the EEG and brainwave. So from my initial series, they have more delta and theta activities, and I think you can do more on this. You can look at the power of the brainwaves as well, which is going to be very interesting. I think that's all from me. Thank you very much.
Thank you, Prof. Zamzuri, for your interesting and very informative talk. For the interest of time, let us proceed with the next presentation by Dr. Fazli Shah Johan Abbas. He is a consultant neurosurgeon from Hospital Kuala Lumpur with special interest in pediatric. So let us welcome Dr. Fazli Shah Johan Abbas. The floor is yours.
Please unmute, Pas.
All right. Assalamualaikum and good morning, everyone. As a disclaimer, our system, we use MENOP endoscope because that's what we have in both the children and adult hospital. But as a disclaimer, we are not affiliated with any brand or companies. All right. So I'm breaking my talk in two parts. One is for pyogenic ventricle, and the other one is for IVH. Concentrating on pediatric age group because that's what I mostly do. All right. For pyogenic ventriculitis, it carries a high mortality and morbidity rate, and it commonly occurs as a complication rather than a primary problem. In a primary pyogenic ventriculitis, it's more common in children. Usually it's gram-negative organisms in 60%, followed by Staphylococcus species. For your information, Staphylococcus species is not that common in adult age group. In the adult age group, is usually Neisseria or Pseudomonas or even Candidas albicans. All right. Ventriculitis complicating meningitis usually present in neonates rather than bigger age group. EVD infection rate has been described up to about 22% of patients in a local study done by Mr. Azari. It was quite high. The EVD infection rate is about 32.2%. Another local study by Ms. Sharon Casilda for VP shunt infection is about 14.4%. So it's a bit on the high side. All right. So I've presented an oral study at ISPN in Birmingham in 2019, but I expanded this a bit. So we took about 13 pediatric patients with pyogenic ventriculitis who underwent endoscopic lavage between 2016 and 2020. Right, but in comparison, we also took 6 previously treated patients who had only EVD and antibiotics for comparison. Okay, so this case series, this one is where we did the endoscopic lavage, and this one is without the washout. So age is about 13 months average. Age is about the same. Sex is about the same. Etiology,
9 from meningitis, 4 from infected VP shunt, and Acinetobacter baumannii, no growth is because the patient, they usually have commenced antibiotics, so we don't really get anything from the washout, right? Okay, so methods, they all underwent endoscopic lavage as secondary surgery because the first surgery was EVD. Then we used a 0-degree escallop endoscope with a 6 French suction catheter and a grasper. They all had bilateral frontal burr hole made, and each site was cleared individually. We used the Hodges point for this. We also used body temperature Hartmann solution, on average around 10 to 20 bottles. And then we insert an EVD at the end of the surgery. CSF samples were taken pre and post lavage for comparison. And subsequently twice a week until cleared pre-subsequent samples before deciding whether a permanent CSF diversion is needed. This one we see the amount of CSF that comes out as well as the protein count. Right, and all of them complete a 6-week course of antibiotics. Right, so this is us. These are the equipments that we use. And just for reference purpose, you can see the scope channel is about 2.8 millimeter, but most important thing is the working channel, 2.2 millimeter. All right, these are all the standard equipment that we use, but for suctioning, we use the suction catheter, usually used by the GA. We don't use the Rouse tube because Rouse tube, they do not have that hole for the suction. And it can be detrimental if you just continuously suck the CSF. So you have this opening here that you can control whether you want to suck or not, and you cut off the 2 holes in front here. The length is about 50 centimeter. The scope is about 15, so you have good length actually. All right. So this is a sample of bioventricle that we deal with, and this is a video, 1-minute video. As you can see, when we go in, we don't see anything at all. So we have to go slow. We have to be very, very patient. And the thing is, we don't usually, especially in cases like this, severe cases, we don't usually get to clean the entire ventricle at one go. So it's also important to know when to stop. Right, so we use the suction machine, we use the grasper. Right, so until we can actually see some of the normal ventricular wall. So at least we know we're getting somewhere. This is sped up 4 times, so you can see it's a bit cartoonish. All right, so as a result, number of surgeries were markedly less, about on average 3 surgeries compared to 6 or more surgeries. They do not require intratical antibiotics. They do not have subsequent positive culture after the procedure compared to the ones without endoscopic lavage. There were no worsening or knee infection. Outcome, 9 of them required shunt, 4 of them were shunt-free. Whereas in the ones without endoscopic lavage, all of them required shunt, 1 resulted in death. Hospital stay was also shorter. This is because of 6 weeks antibiotics course. And 1 year follow-up, about 6 of them had normal developmental milestones, 4 had mild delay, 1 had poor developmental milestone, and 2 required shunt revision. If you recall from Prof. Zamzuri's and Ms. Pui's talks just now, in infection, usually the arynoid granulations are also blocked. So the CSF flow is already affected. They usually require shunt or any permanent CSF diversion. So endoscopic lavage in poor ventriculitis yields better clinical results compared to just EVD and antibiotics alone. And early aggressive intervention can help reduce morbidity and mortality in these patients. Right, moving on to IVH. In premature babies, the germinal matrix IVH is the commonest and distinctive pathology because of vascular immaturity and complex hemodynamics factors. They have impaired cerebral flow autoregulation, and also they are prone to venous congestion stasis, And the incidence of IVH in term newborns is low compared to preterm newborns. You can see there 4.6% compared to 50%. Most likely due to the maturity of the brain at term. In term newborns, IVH commonly originates from the choroid plexus or as an extension of thalamic hemorrhage or subependymal germinal matrix bleed. So what's the germinal matrix that I've been talking about? It's a highly cellular and vascular brain region from which cells migrate out during brain development. It's the source of neurons and glial cells, most active between 8 to 28 weeks of gestation, right? And what's important is it completely regresses and converts into normal brain parenchyma by the 36th week of gestation. So before that, it's still active and there's a chance of bleeding it when the patient is premature. Right, the capillary network is of high caliber and thin wall, no muscularis layer and immature vessels, so they tend to bleed. So this is where we can find the germinal matrix, right? Medial to the caudate nucleus. This is when it can bleed, right? So the presentation, GM-IVH in premature infants is typically diagnosed during the first week of life. 50% on the first day, 90% within the first 4 days. In severely premature babies, 33 weeks or less, the neonatologists make it mandatory to do an ultrasound cranium because they tend to have IVH. But depending on how severe the IVH is, most of the time they do not require any intervention from us. Right, usually it's subependymal and asymptomatic. In symptomatic cases, there's a large bleed and the complications may come with altered consciousness, cardiorespiratory deterioration, unexplained drop in HB or hemolytic rate, acidosis, SIADH, severe apnea, seizures, right? Tense fontanelle, abnormal eye movement. You can have all these abnormal presentations. GM hemorrhage in newborns have a later onset, 4 to 10 days postpartum. For neonatal seizures, decreased consciousness and raised intracranial pressures are usually the most common presentations if these patients have ICH as well. Right, so imaging, ultrasound has been really, really important and really helpful in diagnosing GM-IVH. You can do it bedside, neonatologists are trained for it. And if there's any doubt, we can actually ask for a formal one, right? CT scan has been used before, but we try to avoid it because it causes radiation complications later on in life, right? MRI is superior to detect white matter abnormalities and for identifying small hemorrhages or posterior fossa hemorrhage. To treat or not, it doesn't really help, but we do use MRI to find out whether there's any brain abnormalities. All right. So we have a few grading system for IVH. This one of them is for specifically for the germinal matrix IVH. Grade 1 is germinal matrix bleed. Grade 2 IVH without hydrocephalus. Grade 3 IVH with hydrocephalus. Grade 4 you have periventricular hemorrhagic infarction. Usually grade 1 and 2 are quite mild. They do not show any late sequelae. Grades 3 and 4, they have high incidence of neurologic sequelae, such as cerebral palsy or mental retardation. This is an example of ultrasound with IVH. You can see the hypoechoic region, the whiter ones. These are the IVH regions. All right, another 1-minute video. Usually when we do IVH, it gets really frustrating because we cannot see anything. So we put in the scope, we just let the Hartmann run and until it clears up. Once it clears up, then we can see everything. So if you can see here, it's very subtle. There's a difference. You can see that flow of water there because the CSF inside is very, very viscous. It's very proteinaceous. So when the Hartmann goes in, you can actually see it. And if you can see this patient, you can see the foramen Monro. There's absence of septum pellucidum. These are all the hemosiderin deposits. Usually in IVH in the neonatal age or in the premature age group, the anatomy is a bit different from the normal one. So sometimes when it gets really, really different, you can actually get lost. So it can be dangerous. So do not go in deep. Just give it time. All right, so these are other examples. This one is in a mature term baby IVH. You can see there, these are all old blood clots, right? Okay, so we also did key series on this. Between 2019 and 2021, we managed 9 premature babies with IVH grades 2 to 4. All right, so age group is about 34.4 weeks in average. The weight is about 2 kilograms, so you can see they are very small, right? Sex 5 females, 4 males. You can have actually 3 grade 2, 4 grade 3, and 2 grade 4. Initial treatment for them, we did AF tapping for 7. We inserted EVD on 2 patients because of the severe hydrocephalus. Then subsequently, we did 5 serial AF tapping at the clinic. Those who can come to our clinic. For those who are at other states, difficulty coming, we put in Omaya so that the pediatricians at their own hospital can do it. And 2 of them had EVD with 2 weekly change. Endoscopic treatment, 6 of them required out of the 9. 3 did not require definitive intervention, so they didn't have to do anything. Out of the 6 patients, 3 of them were shunt-free later on. 3 of them required VP shunt, 2 of them were shunt-free, and 1 required VA shunt because of congenital abdominal complications, not because of VP shunt complication. We didn't even put in a VP shunt for this patient. All right, complication, 1 of them who from the serial tapping had Enterobacter species. We didn't know this because the patient was very asymptomatic, but the CSF sample that we sent after the lavage came back as Enterobacter species. Subsequent EVD change while completing 6 weeks of antibiotics, and eventually the child required VP shunt. All right, this was a presentation that I did in Birmingham as well. This was endoscopic washout for term babies. All right, it's very rare, like I mentioned just now. We had 2 of them in this series. All right, thank you so much.
Thank you, Fas, for the very wonderful presentations. So I think we now shall proceed to the next speaker. It will be given by Prof. Azizi Abu Bakar. Prof. Azizi is our senior consultant neurosurgeon at HUKM. He has a very deep interest in pediatric neurosurgery. And for today, he will talk about when is spinal bifida an emergency. So let's focus and get the answer from our dear Prof. So with that, Prof, the floor is yours.
Thank you for kind introduction. Boleh dengar?
Boleh, Prof.
Yeah.
Very clear.
Can see my slide?
Yeah, you can see your slide.
Silap. Sekejap. Terbalik. Tak apa, you can see all the slides first. So that roughly, I will talk about just a list of emergency spinal bifida, or the title given to me is when is spinal bifida is an emergency. So definition of emergency means needs early intervention, either treatment, surgery, or any kind of medical intervention. For which delay in intervention will lead to significant morbidity and mortality, either via infection, via neurological damage, or some other mechanism. So for spinal bifida, there are few risks associated with surgery and anesthesia. So for anesthesia, it's mainly breathing problem. The patient have a bad KRE2 reaction to medicine, among them bleeding, especially in newborn babies, where they are, especially when the birth weight is less than 3 kilograms, and we know the blood volume is 80 cc per kilogram. So if patient 3 kilogram, they have 250 cc, which is roughly 1 cup of blood. So any tablespoon or 2 tablespoons of blood loss can cause hypertension. And also risk of infection and latex allergy, which is not common in Malaysian population. For surgeries, after we repair the spinal bifida, they can develop hydrocephalus, increased chance of urinary tract and bowel problem, neurogenic bladder, infection or inflammation, spinal cord immediately, the closure, and all sort of neurological damage. And the first, the one that I listed as the first emergency in spinal bifida is immediately after antenatal diagnosis. Usually the parents will be devastated. So usually they are in urgent needs of psychological intervention in the form of access to early consultation. So they need a lot of information. They need access to contact groups, and if the diagnosis is made early in pregnancy, so they want an option of termination of pregnancy probably. So in our practice is quite customary. If we have referral from maternal-fetal medicine about the newly diagnosed spinal bifida, usually we just give our consultants contact number to the expecting parents. And number two is a spinal bifida itself at birth. So this is for like this. You see, this exposed plaque. So this is a lot of arachnoid, and which is very thin and can rupture at any time. So for this kind of baby, usually most are diagnosed antenatally, so we can pre-plan the delivery and instill the repair immediately after the delivery within 24 to 48 hours. But some quite recently we received a few patients delivered somewhere else in private hospital with no antenatal diagnosis. So so in this operative preparation, basically we need to counsel the parents. We need to refer to neonatologists to rule out any organ malformations, and also we have to assess them for fitness for surgery. We have to do ultrasound, MRI, ultrasound of the heart. So there's a lot of things to be done within this short period of duration. So after 48 hours, so if we don't repair, so the risk of complication is quite high. So what we want to really to do is to prevent the rupture of the sac, CSF leak, infection, desiccation, and further trauma to the plaque. So number three, that we can consider emergency in spinal bifida is post myelomeningocele repair hydrocephalus. So usually we detect by doing the occipital circumference daily after we repair. And also we do imaging to have a rough idea of the internal architecture of the of the ventricles. So in case if the head increasing in size and we need to do a shunt diversion, we can do it satisfactorily. And also after we repair, there is a risk of infection. So we need to assess the risk of infection before we do shunting. If we think that the CSF is not clean, or there's a lot of cells, a lot of blood inside, so we might have to do an external CSF diversion first until it's clear. And the other one is post myelomeningocele repair complications that we can consider as an emergency. For example, post repair CSF leak, wound breakdown or skin ischemia around the wound, large myelomeningocele that actually is much bigger than the volume of the ventricle system. So we got a low ICP symptoms, and also wound infections and other things like shunt malfunction and shunt infections. So all this we can't really sit on them. We need to take action fairly soon. And the other thing, this is not real emergency. This is a relative emergency when patient coming with almost no symptom usually, but we do a radiological investigation. We do MRI, and we see on this side, you see on the CSF thickness on the in front and the back is almost the same at all levels. So this we can safely say, even though there's a tethered cord, there's not much of a tethering. But in the image on the right side, so there's a cord touching the anterior part. It means this one in Formula One, we say the cord is actually catching the apex of the curve. So this is a sign of cord deteriorating. So if we don't do anything for this within 4 to 6 months, most likely we will see some neurological deficit. For example, the bladder become more neurogenic, the lower limb become more stiffer, the tone is increasing. So there are two schools of thought about this. So one is we wait for clinical deterioration to occur before we release the cord. But in our current practices, we prefer to deteriorate the cord early before the clinical deterioration happen, because our reason is once the deterioration occur, if you release the cord, they will improve, but improvement most likely will not be 100% compared to if it released earlier. And next one is a clinical pterygoid syndrome. This is a clear-cut, to me, it's a clear-cut emergency. So we should treat this like acute spinal cord compression. We should release as soon as possible, not within a golden hour or 6 hours. These are the symptoms of pterygoid syndrome that they usually present. So we should do early MRI and release the cord as soon as possible. And these are the causes of pterygoid syndrome. And this is quite straightforward. The bigger issue now in most spinal cord pterygoid syndrome in this region is mostly undiagnosed. So mostly it will be passed as a normal history of a spinal bifida patient, so that they will lose their lower limb function, the bladder function, sphincter function, and instead of being prevented to deteriorate, so they will just do a rehab for increasing disability. And then the other thing is the reported incidence of pterygoid syndrome in spinal bifida is 20 to 50%. So this is a US figure. So, but I doubt the number is correct, because even with the best closure of spinal bifida aperta, usually the lower end of the cord is quite bulbous, and sooner or later, so they will develop pterygoid syndrome. So from my experience, almost all patients, more than 95% of patients actually develop pterygoid syndrome if we leave it alone. So it's important for us to follow them up until they stop growing, at least to detect this complication. And the other one is exposed gibbous in spinal bifida. So the gibbous in spinal bifida is typically occur lower than the developmental adolescent scoliosis or kyphoscoliosis. So they occur in lumbar region or lumbosacral region, and we have these 3 patients presented with a skin breakdown, where one of them become infected, so we need to clean up, do refer to plastic for dressing until it's regulating, and we have to excise the gibbous and put the rod in, and they, even though this procedure will not increase the chance of neurological recovery, but at least you will prevent further ascending infection from the exposed gibbous. And the other thing is symptomatic HRE2, and then this group patients, spinal bifida with HRE2, usually they become symptomatic much earlier than the HRE1 type. Usually in early childhood, 4 or 5 years old, they become symptomatic. So, and it can be life-threatening. Sometimes they present with respiratory problem. So, and the treatment is by foramen magnum decompression, with or without fixation. And the other one is infected dermal sinus tract. So in my career, I confronted with 2 of such cases. One patient actually died because incomplete surgery. So what happened was when the surgery was performed, so the tract was cut at the just outside the dura. So what happened is at the time, this one is already infected. So the intradural component of infection was not removed. So patient was discharged, and then she presented few weeks later with respiratory arrest, and it was treated, we opened everything, but she succumbed to the surgery. In that case, actually, the family sued the hospital, and actually we have no defense against the litigation, and we have to pay the compensation. So what the right thing to do is to excise everything, do a proper laminectomy, expose, open the dura until we can see the normal part, non-inflamed spinal cord, and then we repair, and then do a plication of spinal cord to reduce the raw surface area. If needed, close the dura properly. If there's a big dural defect, don't use the artificial dura. Use the fascia to close, and better put a drain in and out. And this is another common emergency in spinal bifida, where there's acute paralysis in spinal bifida of any cause. We have to investigate early. We can't discharge them. We have to admit them straight away, investigate for the cause, and instill the treatment early. And then this is high syngomyelia. So in this picture, this is not that very high. The high syngomyelia, what happens is it can interfere the function of the medulla, where the center of life. So they can interfere with the cardiorespiratory function, and so in children it's quite difficult to do a shringo peritoneal shunt or shringo etc. shunt. Anyway, in adults, for this syngomyelia, the best treatment still is ventricular shunting from the ventricles. And the next one is bed sore. So the bed sore alone it doesn't need immediate treatment, but the issue that may arise from the bed sore is actually it can undermine, the wound can undermine, and there's a lot of slough inside. It can get infected, so we can become ascending infection through the defect. So because of that, all these bed sores need to be attended early. So in our practice, what we do usually, we just refer to our plastic surgeons who are very interested in caring of this age-sensitive skin lower than the lesion. So normally we try few weeks of silicone cushion, and some sun dressing. If it fails to heal by 1 month, usually we do operative closure. And the other thing is, this is quite common among the spinal bifida admissions to hospital. Almost 30% of them are due to urinary tract infection, and usually this urinary tract infection is caused by other bad neurologic bladder, which reflects the underlying Taylor syndrome, which is untreated, or a patient needs to do a proper catheterization to be taught again to them. And the other thing is a major psychological crisis in spinal bifida. We don't see quite common. Because this one is there's a lot of interplay between the biological pathology, necrosurgical, and social adjustment. So what happened is because they suffer from this condition daily compared to us, a health provider, we only see them probably once a week. So and they are quite young, and then they probably have parents with a strainful relationship because of the need of frequent medical attention. So some patients presented with depressive symptoms, and they can actually can become suicidal. So but it is a well-known aims for psychological issue in spinal cord patient at any stage of their life, even from 0 to 1 years old to 1 to 3 years old and adolescents. So we can achieve a certain target. And if they deviate a lot from this aim, so we should do intervention, refer to the proper units to prevent further escalation. And this is my last slide. So this is quite a big challenge for us actually, to because most of these patients, the defect is quite low. So originally they have a normal brain. So, and our challenge is to maintain this brain function as much as possible. So they have the right to live like normal people. And the challenge to us, a healthcare provider, is to provide ourselves with proper knowledge, be aware of their issues, and put it into our practice. So, and we detect the issue as early as possible, and and take action early. And so this is I find it's quite difficult in Malaysian context to make our service accessible. So most of the patient, especially spinal cord patient, if they have a problem, acute problem at home, so it's quite difficult for them to access the healthcare provider, especially middle of the night, over the weekend. They don't have emergency numbers that they can call for immediate attention. So with that, thank you.
Thank you very much, Prof. Azizi. There's one question, but we'll keep it until the Q&A session later. So next will be Dr. Rohazli binti Ismail, a senior consultant pediatric radiologist currently based in Hospital Tunku Azizah, Kuala Lumpur. She's a medical graduate from University of Manchester before pursuing her radiology specialty in National University of Malaysia and subsequently her fellowship in Hospital Kuala Lumpur and the Royal Children's Hospital in Melbourne, Australia. Please welcome Dr. Rohazli with a talk on radiological findings on brain trauma. Dr. Rohazli, please.
Please unmute yourself, Rohazli.
So you can go to the slide presentations, Dr. Rohazli.
Okay, is that better?
Okay.
Boleh dengar?
Okay.
Okay. I don't know, for some reason the unmute button does not appear. For some reason. Okay. So thank you. Assalamualaikum and good morning. Thank you to the organizing committee for inviting me to give this talk. I'm very honored to be, with all of you on this Sunday morning. So we know that there are a few emerging modalities, but the one that we mostly use and almost all the time use is actually CT scan. Very limited use of ultrasound. We try not to use it because we know that the sensitivity is very low, but maybe when the child is very unstable to move, and it has, of course, to be an infant. And scar radiograph, we try not to advocate that because that's another radiation for the child. So it should be whether CT or not. and MRI is reserved only where the persistent neurological symptoms which is unexplained by the CT findings. Okay, so I just show these MRI images and not going to sort of show any more MRI images after this. So from the CT, you can see this small petechiae of hemorrhage, and which is seen better on this to flare, hyperintense signal, which is showing blooming artifacts and this GRE sequence and restricted diffusion. So you can sort of see the abnormality better in the MRI. And like I say, it's reserved only for those cases that the symptoms actually does not explained by the CT. And if you go by this NICE guideline established in 2014, and all these sort of clinical features that that need to be present before the child is done for the CT brain, you don't see any of here that's actually says skull X-ray. Yeah, it's either to do a CT or when to do not to do a CT. So we know that it's fast and easily obtained, sensitive in the detection of intraparenchymal and extraparenchymal hematomas, mass effect, and fracture. You can scan the rest of the abdomen, chest, and spine if needed. But of course, in children, and it's my special duty as pediatric radiologist to just make everybody aware that of the risk of radiation in this very vulnerable group of patients because of their developing and maturing tissues and cumulative radiation risk, because they live longer, therefore they have enough time to express the radiation sort of results that ensues from the risk. So the risk of radiation have to be weighed against the need to identify clinically significant and treatable head injuries. So we should not use CT just to have a look or because we can, because it's clinically indicated and it will actually intervene in the child's further management. So because we know most of the head injuries are mild, in fact, in one studies in the Australia and New Zealand, of the 20,000 patients who presented to ED, they found that over 18,000 is actually under the category of the mild head injury. So these are the ones that actually give the most of dilemma to the clinician, whether to CTs or not to CTs, because we do not want to miss although the injury is mild, but they can have a clinically significant intracranial injuries, and we don't want to miss those. So that's why the clinical decision rules comes to play, and it have been developed to identify children at high risk, and also aiming to assist clinician to minimize the CT scan, but still identifying all the relevant injuries. So 3 clinical decision rules with high methodological quality have been established. And they are PCAN. I know our ED doctors use this. The Catch-2 rules by the Canadians and the Chalice UK. So this is the study that I mentioned earlier, conducted in the, I think 10 hospitals in the Australia and New Zealand, applying all these different decision rules. And they look at the results and comparing it with the clinician practice. So their clinician accuracies are very high, and that's PCAN, of course, giving you the highest sensitivity and also the highest negative predictive values, but the rest is also quite good for Catch and Chalice. So definitely clinician accuracy plays the most important role. And for us in our department, we feel that because this is not really comparing of direct comparison, because PCAN is actually looking at who not to CT, and Catch and Chalice more to who to CT. So for us, we choose Catch, so it's easier to decide when there is a request. So does it actually fulfill this criteria? Rather than actually having to think too much or too hard about it. And in 2010, Catch actually was published, and they have these 7 features that suggest association with significantly intracranial injuries. And then they sort of modify it in 2018, and they add 1 more, which is vomiting of 4 episodes or more. So that actually increased the specificity of the the sensitivity of the study. So in CATCH, 4,000 over children were enrolled, and they CT 34, almost 35% of these children. And then the ones that they didn't CT, they just follow up by phone. And then these are the findings of the CTs, which I think is true for almost all anywhere else. The extradural hematoma, subdural, cerebral contusion, hemocephalus. So I'm sure all of you here attending this conference today are very familiar with CT brain. I'm just showing you a normal CT brain of a child. Of course, for trauma, we would do a plain CT. This is what the plain CT looks like. We always make sure that our KV for children does not go, that's the dose for CT scan does not go above 100 kV, and it's already showing quite good resolution here. And then all the rest of the other images I show here are all post-processing images, so they did not actually cause any extra radiation to the child. So 3D VRT is almost always a must for our radiographer to reconstruct because in children, all the sutures and can be quite confusing and to differentiate with the fractures. So this actually, the 3D VRT, the volume rendering technique actually helps a lot. And of course, the coronal and sagittal views and planes and also the bone setting. And always remember to look at the mastoid air cells to make sure there's no fluid there, which may suggest base of skull fracture. So extradural bleed, I'm sure all of you are very familiar with it, is subdural bleed and contusion and intraparenchymal bleed. Contusion means there's bone bruise, which if it's more expanded, then it becomes the intraparenchymal bleed. So extradural hematoma, I just mentioned these two types of hematoma because they are the difference in children compared to adults. They are uncommon in infants and increase slowly in incidence throughout the childhood. Different pathogenesis and clinical manifestation than adults because commonly they are results of tears of the dural veins rather than the middle meningeal arteries that usually occurs in adults. And the presentation does not evolve as rapidly as it does in adults because the skull is more pliable, and the intradural injury that comes with it is usually uncommon in children. And of course, there is usually a skull fracture and soft tissue swelling are often present. Then you can see here on the CT, this is the lentiform hyperdensity at the left frontal lobe, and then the associated skull fracture adjacent to it. Most common in infants and elderly, less common in older children and adolescents, and it's due to the tears of the cortical veins, the subdural hematoma, and the bridge in the bridging subdural space. And usually in infants, they're bilateral in most cases, up to 85%, and located in the frontal parietal convexity, as opposed to adults, where it's usually unilateral. But of course, with subdural hematoma, always be careful that when you have history of mild trauma that's not consistent with the severity of the injury, then you always have to suggest the possibility or be aware of the possibility of child abuse or non-accidental injury, especially in the presence of other features like retinal hemorrhage and fractures. So this is something that we have to think about as well for subdural bleed in infant especially. Okay, so I think we'll have a look at a few cases that we actually see in our hospital. So this is 4 months old, a lurch fall with mother. So mother was carrying the child and she tripped over and fell. Child was otherwise well, but they noted heart swelling over the hospital region, and the ultrasound bedside by our ED doctors showed a comminuted skull fracture over the hospital room. Actually, with all due respect to our ED doctors, I'm sure they're very good with the ultrasound, but actually the ultrasound findings does not actually decide for us to do the CT or not. This child had heart swelling over hospital region, and yes, it's over a meter high. It's in the CT brain is indicated. So this is the CT of the child and showing there's no intracranial bleed. Yeah, I'm sure you can see from these two slices that I share here. Normal appearance of the CT brain in this age group, where you can see that prominent extra-axial spaces are quite prominent. Ventricles are also quite prominent, but it's still considered normal for this age group. So this is a bone setting showing there's a sort of this fine fracture line here. Okay, not too obvious on this axial slice, but if you do the 3D BRT, then you can see it's very obvious, a transverse fracture of the bone from the suture to suture at the hospital bone there. So this is why we really like the 3D BRT, so we can see the fracture so much better. So I'm just sharing you the normal CT brain of a 2-year-old. You can see that comparing to the 4 months old just now, that the extra-axial spaces are less pronounced as the brain is growing more than the skull, and it can appear, you know, to those untrained eyes like a light brain, but it's actually quite a normal CT brain for this age. Okay, second case is a 2-year-old girl, alleged fall from height from 13th floor to the 6th floor. Yeah, found on the balcony of the 6th floor. So GCS was 10. Okay, so this is no issue. Definitely, she needs CT brain. So you can see that there's the intraparenchymal bleed here in the right temporal region, and a large scalp hematoma there, and you can see the extradural bleed in the left posterior parietal. And as usual, usually there is an associated fracture with the extradural bleed. You can see that the fracture is shown here as well in the sagittal reconstructed image. And on the 3D VRT, you can see the fracture too. So another child, alleged for at 12:45 at home, and then sustained left eyelid laceration secondary to eyelid puncture by the tip of pen. So there's a penetrating injury to the eye. The child was holding a pen and then fell onto the door handle or something. And then after that have unsteady gait. So CT brain was also done, I think because of the unsteady gait. It's normal. And you can see that this is the already posterior to the globe. You can see the lateral or extraocular muscles showing a very swollen left lateral rectus compared to the right side here. A lot of streakiness there, and there's an air pocket within, and now the child's eye is sort of fixed, adducted. So they're asking us whether there's a trapped muscle, which we really can't see that. But definitely the lateral rectus is very swollen. Okay, this unfortunate boy was standing at the back of the lorry, so actually on the lorry itself, and then fell to the ground for whatever reason, hit the back of the head, having GCS 14 when he arrived, hemotympanium right-sided. So yeah, CT is indicated for this child. And you can see that there is a small pneumocranium there. Extradural bleed, not sure if you can appreciate from this image, but I think if I were to use the lower slice, you can see the extradural bleed better. But you can see all this fracture involving the squamous part of the temporal bone, and also the mastoid part, the mastoid temporal bone with fluid within. So there's a base of skull fracture. That's why he developed the hemotympanum and fluid within the mastoid cells. And same boy showing the diastasis, widening of the suture there. So that's the widening of the suture there. This child was actually discharged, the parents to A were discharged from ED, but when we reviewed the 3D BRT, we thought, is there a fracture of the left orbital floor if you compare with the right side. But if you look at our raw data, we did not finish scanning the orbit because there was no indication for the orbit really. There's no periorbital hematoma. So be careful when you review this. This might just be artifactual, but we did inform the ED people to contact the child in case, you know, anything symptoms occur. Right. Another case is 1 year, 9 months old boy, alleged fall, and then vomiting for 17 times. So the symptoms are, the reason for CT is actually because of this excessive vomiting, but we do not see any evidence of intracranial bleed. Usually I would look up to the top, make sure that the extra-axial spaces are still quite capacious for this age. You can see that it's quite capacious to make sure that there's no cerebral edema going on. The ventricles are also good for age. There's no fracture on this 3D BRT. Next one is a boy who had MVA. GCS was quite bad in Hospital Sungai Buloh, was transferred here. The GCS dropped from initially 14, dropped to 12. So in pediatric, we're happy also to say that, you know, because we don't practice a regular sort of routine 6 hours, 8 hour CT scan, and our neurosurgeon also do not request that unless clinically indicated. And in this child, because of the drop in the GCS, the CT was indicated. So this is the CT that was done earlier in Sungai Buloh, showing intraventricular bleed in the left lateral ventricle. You have this subdural bleed in the posterior interhemispheric fissure, which actually has resolved. So the CT actually does not explain why the GCS dropped. So we did raise the suspicions of DAI, but I think no MRI was done, but the child improved after that. Okay, this very, very unfortunate child, mom actually, you know, committed suicide and bring her along with her, jumped from the 9th floor. Mom died, and she had multiple skull fractures, as you see here, multiple intracranial bleed, this left subdural bleed here, and then skull fracture there, and then you have the right posterior parietal extradural bleed. You have the subarachnoid bleed, you have the right contusional bleed in the right cerebellum. So basically all types of intracranial bleed that can occur in trauma. She has it, with jumping down from the 9th floor, you expect that. And all this is depressed skull fracture. But if you notice something, something else is abnormal with his brain, which is not related to the trauma. You see the white matter here, the periventricular white matter is very dark. And so white matter injury like this, this diffuse symmetrical, it has to be something quite systemic, and we know that's not related to the recent trauma. So looking back into the history, a few months ago, mom also tried to commit suicide by burning the bedroom with the children inside, and I think there was a lot of smoke, and we feel that this is due to the inhalational injury from the attempt to burn down the house. The child is CP now. So, but the CT cervical is normal. This is another one actually came out into our national news. She, 8-year-old girl, not sure it's unfortunate or fortunate, but the child actually, if you can imagine the highway this is not the exact place where she had an accident, was ejected out from the dad's car, which skidded from the I think the back window, and actually fell down onto another car that's parked in front of the shop, and fell down onto the road. Her GCS miraculously is full when she came to the hospital, and she has no intracranial injury or any skull fracture. She does have a femur fracture, and the cervical spine is normal. It seems that everybody is happy with the cervical X-ray, and she has no sort of symptoms to suggest a cervical injury. So no CT was done. I think last time we saw her when she came for the repeat X-ray for the femur, and she was well. Another child, 2-year-old, hit by this bunch of oil palm fruit. So you can imagine this hitting a 2-year-old brain patient. unconscious and with left ear bleed, very poor GCS and intubated. And again, showing this subarytenoid bleed with a comminuted fracture there in the left parietal bone, a lot of sort of surrounding edema in the contusional intraparenchymal bleed, and you have the comminuted fracture shown better on this bone setting.
Sorry, Dr. Rohazli, short of time.
Okay, I'm finishing. I think I'm going to my last slide. Yeah, boleh? 1 minute? Okay. So again, the cervical spine is normal and the comminuted fracture again shown there. And this is, okay, my last case here. Fell from bed but noticed swelling 2 days later, but only come to ED 2 days later after that with a scalp hematoma, but was discharged initially. Yeah, but as mom noticed that the swelling is getting bigger, came again, so it's already like a week after the trauma, and now you can see the extradural bleed in the right parietal region, and you can see the difference in attenuation because this is already sort of a subacute blood in there with a large scalp hematoma and a fracture. Okay, I just show you this. This is the CT brains that's done in our hospital this year from January to October. There were a total of 569. From ED, we try to catch the ones that comes to head injury, usually come through ED, 169, all of them are pediatric cases. Out of these, 88 are due to head injury, and the intracranial injury that's found, bleeding that occurs, is 58%. So I think it's not too bad. I don't think we're doing, to have positive findings in 60% of the scan that we do. I think we are on the right track. So this is my references, and thank you very much. So please image gently.
Thank you very much, Dr. Rohazli, for the very excellent lecture. Because time concern, we can only allow one question from the participants. The question is actually to Prof. Azizi. Go from Sarawak in child with tatted cord post myelomeningitis surgery but remain asymptomatic. How frequent would you follow up with MRI spine, and what age to do the scan? Prof. Azizi?
So thank you for the question. So normally what we do is we do a baseline MRI just after the initial repair. And then the child will have a growth spurt at first year, and then 4 to 5 years old, and then somewhere around puberty. So basically, we should do MRI just before after the growth spurt. So this is where we can anticipate things if they deteriorate further. So sometimes we don't have time to in certain centers it's quite difficult to get MRI. So these are the minimum. So at least one at the growth spurt, and if resources is not the problem, so what we do is we do MRI every 1 to 2 years.
Okay, thank you, Dr. Azizi. I think because of the time interest, we have to stop our session for this morning. And thank you again.
There's one more question for Prof. Zam. So I think just one more last question from Ms. Yuzili. Prof. Zam, with regards to microgravity and sinking flap syndrome, it seems that the pressure difference between compartment, intra and extracranial is of utmost importance. May I ask Prof's opinion regarding placement of a closed negative pressure subgaleal drain right after cranioplasty for patients with sinking flap syndrome? What is your opinion on this practice or recommendation on this? Thank you for your time, Prof. Zam.
Yeah, so my practice is a gravity drain. It's not a negative pressure drain. So if you put a negative pressure drain, can be disastrous for certain neurosurgery procedure like transtentorial herniation, outward herniation, dural hemorrhage, and so on. If you put the negative pressure inside it, sunken flap syndrome, then that's the risk. You create more negative pressure inside it. Then this negative pressure can cause a change in blood flow. So I don't use negative pressure. I use the gravity drain. Without pressure, basically it's a gravity drain. Again, if patient on shunt, patient was shunted and then also has this sunken flap syndrome, then what I normally do is I clamp the shunt first, and then wait until it's bushed, and then do the cranoplasty that time. And you can mold the bone nicely, and then you can release the the shunt again. So the key is negative pressure drain can be disastrous, can cause many things: dural hemorrhage, bradycardia, upward herniation, and so on. You have to be careful with that, especially with these two differential pressure condition.
Okay, thank you, Prof. Adam. I would like to thank again to all the presenters and to my co-moderator, Dr. Alaini, and I'm sure all have gained a very much knowledge from this session. So with that, I would like to pass back to our organizer to continue with the next session. Thank you very much, and Assalamualaikum.
Waalaikumsalam. Thank you, Azhari and Ailani. So the most important session is photo. So can all the moderators and speakers put on your camera on? Or the rest can join too? So who are going to do the count? The rest can join too. So in 5.
I'll do the count, Mr. Azmi.
Okay.
All right. Everyone ready? Okay. 3, 2, 1, smile. Okay. One more take. Okay. 3, 2, 1, smile. Okay. Thank you very much.
Thank you very much.
Thank you. Thank you.
So we shall move to the next session.
Okay, thank you to the speakers this morning.
Yeah. Okay, thank you very much. So once again, welcome to the joint AASNS educational course and the second Neurosurgical Emergency 2021 online conference. We're excited to have you join us online today. We are currently in the functional epilepsy DBS session scheduled for the 14th November. So I am Dr. Yu, a neurosurgeon in Hospital Sungai Buloh, Malaysia, and I'll be moderating this session together with my friend and fellow neurosurgeon, Dr. Yi from Hospital Kuala Lumpur. So just a few tips before I introduce the session presenter. If you have a question for the presenter, please type it in the Q&A chat box. Dr. Yi and I will help convey the question to the presenter at the very end of the session. General comments and reflections on the presentation can also be typed in the chat. Now let's get started. So it is my pleasure to introduce Professor Dr. Eka. He is a professor, chairman, and dean of the medical faculty in Pelita Harapan University, Indonesia, and also the founder of the Indonesia Brain Foundation. He holds the post of the president in the 11th International Conference of Cerebrovascular Surgery. His special interests are vascular, tumor, and neuroscience. I will now turn the session over to Professor Dr. Eka to begin his topic on emergency in giant aneurysms. Professor?
Thank you very much, Dr. Yosindi. Thank you, my brother Asmi alias. Everybody in Malaysia, missing you eating durian very much. Yeah. So hopefully soon. Yes, very much.
Yeah.
Okay, thank you. Let me share with you about experience in Indonesia in emergency of giant aneurysm. Let me use my slides. Everybody can see the slides?
Oh, yes.
Okay, thank you. So we have two giants in Indonesia, giant Buddha Temple of Borobudur, and giant dinosaur of Komodo. And next time, join us coming to Indonesia. Okay, this is our hospital, my medical school and research center. So every day and night we are here. And now we have 6 full-time neurosurgery in this hospital, and whole Indonesia. In a team, we have 27 neurosurgeons joining our group, and we manage them in a team. And hopefully next time you can join us. We will celebrate 25 years our team of neurosurgery this month. So actually, when there's no quarantine, please come. Yeah, it's missing very much traveling abroad. So we are also center of WNS in neurosurgery. Okay, about giant aneurysm. So in medical practice, probably we will see many giant aneurysms. But when to do something, when we need to be interfered, because many times I give lecture in my young generation, not everything appear abnormal in the imaging need to be interfered. So giant aneurysm need treatment, of course, when hemorrhage and when progressive headache, when worsening of cranial nerve palsy, like these guys. This is just an example. You see that hematosis means there is like enlargements of the aneurysm and compressing third nerve. That is very important for young neurosurgeon practicing in the neurosurgery. This is a sign of emergency because that is starting of enlargement. If we are not aware, then soon aneurysm will bleed, definitely. And also when there is an intractable seizure, also indication to be treated. So during our experience, we have 93 surgery in giant aneurysm. And by definition, giant aneurysm is when large, more than 25 millimeter, and 5% of all intracranial aneurysm. We understand that sacral aneurysm during the lifetime probably bleeding, but sometimes also probably grow to reach giant proportion. So giant aneurysm basically coming from saccular or fusiform, where there are different history, different pathophysiology, and of course different treatment and different approaches. We will see later in the cases. What is the pathognomonic finding in giant aneurysm? We need to see that the broadening of the parietal artery, the spring, branch vessel, and sclerotic calcification, and also mural thrombus that very often happen in the giant aneurysm, and that's will need to be considered in the tactic of attacking giant aneurysm. And this is the annual risk of the rupture of giant aneurysm. So again, decision to treat giant aneurysm. Not every abnormality in the imaging need to be intervened. Yeah? Of course, the decision is very much depend on the age, the location, mass effect, clinical presentation. One symptomatic normally need a prompt treatment and future stenosis of the parietal artery. So remember that we are not God. Yeah? We are neurosurgeon, means that we are consultant of our patient, and the patient very much rely on us what need to be done. So they don't understand about giant aneurysm, but what they understand is, oh, I am the patient of Dr. Asmi, I am patient of Dr. Sinli, I am Professor Samsuri, and then please advise me what to do because I don't understand. That's very important. So again, yeah, so normally our hand is itching to attack the aneurysm, but sometimes, remember, when attacking is more risk, then we need to consider whether we need to attack or not. So I try to draw some scheme of giant aneurysm. They come to us with impending bleeding, impending rupture. So when they come with the impending bleeding, of course, we need to do something, either one, surgery or embolization. And surgery may clipping, trapping with or without bypass, low flow, high flow, that's depending on the situation. And sometimes we need to do a balloon test or ligation test. And sometimes they do endovascular, which is leg coiling, stenting, flow diverter. They all has its own risk that really need to be considered, what need to be done. And sometimes the patient comes to us with mass effect. I will show the cases later also when they come with mass effect. The answer is surgery, because we don't have time to do endovascular for this. And sometimes I put in question marks in the box. So the preoperative planning, I like to do sometimes simulation, how big is the craniotomy needed. Because craniotomy for the giant aneurysm is different with sacula. We don't have like a mini craniotomy for giant aneurysm because philosophy is different. We need to see the position, the neck, the proximal, the distal artery of the aneurysm before attacking. So I don't think any wise decision to do mini craniotomy for this. And there are many roads going to Rome. We see that again, sometimes clipping, trapping, coiling, decompressing, and sometimes reconstructing. And the best approach is the maximized approach for the surgical anatomy. Important to have, for instance, orbidozygomatic approach is very good to have a huge exposure. And wide splitting of the Sylvian fissure, very, very important. When you are a young surgeon, I recommend you to exercise yourself how to split the Sylvian fissure nicely, gently, because it's important to expose many structure before we attack it. And then removal of the clinoid for the paraclinoid aneurysm, and of course the control proximal and prevent multiple clip. So surgical clip may cause infection of prolonged temporal artery, very important. We need tactic, we need to have a strategy before. Prolonged temporary clip, for instance, of course, may cause infection and may have a more morbidity. So let me show you some cases of giant aneurysm. This is like an M classic aneurysm with convulsion. This is a young lady. This is a CT angio. We'll see here. I do surgery with my colleague in a rural place, not in the Karawaci. You see wide splitting of Sylvian fissure. Very, very important. Then when we can split nicely, we can have also nice structure here. We can see very clear whether the IC, AM, optic, then chiasm, third nerve. Again, it's very, very, but you see it's very beautiful when we can split very good in the Sylvian fissure. You see, we need to see the parent artery, the proximal part of IC, right? This is the ophthalmic here, and this is the distal artery of the giant aneurysm. This is the giant aneurysm. You see the body here. So again, wide splitting is very important. They recognize everything. Then classically, we have to clip proximal control. In this case, it's the IC and also the anterior cerebral artery. We need also to temporary clip. You will see here, both we clip, then we have time, because after clipping, of course, the body of the aneurysm become less tense, right? Then we have the clipping permanently this time. So remember, these two proximal control, then we can clip permanently. Again, use a big clip and multiple clip, because single clip is very dangerous. Because again, the anatomy of the body of the giant aneurysm, many times, many thrombus and thick body, then on the single may slip to the parent artery, and this dangerous to make a stenotic in this parent artery when we are not aware for that. So again, remember, always double or triple clips. Never use a single clip in a giant aneurysm, except you are very sure that the wall is very thin and not any structure inside the aneurysm. This is another classic 50 years female with a severe headache. You see already as an age here. And you see here, this is also classic giant M1 aneurysm. You see in the CT angio. And this is also classic surgery. I see here, A here. Then again, we just clip temporary here. Then in this case, you see that I suck the body of the aneurysm. After clipping the proximal and distal artery, then classic things when we suck, collapse in a few minutes, then we have time to clip. You see, multiple ring clips to restructure the parent artery. This again very important. Otherwise, they will slip to the parent artery. So this is classic one when you can suck the body of the giant aneurysm. After that, removal the temporary clip, then everything going well. When you don't have an ICG, this is Doppler. It's very simple, very cheap tools to check the existence of the parent artery. It is the lady couple months after surgery. She lives in Bali. This is another unique case of giant IC A1 aneurysm. You can see here. This is MA1. So after opening the Sylvian fissure, you will see M1. But because this is very big and very tough body, then I have no chance to see A1 in this case. So what I did, I clip here in the IC, then I asked my assistant to suck with a very big and strong syringe, suck like this. There's a competition, you see, competition, the sucking and the feeling of A1. When the suction of my assistant is stronger than feeling A1, then I have a couple of seconds to see the collapsing of the body of the resident. Then we clip the body. You see that? I see here, we clip temporarily and then suck here. My assistant strongly suck. Then I have time to see the collapsing and quickly clip the neck of the aneurysm. So this is on this strategy. So there's a giant ICPC, and then we decided to do bypass and then clipping of the parent of the artery. This is another unique case. So this male came to me with a worsening of the visual after coiling of the giant aneurysm. So he came to my colleague in Jakarta, and my colleague doing embolization of the giant aneurysm. That was correct. But after the coiling, the patient get worse and worse the visual. So he came to me, and when I checked with a CT, with a DSA, you see here the refilling of the giant aneurysm. So this is what I mean with the patient came to us with a compression syndrome, compression of the chiasm. And this is very critical because you see this is the remain visual. So no time to do another embolization. Because when you embolize the giant aneurysm, you need times to wait until shrink of the giant, right? So no way to endovascular this case. Then just do opening. Then quickly I open the Sylvian fissure, like the first case you see here. This is very nice, and because this is paraclinoid, I need to drill the anterior clinoid. I like to drill intradurally, is severe, because we have time when something happened of bleeding. So you see this case, I clip in the proximal side of the aneurysm and distal side. Then I try to puncture as the former case. You can see here after puncturing, but you see there's nothing happened. Nothing happened. Then I clip. We don't have time too long. Yeah? I clip the neck of the aneurysm, then quickly remove the temporary artery because again, we have limited times. Opening this, then I try to suck again the body of the aneurysm. When I suck, but again, there's no collapse. You understand why? So we have no time. We have to open the body. So use a knife opening. You see why not collapse? Because the coil are inside. So anyway, quickly removing of the coil, then clipping here. You see, you have to be careful because the clip slipped to the parent artery. You need to double and triple clip here. So this is what I did because with the compression syndrome of the chiasm, then the answer is quickly decompress by removal of the compressing things, which is thrombus giant aneurysm in this case. So there's another case, unique case. Somebody came to me with a bitemporal hemianopsia and already blind on one side. You see here giant aneurysm here. And this is also, we need to quickly clip in the body after aneurysm and then quickly remove the content because the thrombus here. So this is very thin chiasm here. So do not remove everything, do not peel too much because this is very minimum modality. So just clip here and then remove the content of the aneurysm. So this is another case, unique case of the huge young lady with a bleeding SAH with a giant aneurysm 6 centimeter. So, you know, you understand what it is very unique because definitely aneurysm already there when she born because she was only 12 years. So anyway, in this case, I open widely the Sylvian fissure. You see this, the IC, you see this, all of the structure inside. Then quickly I clip here in the parent artery, then opening the giant aneurysm. So this case is very unique because this is in the left side And the young lady came to me with a very good condition, there's no deficit. So this left, be careful, everything attached in the normal cortex. So what I did, I just clipped from inside. After removal of the content of the thrombus from inside, you see here, the resources are here, and then I clip from inside of the body of the aneurysm clip. This is unique because I don't want to fail, because the wall is attached in the cortex. When we fail, we will damage because the left cortex. Be careful. So this case very unique and very different. When you study everything in the anatomy, then you make everything take a different. And again, this is from inside. You see that from inside the body of the aneurysm. And after make sure there is already no bleeding. And this is the lady after surgery. So this is another case of dolichoectasis. So this is coming from fusiform, not from the bacilli. This is very difficult case. He came to me that we discussed with every expert. This is with SAH. What do you do? Because at the time it's so many probabilities. I said to the wife, when you do nothing, it may get rupture. When you do clipping, well, we cannot clip. When you do bypass, we don't know where clip. Then finally we trap. We have the vertebral artery in this case, 44 years with the SAH. But you see, he never wake up after trapping the vertebra. It's unfortunately, this is not good a decision. Anyway, that is after explaining there is another possibility we cannot do, and then this is the only case. But another similar case, this happening somebody in in Kazakhstan. Then Professor Yerbal consulted with me. I also suggest to trap one vertebra here, but he survived. You see, this is the guy after trapping. So two similar case, but different result. Anyway, we are consultant, and sometimes the result not always good. Explain carefully, everything may happen to the patient. So I thank you very much for your attention. This is the decision how and what to do to the giant aneurysm. Thank you very much.
Thank you very much, Professor Eka, for addressing this very interesting topic and the wonderful videos. So our second presenter today is Dr. Ahmad Ritaudin Muhammad, who will be talking about the red flags in epilepsy. Dr. Ahmad is a pediatric neurologist working in the Women and Children's Hospital, Kuala Lumpur. He obtained his medical degree from the University of College London in 1997 and membership of Royal College of Pediatrics and Child Health, UK in 2003. He now leads the Pediatric Epilepsy Surgery Program in Hospital Tunku Azizah, Kuala Lumpur. Now let us welcome Dr. Ahmad and his topic today, red flags in epilepsy. Dr. Ahmad, the floor is yours.
Thank you very much, Dr. Yu, for the kind introduction. I actually pre-recorded this presentation to make sure that I didn't run out of time. So I'm just going to share my presentation now. Can you see the screen?
Yes, we can see.
I'll just play, and hopefully this works well. Thank you for the organizing committee, especially Mr. Azmi, for inviting me to this talk. Neurosurgeons and neurologists often work together, and we've been working together even more so in recent years because of our epilepsy surgery program. I understand the next two speakers will cover a bit more on epilepsy surgery. So just to cover some basics in seizure and epilepsy classification in my talk, and then discuss a few instructive cases that I hope will be helpful for the audience. As we know, a seizure or epilepsy is a disorder of the brain which is characterized by an enduring predisposition to generate epileptic seizures. How do you diagnose epilepsy? It's a clinical diagnosis. So if you've had 2 or more unprovoked seizures more than 24 hours apart, you've got epilepsy. You don't need EEG for diagnosis. You can even diagnose epilepsy if you've had 1 unprovoked seizure plus an additional risk factor. And this is usually in the form of abnormal neurology, significant MRI findings, or an abnormal EEG. The incidence of epilepsy in Malaysia is estimated to be 4.2 in 1,000 population. And if you calculate that for children, there's more than 30,000 children under the age of 14 years who have active epilepsy. When you're dealing with children or adults with epilepsy, it's worth trying to understand and classify their seizures. And this is the latest seizure classification by the ILAE, which is the International League Against Epilepsy, which has divided seizures into focal onset and generalized onset. And sometimes this division is not easy to distinguish, and therefore there's also this category of unknown onset. It's worth familiarizing yourself with some of these terminologies. The other thing that is useful to get yourself used to is this epilepsy syndrome classification. And by epilepsy syndrome, we mean groups of patients who share same seizure type, usually similar age of onset, similar EEG changes, and they may even share imaging, genetic, or other metabolic abnormalities. One of the easiest way to classify is according to the age of onset, from the neonatal period all the way up to adulthood. This is another way of looking at it. And the advantage of seeing it in this way is because the etiology is put here separately. Because we know that a single epilepsy syndrome can actually be caused by several different etiologies. And similarly, one etiology can give rise to several different epilepsy syndromes. I'm going to give some examples in the next few slides. Well, the most common epilepsy syndrome in childhood is benign Rolandic epilepsy. And these are children who are usually school age. They have focal seizures, usually in sleep. When you do their EEG, they show this typical centrotemporal spikes. Imaging is not helpful, so we don't routinely order MRI when we suspect benign Rolandic epilepsy. And we basically do not know what causes it, but there's a suggestion that there might be some genetic basis for this. An example of a generalized seizure in childhood is childhood absence epilepsy. And these are children who present with frequent staring spells. When you do their EEG, they show this typical 3 Hz generalized spike waves. Again, MRI is not helpful. And again, we think there's probably an underlying genetic contribution, although the gene, a single gene, has not been found to explain the condition. Then you have some more nasty epilepsy syndromes, such as this, Dravet syndrome. And these are children who tend to present early in life with febrile seizures, most of it prolonged, some with status epilepticus. And their seizures may evolve with time, and they may develop different seizure types. And their EEG may evolve over time from a normal EEG to that which typically shows multifocal or generalized spike waves. Imaging is often unhelpful, but the key to diagnosing this syndrome is doing genetic testing, where you should find sodium channel 1A mutation in the vast majority of cases. Sometimes, and this is what I refer to, one syndrome can be caused by different things. A typical example of this is West syndrome. Now, West syndrome are infants that present with epileptic spasms. When you do their EEG, you'll see a very bad EEG with highly chaotic background that is known as hypsarrhythmia. And West syndrome can be due to many things, among them tuberous sclerosis complex, where children will have often multiple tubers in the brain. But we also know now that West syndrome can be due to many different monogenic conditions, which are collectively known as early infantile epileptic encephalopathies, or EIEE in short. Similarly, one condition or one etiology such as tuberous sclerosis complex can cause slightly different epileptic syndromes. We've heard about West syndrome, but children with TS whose seizures are poorly controlled can progress to develop many different seizure types, including tonic seizures, drop attacks, and generalized tonic-clonic seizures. And their EEGs may progress, often becoming multifocal, having this characteristic generalized paroxysmal fast activity and slow spike waves on their EEG, which are typical of this condition known as Lennox-Gastaut syndrome. An example of a syndrome that's often a favorite for epilepsy neurosurgeons are these patients with temporal lobe epilepsies due to hippocampal sclerosis. And they typically present with focal seizures with impaired awareness. When you do their EEG, they may show focal slowing and epileptiform activity lateralized where the hippocampal sclerosis is. We don't know what the etiology of hippocampal sclerosis is, but the most favored hypothesis is that it is an acquired disorder, and certainly children with history of prolonged febrile seizures are at risk of having this syndrome. Another example of an epilepsy syndrome which may end up with epilepsy surgery is Rasmussen syndrome, where children have focal seizures to start off with. Seizures then ramp up, and they may develop this epilepsy partialis continua, or APC. They have typically EEG abnormalities lateralized to one hemispheres. The MRI may show progressive changes involving one hemisphere. And we think this syndrome is due to immune-mediated disorder. Now, why are we so interested in trying to classify epilepsies into particular syndromes? Is because it has important therapeutic and prognostic implications. We know children with one of these genetic epilepsies, such as benign Rolandic epilepsy and childhood absence epilepsy, have got excellent prognosis. All children with benign Rolandic epilepsy will grow out of their seizures. Most children with childhood absence epilepsy will have their seizures stopped just by a single medication. On the other hand, children with Dravet syndrome or West syndrome due to one of these monogenic EIEEs are often drug refractory, and they are usually not surgical candidates. Therefore, you may need to think about other therapies, including ketogenic diet or vagal nerve stimulator. On the other hand, syndromes like tuberous sclerosis, temporal lobe epilepsies, and Rasmussen syndromes, if they are drug resistant, they are usually excellent candidate for epilepsy surgery. Therefore, it's worthwhile recognizing these syndromes and trying to classify them accurately. Who are the patients who are good surgical candidates? These include any children with a lesion on their MRI, regardless whether their seizures are controlled or not. Any children with drug-resistant seizures, and that's defined as ongoing seizures despite adequate trial of 2 appropriate anti-epileptic drugs. There are some patients with specific surgically remediable syndromes, and these include patients with hemimegalencephaly, for example, or children with Sturge-Weber syndrome, hypothalamic hamartomas, and even tuberous sclerosis complex. And all these children and all these patients need to be referred early on, especially if they are young. They have bad EEG, or they are showing evidence of developmental delay or developmental regression. I'm going to spend the next few minutes talking about a few case histories which are of some interest. The first is an infant who at 6 months of age had status epilepticus and weakness on the right side, and the CT showed bilateral subdural hemorrhage, which is worse on the left side. It was managed conservatively, was discharged, but 2 months later was admitted with cluster of seizures, especially upon waking. This is a video of the patient. You see these flexor movements which occurred repeatedly. There's one there, there's another one there, and there's another one coming there. And when you do the EEG looks bad with chaotic background and multifocal EEG epileptiform discharges. And this child had a repeat scan which showed persisting subdural collection. And the question was whether he needed surgery because of this new onset of seizures. But in fact, epileptic spasms per se almost never occur following acute insult or neurosurgical complications such as hydrocephalus occurring after a brain insult. And that's because the pathophysiology of spasms is thought to be due to a complex interaction between cortical and subcortical structures. So it takes time for spasms to develop. It also explains why spasms occur usually bilaterally, so you get bilateral jerks, despite a unilateral lesion. And when Dr. Sumita looked at a cohort of patients with epileptic spasms, she found that in fact the most common cause of spasms in our population was post-traumatic brain injury. And the spasms occurred typically 2 to 14 months post the traumatic brain injury, not immediately after. And similar experience is also reported elsewhere. And it's again in this paper, the reported spasms occurring 2 months to 2 years post-traumatic brain injury. And importantly, the spasms would respond to corticosteroid and or vigabatrin. So if you see infants in clinic doing some funny episodes, especially repeatedly, especially upon waking, think of spasms. Second case is a 9-year-old who had seizures since 5 years of age, described as an aura and right-sided stiffening. And interestingly, the seizures were mostly triggered by loud and high-tempo music. And her seizures soon became refractory. She even had a status epilepticus. She also has history of recently diagnosed hypothyroidism and a family history of hypothyroidism. Previous EEG and brain MRI was normal. Won't have time to show her video. I'm sorry, I don't know what happened. I'll try and share again. Sorry about that. Well localized to the left central and temporal region, as shown by the arrow there. When we did the MRI, even on 3 Tesla, we could not find anything. But on PET scan, she showed hypometabolism over the left temporal region, specifically over the left superior temporal gyrus. This girl has a musicogenic epilepsy, and that is epilepsy with seizures that are consistently triggered by sounds that are in melodic or harmonic combination. I think many people have reported localization where these seizures arise from, and in various papers, various people have reported, mostly originating from the right or left temporal region. There are also reports of intracranial EEG localization of musicogenic epilepsy, and people have localized it to either mesial temporal region or the superior temporal gyrus or even the lateral neotemporal cortex. Because of this, we wondered whether this girl, since she was a drug refractory, would be a candidate for a surgery. Remember, she also had this history of hypothyroidism, and as we were looking up musicogenic seizures, we came across reports of GAD65 antibody in patients with musicogenic seizures. And in this report, they had 9 patients, all who had temporal lobe epilepsy, who was positive for GAD65 antibody. 2 of them, in fact, had surgery but did poorly, and a few of them had immunotherapy with some response. So we went ahead to check our patients' GAD65 antibody, and indeed it was elevated. And so the final diagnosis was temporal lobe epilepsy secondary to GAD65 autoimmune encephalitis. And she was given methylprednisolone recently, and we are yet to find the outcome. Third case is an 8-year-old with 6 months history of seizures, with blank stares, right-sided stiffening, and hypermotor behavior. When we did video EEG, her seizures were very well localized to the left temporal region, and the MRI showed slightly enlarged and high signal left hippocampus. So we thought she may have a left hippocampal dysplasia. And because she was drug resistant, she subsequently underwent left anterior temporal lobectomy. The seizures worsened after ATL, and serial EEG subsequently showed abnormalities confined to one hemisphere. The serial MRI showed progressive atrophy, and clinically she developed a hemiparesis and cognitive decline. And all these features actually fulfills the criteria for Rasmussen's encephalitis. She eventually had a functional hemiaspherotomy at age 13 years, and fortunately she has been seizure-free, albeit with new hemiparesis now. And early Rasmussen's may be difficult to distinguish from epilepsy due to focal structural abnormalities, and there are various reports from that from even as early as 1996. So in this report, there are 3 patients who had typical temporal lobe epilepsy, presenting initially and then had surgery, but subsequently found to have Rasmussen's encephalitis. Case number 4 is a girl who had history of severe nephrotic syndrome and multiple complications during infancy. She recovered from her nephrotic syndrome, but subsequently developed seizures from 5 years of age with aura, palpitations, and automatisms. Her seizures soon became refractory to medication. She also had some behavioral problems with aggression and learning difficulties. When we did her EEG, her seizures and interictal abnormalities were well localized to the left temporal region, and her MRI showed convincing left hippocampal sclerosis. And because of this, she had a anterior temporal lobectomy at 14 years of age, and she became seizure-free. But she had a relapse on nephrotic syndrome at 18 years, and about a year later, she presented with episodes of headache, difficulty breathing, fainting and shaking, and she went to see some other neurologists who thought these could be seizures, and thus she was restarted on anti-epileptic medication. But these were the episodes recorded, and they clearly looked different from what she had before. Upon further questioning, and she's had some other issues recently break up with boyfriend and things like that. And in fact, what she had was psychogenic non-epileptic seizures. This is well described in the literature. And risk factors for post-surgery PNES include temporal lobe epilepsy, those with previous psychiatric illness, if they've had PNES even before surgery, those with learning disability and female gender, and you should especially suspect PNES when there's a different semiology reported. So I hope I've given you some idea about seizure and epilepsy classification, and that it's important to recognize that for therapy and prognosis. Epilepsy surgery evaluation should be offered to all with lesional epilepsy, drug-resistant epilepsy, or specific surgically remediable syndromes, and these should be urgent if they are young and if their EEG is bad. It's always important to think of differential diagnosis and other pathologies when working out children for epilepsy surgery. With that, I thank you.
Thank you very much, Dr. Ahmad, for the insightful presentation.
Yes, thanks very much. Sorry about the glitch just now. I don't know what happened.
I think it's okay because we can still see the rest of the screen very well, and after you drag, actually it's quite clear. So getting back to the session, as a reminder, if you all have any questions for the presenter, please type it in the Q&A chat box. Dr. Yee and I will help convey the question to the presenter at the very end of the session. Now, it is with great pleasure for me to introduce our third speaker today, who will be talking about the highly anticipated talk entitled Epilepsy, a Surgeon's Perspective. Our speaker is none other than Mr. Azmi, who is our very own organizing chairman for this course and the Vice President of AASNS. Mr. Azmi is the head and senior consultant neurosurgeon in the Department of Neurosurgery in Tunku Abdul Rahman Neuroscience Institute, HKL, and also the head of Department for Pediatric Neurosurgery in Women and Children's Hospital, KL. Apart from holding the post of Vice President in AASNS, he is also active in the international scene, namely WFNS, ISMIN, World Academy of Neurological Surgery, ACNS, ISPN, AASPN, and our very own Neurosurgery Association of Malaysia, NAM. So now let us welcome Mr. Azmi Alias. The floor is yours.
Thank you, Zinli, for your kind introduction. So it is my honor to share some of our experience in Hospital Kuala Lumpur. So thank you everyone who joining us. So the first speaker, Dr. Ahmad, is one of our colleague, a pediatric neurologist, has covers a broad spectrum of epilepsy syndrome in pediatric. So it's my task to continue as a surgeon perspective. So this is our hospital in Kuala Lumpur. We have our adult wing located at the Tunku Abdul Rahman Neuroscience Institute, part of this big hospital complex in Kuala Lumpur. And this is our children wing, which is located just across the road and officially opened about 2 years ago in July 2018. It's named Hospital Tunku Aziza, also known as Women and Children Hospital, where we do a lot of epilepsy and pediatric surgery nowadays. And this is our theater. As we know that refractory epilepsy in children is an enormous challenge, not only for us as caretakers, health of personnel, but also the parents, families, and communities. And the epilepsy can be progressive with potential risk of structural damage to the brain and the nervous system. And if it is not well treated, it can lead to development regression, associated morbidities related to psychological learning disability. It creates social stigma and occupational consequences. And we know that the sudden death in uncontrolled epilepsy can happen in children. So this is quite typical cases where the child can present with epilepsy. And the various etiology and the spectrum in pediatric are much more different compared to adult. In terms of surgery also, in terms of indication of surgery for refractory epilepsy in adults, usually you wait for 2 to 3 years, and then you declare as a resistant. But in children, sometimes the tendency to refer for surgical intervention is much earlier because the child can develop a rapid progression and the brain, because of the brain plasticity, and the child will recover early, therefore surgery intervention can be done earlier. And the various etiology also in children, they are much more different. they can have a metabolic or genetic disorder as compared to acquired pathology in adults. So the treatment can be medical and surgical, but the medical therapy, out of that, about 25 to 30% will be resistant. We know that the seizure which originate in particularly of the brain and secondarily spread to involve other brain region may benefit from various surgical treatment. So when we do a surgical surgery in epilepsy, whenever in our case, we receive cases from our pediatric neurologists, we discuss in multiple disciplinary treatment approach, and usually we start to treat in terms of surgery when, especially when there is a lesional lesion on the MRI. And as you can see, the epilepsy can be caused by various reasons. When you have a lesion, sometimes you can do just lesionectomy, but sometimes the brain network and the pattern are completely different, where there is a potential of seizure zone which is broader than area that you need to resect. Therefore, sometimes you have to do a functional resection in which your resection of area is much more. So therefore, the target of surgery for epilepsy is to eliminate the cause if possible, and most importantly, to eliminate and lessen the severity of the seizure. If you can have a prism of seizure, is very much better, and if possible, without any deficit, and of course, to alter the long-term development and behavior outcome of the children. So there are various type of epilepsy surgery that we can offer, either resective or disconnective, and we also offer neuromodulation. So this is example of lesionectomy, a case of refractory epilepsy. As you can see on MRI, this is rather straightforward. This embryoplastic neuroepithelial tumor. As you can see from the intraoperative finding, you can see a very clear demarcation between the normal brain as well as the tumor. So this is quite easy surgery, but most important thing that you should try to remove all the entire epileptogenic substrate. As you can see here, you can use, by combination of blunt dissection and a little bit of, if possible, avoiding bipolar, because the thermal injury can impact the function of the brain. And you have to remove the entire epileptogenic substrate, because even you retain a small component part of it, the patient still have a seizure. So sometimes you can offer other form of lesionectomy. For example, in tuberous sclerosis, as you can see, these kids who presented with a seizure since 9 months, and from the MRI you can see there is a tuberous. For tuberous sclerosis, the lesion can be multiple, and the indication of surgery mainly to remove the one that caused a seizure, which can be identified using EEG. And you can see here one of the tubers. So the technique is you do tuberectomy. In other words, we do not remove the abnormal gyrus and so on, but we go and we go along the perituberal tissue, which need to come out. Intraoperatively, usually you can define the margin, because the consistency between the tubers are usually very firm, and compared to the surrounding area, which are very soft. So you can just use a microscope and usual micro dissection. You can do tuberectomy. This is a closure view and post-operative control CT scan. And the use of intraoperative technology in terms of localization is very important, because it will help you to reach the target adequately. We use navigation routinely, and sometimes we use intraoperative ultrasound to determine the extension of our resection and the completeness of the resection. And we use ultrasound in our theater, and we compare the finding with post-operative MRI. So back to Hospital Kuala Lumpur, we started the program somewhere in 2012 for children, but only in 2013 we have done our first anterior temporal lobectomy, and subsequently in 2016 we embarked on the multiple disciplinary team. Pediatric epilepsy consists of multiple discipline. And in 2018, we moved to our neuromodulation surgery with involved VNS. So this is the team consists of the neurosurgeon, pediatric neurologist, neuropathologist, neurologist, a nuclear medicine specialist, and we also collaborate with one of our senior neurosurgeon. We have very vast experience in doing a pediatric surgery, epilepsy, which is a Professor Ben, who's work in Radha Masara Private Hospital, and also Dr. Ahmad, a very strong collaboration with Royal Children's Hospital in Melbourne, where he was trained and worked as a pediatric neurologist there for 2 years. So if you look at the experience in our hospital, Kuala Lumpur, we move slowly. We start with a lesionectomy and subsequently followed by ATL because we want to see the outcome. And eventually, we embark in the phase 2 in 2018 when we start to do a functional disconnection surgery. And in 2019 and in 2020, we do a lot of vagal nerve stimulation for refractory epilepsy. So this is the first experience that we do ATL. So we use in 2 components, 2 steps. First, the neocortical resection and followed by messiotemporal resection. So in the first few experience, we use we measure the temporal tip about 4.5 centimeter on the right and 4 centimeter on the left along the medial temporal gyrus, and we resect along the superior temporal gyrus and perpendicular to that. And this is where we make a resection on the neocortex as we enter to the temporal horn of the ventricle. So this is an initial phase that, but later we modify the technique. We only remove the anterior 2 centimeter of the superior temporal gyrus, and we preserve the distal cortex. And then the technique of the resection using both sharp, bipolar, and also CUSA. So, but as we reach the ventricle, so usually I use just dissector and try to minimize the use of bipolar. And I will skip the detail because the next presenter will cover more of the ATL. So for the mesial component, usually we take about 3 centimeter from the head of the hippocampus, and then we resect it accordingly. This is a immediate post-op, and in the early experience, we use a lot of PET scan just to help us to understand and to make sure that our resection area appropriate. So sometimes you can have a pleomorphic tumor, for example, like this, where we also use ATL technique to remove not only the tumor but also the mesial component. But the dissection are much more extensive compared to the usual measurement because you have to include the cortex which involve the tumor. So this is a mesial component and the temporal lobe. So we look at our analysis involving patient in our center. Majority are hippocampus sclerosis, and we also have about 55% tumor, including ganglioblastoma, PSA, DNET, low-grade astrocytoma. And then there are significant in terms of reduction of medication before and after surgery. And in terms of outcome, angle outcome, grade 1, in the immediate, about 96% have seizure reduction, and about 3 to 6 months early outcome, about 82%, and 1 year, about 82%, which is quite reasonably good. So by having this a good result, so we decided to embark on much more intervention, which is involved the functional resection or disconnective surgery. This is our second phase. As we build up our confidence, we move to functional resection. And we have about 11 cases. And out of this, about 91% has a significant reduction of seizure, but 1% unchanged. We perform about 5 peri-insular functional hemispherotomy, 1 MCL stroke with seizure-free, 1 Rasmussen encephalitis, also seizure-free, 3 hemimegaencephaly, although we do not have a seizure-free in all these cases, but majority, about 1 case, 90% reduction, and 50%, more than 50% reduction in 1 case, and less than 50% reduction in another case. So we also perform 1 completion of hemispherotomy. After ATL, the patient still have a seizure. So subsequently, following the second surgery, the patient has seizure-free in 1 Rasmussen, and we do a quadranectomy or temporoparieto-occipital disconnective surgery in 5 cases, 1 encephalomalacia with seizure-free, and 2 dysplasia, 1 seizure-free, and 1 more than 50% seizure reduction, and 2 cases in hemidysplasia with 1 cases achieving more than 90% reduction and 1 case unchanged. So the indication of TPO, they make sure that the seizure refractory to medication, and there is a focal seizure associated with unilateral TPO onset, and generalized seizure with asymmetrical clinical or EEG feature to suggest focal basis in the TPO region on one side. So this is example of cases, a 7-year-old boy who presented with a congenital hydrocephalus at birth and also nasal encephalocele. So he underwent BP shunt at day 4 of life and subsequently repair of the nasoencephalocele. And he had episodic spasm since at the age of 5 months and cluster spasm which does not cease on medication. And he had recurrent seizure at the age of 2 years and 7 months characterized by feeling of fear and left-sided stiffness during the attack of the seizure. So the EEG shows that he has a right posterior quadrant slowing and epileptiform activity. And also we did MRI and also PET scan. As you can see here, there is evidence of heterotopic gray area over occipital region with no FDG PET uptake. So indicate that the lesion is localized and to the temporoparietal occipital region. So this is a good case where we can offer TPO. So usually we use a 3D T1 surface reconstruction prior to surgery to plan our surgery, because this is very important. As you can see, we use this superficial landmark that we plan pre-operatively. We have a good discussion with our neurologist prior to surgery. We use a superficial vein as our landmark. As you can see, we take about, this is since a motor sparing surgery. So we have to identify the location of the motor strip. Yeah, and then we take one strip behind that. So in this case, we decided to resect and use the superficial vein as the landmark. And during surgery, we will identify it easily. Sometimes we use a navigation also, which could help us in terms of localizing the target and the sulcus, as you can see here. And the technique usually we start with, there is 2 ways. Either you do resection from here, or for ours, we like to go from the temporal area. We started with the ATL, okay, and then we follow upward, as you can see from this. And most important thing in the TPO, we have to resect part of the splenium, and we have to reach the deep vein to indicate this is the end of the resection for the upper part, and followed by the temporal disconnection. Okay, sometimes we use SACP in cases in order for us to identify exactly the location of the central sulcus, and then from there we can easily objectively determine our line of resection. As you can see, this is a phase reversal, then you know where is the location of the central sulcus. So as you can see here, so this is the location of the central sulcus that we identify pre-operative and intraoperatively, and we take one cortex behind that, and this is our line of resection and deepen, and subsequently we continue with the resection from the temporal side. Okay, this is how it looks like at the end of the disconnection, and this is post-op MRI control to confirm the line of the resection. And these kids, for some reason, she developed post-operative intraventricular hemorrhage. They have to go in to evacuate the hematoma, and we remove the shunt and put EVD, and he was shunt-free, and subsequently also seizure-free. So this is a very rewarding surgery, as you can see. And the other part of the disconnection surgery we do is peri-insular functional hemispirotomy. We use a question mark incision. Okay, and then this is 7 steps as described by Daniel. Okay, we start with the ATL first, and then subsequently we try to open to the ventricle. We get to the foramen of Monro, and then most important thing, as we get into the ventricle, the resection of the colostomy is the second step. So we measure about 1.5 centimeter superior lateral to the foramen of Monro, and then sometimes we use a Doppler to identify the pericallosal, and we follow that disconnection just above the corpus callosum until the splenium and to the deep vein, and inferiorly we follow the pericallosal, and subsequently we complete with the frontal basal resection. And for the insula, we use a technique that we dissect below the cortex. This is much easier, and we can complete the insular resection by disconnecting and elevating this cortex. And then this is example of a case, a child with a left cerebral hemiatrophy secondary to vascular insufficiency, which probably he sustained during intrauterine life. The EEG shows that focal seizure lateralized to the right hemisphere with possible onset over the right central region. And then the MRI shows that hemiatrophy secondary to vascular insufficiency. We use the 3D surface reconstruction to help us to identify the surface marking before we start the resection. We also use neuronavigation in this case, and using a similar technique that we described before, we complete the functional hemispherotomy, and then immediate post-op, he had a seizure-free, just only a lid smacking, and then this is a control MRI post-operatively. And one of the problem or the risk that we take for hemispherotomy is usually the children will develop hemiparesis. But in our series, they recovered very fast. Of course, they will have some residual, but the muscle power usually improve over a period of months. So this is a beautiful if you do it in children, because their recovery are much faster. The final part is vagus nerve stimulation. So we have about a total of 26 cases, 20 in adult, and the indication as listed, majority for Lennox-Gastaut syndrome. We have implanted about 20 model 106 aspired SR and 6 model 103 demi-pulse. So we have quite a reasonable good reduction in these 20 cases in children. About 85% achieve a seizure reduction at least, but we only achieve more than 50% seizure reduction in 30%. And in terms of the quality of life, majority have some improvement. And in terms of the ILE outcome scale, achieve about class 4-5 in majority of the cases. So this is among example, Lennox-Gastaut syndrome. A child presented with a recurrent seizure. EEG shows a generalized discharge, and MRI shows unilateral gliosis, which is possible to offer surgery, either hemispherotomy. But unfortunately, the PET scan also showing that there are another some hemisphere involvement on the opposite side. So it's showing that we can't really localize the lesion. So therefore, VNS was offered. So I think in view of time, so I would like to summarize. So based on our limited experience, we found that MRI with the lesion is one of the best indication for epilepsy in children. And those with the perioperative investigation in localization, including EEG, CT scan, MRI, sometimes PET scan, and also the semiology of the epilepsy is very important in determining the indication of surgery. And the success of epilepsy program surgery in children depend very much on the collaboration with the multiple discipline team. And based on our experience, the results are quite promising. And we are looking forward to further collaboration, especially with our pediatric neurologists, to further the development of epilepsy surgery, at least in our hospital, in our country. So thank you very much, and thank you for your kind attention.
Thank you, Ms. Azmi, for the very informative talk on this. We shall proceed with our next speaker and the next topic. It's my greatest pleasure to introduce Associate Prof. Dr. Vairavan. He's a Senior Consultant Neurosurgeon and Associate Professor in the Neurosurgery in the Faculty of Medicine of University Malaya. He's a very well-known figure in our local Society of the Neurosurgical Association of Malaysia, and he actually completed his training with the Royal College of Surgeons Edinburgh in 2011, followed by his honorary fellowship in epilepsy surgery with the National Neurology and Neurosurgery Hospital in London. Without further ado, it's my greatest pleasure to have Prof. Vairavan with us to speak to us on the surgical treatment of temporal lobe epilepsy. Prof.
Thank you very much, Siwun. First, I'd like to thank the organizers, especially Dr. Azmi, for having me here to share some of my insights. Dr. Azmi asked me to speak about specifically about temporal lobe epilepsy, but both Dr. Ahmad and Azmi have actually made my life easier because they have covered most of the basic ideas about epilepsy itself. Ahmad did a very good job in telling us why the issues with epilepsy as well as drug-resistant epilepsy. And Dr. Azmi has shown us all the various modalities available for epilepsy surgery. So I'll briefly go through my initial introduction slides. I think this has been already made clear by the previous two speakers. Temporal lobe epilepsy, it's a recurrent unprovoked seizures originating from the medial or lateral temporal lobe. It is very important for us to classify the type of seizures as shown by Dr. Ahmad. And while temporal lobe epilepsy is the most common form of focal epilepsy, we must understand based on long-standing literature that medical management, while it can reduce seizures, does not completely make it controlled. On the other hand, epilepsy surgery, there's been numerous trials which has actually shown epilepsy surgery is actually has got a very high seizure-free rate if it is done appropriately. And this is the reason why surgery for temporal lobe epilepsy should be offered. As Dr. Azmi informed earlier, epilepsy surgery actually improves both the quality of life as well as neuropsychology, and it minimizes the physical injury, the complications associated with AEDs, and in children, sudden unexpected death. These are things that will be improved with surgical intervention. It is very clear from literature that surgery gives better seizure-free outcome compared to medically treated patients. This was a very important trial and probably one of the first randomized controlled trials in epilepsy surgery done by VB and published in NEJM in 2001. And it provided very robust and precise estimates of the effectiveness and safety of surgery for patients with temporal lobe epilepsy from any cause. And it also showed that prolonged trials of anticonvulsant drugs are futile. This is, I've actually taken this paragraph directly from the article, and it very clearly says prolonged trials of anticonvulsant drugs are futile. Patients with temporal lobe epilepsy should be evaluated for surgery and offered surgery if they fulfill the criteria. This was in 2001. Have we actually improved since then? Unfortunately, the surgical gap remains and the number of surgeries has not really improved significantly. Another randomized trial, this time by Jerome Engel in Canada, the ERSAT trial, was published in JAMA in 2012, again showing very clearly 0 out of 29 participants in the medical group had seizure freedom, while almost 75%, 11 out of 15 participants in the surgical group were seizure free. And since then, there's been numerous prospective trials and numerous trials which have shown that epilepsy surgery is relatively safe and is relatively cost-effective as well as clinically effective for the patients. Despite that, there is a significant surgical gap. In our own series in UM, this is between 2012 and 2015, we evaluated 647 patients, of which only about, sorry, I think this is, everything has come up at the same time. Only about 459 patients were suitable with focal epilepsy, and 191 were refractory. Out of this, we offered surgical evaluation for 73 patients. That's almost 40% of our patients, but only 40 patients. So you can imagine from 647, we have only 40 patients who underwent surgery over a 3-year period. And there is a significant surgical gap. This surgical gap actually happens all across the world, whether it's US or India or China. And this is usually due to a referral gap or anti-epileptic gap, evaluation gap, a cost gap, facility and expertise gap, as well as patients and the referring physicians being averse to surgery due to unrealistic complication ideas. What can we do to make this whole process easier? We have to provide the optimum outcome for our patients with epilepsy. To do that, there are 5 criteria. You have to have appropriate selection of patients. Dr. Ahmad told us the ILAA criteria, which is patients who have failure of adequate trials of 2 well-tolerated and appropriately chosen anti-epileptic. You must have appropriate and concordant investigations. Again, this was very clearly defined by Dr. Ahmad earlier, the semiology, EEGs, whether it's in the form of standard EEGs, video EEGs, stereo EEGs, as well as magnetoencephalograms, imaging, MRI, PETs, PACs, neuropsychological assessment. All of this must be appropriate and concordant. The surgical approach must be appropriate, whether you want to do a resection, you want to do a selective resection, a disconnection, ablation, or a palliation. This must be chosen appropriately. You must have the appropriate surgeon who is both safe and experienced, who has got a good knowledge of anatomy, as demonstrated by Mr. Azmi. You need to know what you're doing, and you cannot be dependent on adjuncts like image guidance. While they may be useful and they may increase your safety, they must not be the only way for you to identify the anatomy. You must be very clear about the pathology and the surgical options, outcomes, and complications. And finally, an appropriate team is always very, very important, because epilepsy surgery is not a one-man show. It's not simply something you go in and resect as a technician and come back. You have to have a good epileptologist, neurophysiologist, neuroradiologist, neuropsychologist, and preferably a nurse practitioner or a patient advocate. This is how we optimize the outcome of our surgical patients, and this is how we convince both the patient and the referring physicians that these surgeries are good and we can reduce the surgical gap. So let's move on specifically to the functional anatomy of the temporal lobe. The temporal lobe consists of both a neocortical gray matter as well as white matter, the lateral ventricles, the tail of the caudate nucleus, stria terminalis, hippocampal formation, and amygdala. And the functions of temporal neocortex include auditory, olfactory, vestibular, visual, and perception of spoken and written language. The medial side of the temporal lobe is it includes regions that are concerned with olfaction, especially in the uncus, as well as semantic memory in the hippocampal formation. And the amygdala, it generates the responses to perceived sensory stimuli, the ancient fight and flight response center. So these are, we need to know the functions, because we need to be able to predict what are the outcomes going to be if we do resect certain areas in this region. Let's move on. The amygdala and the mesial temporal region, as we can see from this diagram, is a deep-seated region and is surrounded by multiple important structures. Other than the vascular and neural structures like the posterior cerebral artery and the optic nerve, which are in the ambient system here, the border of the amygdala is not very well defined, especially if you look here, this green area is the amygdala, the cortico-medial as well as the basolateral amygdala structures are not well defined. There is no actual line or visual identification. So differentiating them is usually a little bit more difficult. This is important because our resection should not breach the corticomedullary or the central regions of the amygdala. And we would like to stay at the basolateral segments. Of course, you also want to make sure the mesial resection is limited below the temporal stem, as well as does not affect the tail of the caudate nucleus. While the previous pictorial diagrams and cadaveric pictures are nice to look at, the planning for surgery is usually done based on imaging. And we frequently, as surgeons, use MRI imaging. The hippocampal anatomy is usually quite clear once you know what you're looking for. In this case, we are looking at the axial T2 and the coronal T2 images here below, while this is a sagittal empirage image. And we can see here at the top, the hippocampal head labeled 1, hippocampal body, which usually curves around the ambient system and the midbrain, and finally the hippocampal tail, which is usually behind the midbrain. And we have got number 4, the midbrain or mesencephalon. And if you look at the sagittal segments, you can see the amygdala slightly anterior and above the hippocampal head. Looking at the coronal sections, you can see the hippocampal digitations as well as the temporal horn of the lateral ventricle and the uncal recesses. The hippocampal formation itself, the hippocampal formation itself is actually a very beautiful and complex structure. As you can see here, again, a coronal segment of the T2 MRI, we can see very clearly that starting from medial, so this is the medial and this is the lateral. So starting from the medial segments, which we would find the midbrain here, we'll start with the tail of the caudate nucleus, and then moving on, you've got the temporal horn of the lateral ventricle. This is the collateral sulcus, which is a imaginary line, but it's usually the line used for resection margins. And then we have got the parahippocampal gyrus. Medially, we have got the ambient system, followed by the midbrain here. And the ambient system contains very important neurovascular structures, including the basal vein of Rosenthal, the posterior cerebral artery, and the branches from the posterior cerebral artery. This is the choroidal fissure, and the hippocampus itself is made of subiculum as well as the corna ammonis from CA1 to CA4, finally ending up in the dentate gyrus. The arterial supply to the hippocampal body, it's a very, very important anatomical structure for us to learn before you start doing enteromedial temporal lobectomies or any sort of temporal lobectomies, mainly because the hippocampal blood supply is from 3 arteries, which supply the head and the body. The head itself, if you look at this, is the artery is actually anastomosis between the branch from the anterior choroidal artery as well as the anterior, as well as from the posterior cerebral artery, and it supplies the digitations. This is important to identify because as we are doing the subpial resection, we have to visually identify this branch and coagulate and secure this artery before we continue dissection. Similarly, the body and tail is supplied by 2 branches from the posterior cerebral artery, one in the middle and one in the posterior. Next, we are moving on to the common pathology in the temporal lobe. So among the common pathologies are mesial temporal sclerosis, as we can see here, the image here. On your left-hand side is the sclerosed mesial temporal hippocampal formation, which is looks much more atrophied. It is slightly brighter on T2. And the internal structures, the digitations and formations are obliterated compared to the right-hand side. On the other hand, when we have got other structures like gangliogliomas and DNETs, the tumor is usually a little bit more clearer because it's actually expanding the mesial structures, and usually this is something we are used to seeing, so we will be able to pick it out a little bit easier. Of course, most of the tumors within the mesial temporal area are usually low grade and they don't pick up contrast very well. Moving on to the surgical options for temporal lobe surgery. There are multiple different options that have been developed over the last 70 years. And this has been developed by many giants in our field, from Penfield to Yasagil to many great surgeons. The standard resection has always been anterior temporal lobectomy, which includes neocortical temporal lobe resection as well as mesial temporal resection. The various different approaches here, the standard anterior temporal lobectomy, electrocorticography tailored temporal lobectomy, as well as enteromedial temporal lobectomy, differs in the extent of neocortical resection. The next group of resections is usually selective amygdala hippocampectomy, which again are different from anteromedial temporal lobectomy in that the neocortex is preserved and only the amygdala and the hippocampus is removed. And in this case, again, we have got three common types of selective amygdala hippocampectomy. The first one is a transcortical, usually via T2. The second one is transsylvian, splitting the sylvian fissure. And the third one is subtemporal, usually through the parahippocampal gyrus. Of course, in recent years, we've developed temporal lobe disconnection as well as hippocampal transection. Dr. Azmi did show us a temporal lobe disconnection earlier. Hippocampal transection is a very esoteric approach done a lot by the Japanese surgeons in cases, especially bilateral mesial temporal sclerosis, where they do not want to remove the mesial temporal structures. And finally, we've got the ablative procedures, which include radiofrequency ablation, laser interstitial ablation, and radiosurgical ablation of the hippocampus. I will be concentrating on the first two common approaches for temporal lobe surgery. So moving on to the anterior medial temporal lobectomy. I think again, Dr. Azmi has shown us anteromedial temporal lobectomy. The incision is usually in the temporal area, and the incision can be as big or as small as the surgeon is comfortable. And I would suggest to start with a standard large reverse question mark incision to provide safe access to the temporal lobe, especially for the new surgeon who wants to be safe and be able to see all the structures very clearly. The maximal lateral resection, as can be seen here, depends on the dominance of the lobe. It can go up to about 6 centimeters in the non-dominant and up to 4 centimeters on the dominant side, with the vein of Labe, which usually runs being the definitive lateral limit. You cannot go beyond that. Mesially, we would expect at least 2 to 3.5 centimeters of the amygdala or hippocampal complex to be removed, starting from the uncus to the amygdala all the way down to the body and tail. So the position of the patient is usually in a Mayfield clamp at about 45 degrees to some people put the patient on 90 degrees. And again, the actual, in this day and age, with the table being able to rotate, the actual head angulation is not so much important as flexing the head and making sure you're able to see the base of the temporal pole. And once the temporal lobe is opened, we should be able to see the sylvian fissure labeled 1 here, as well as the central sulcus and the precentral sulcus here. So this will be T1, this is T2, and this is T3. One of the nice instruments to use in temporal lobe surgery is the Penfield dissector. It may be a very old instrument, but it's probably still one of the best instruments, and which I commonly use in these cases. So the first step I would use is use the Penfield dissector to measure the lateral resection from the temporal pole, depending on the dominance. And subsequent to that, again, as shown by Dr. Azmi earlier, the lateral neocortical resection can be either through the T1 or T2. I prefer T2, all the way down to the collateral sulcus, up to the temporal horn. This will be the first step of the surgery. Once the temporal horn has been removed, we would then be facing the mesial temporal structures. In this case, the temporal horn will give us access to the hippocampal head and the amygdala. And the hippocampal head and amygdala can be removed either en bloc or piecemeal, again, depending on the safety issues as well as the access and the experience of the surgeon. Removing it usually piecemeal is safer than removing en bloc, as you might end up doing too much retraction, and frequently most complications for temporal lobe surgery comes from retraction injuries. So moving on to the next type of surgery, which is a selective amygdala hippocampectomy. The selective amygdala hippocampectomy is, as I mentioned earlier, different from the anteromedial temporal lobectomy in that it preserves the neocortex. And the reason for preserving the neocortex is to reduce the complications, especially involving semantic and verbal memory. And usually it is done, as I mentioned, by 3 techniques. One is a transcortical. In this case, we are showing a T2 access directly into the temporal horn, and then removing the hippocampus, head, and the body. The alternate ways would be subtemporal, in which case the incision is usually done above. It is a L-shaped incision starting from the base of the ear all the way behind the ear, and we would approach it from the parahippocampal gyrus all the way into the temporal horn. This is not very frequently done. The other selective technique would be transsylvian, in which comes completely away from neocortex. The beauty about transsylvian is we do not have to touch any of the neocortex, and it goes once you've split the fissure, you're directly onto the surface of the hippocampus. The downside of doing a transsylvian is there's a very steep learning curve. You have to be very careful not to cause any vascular injury in this process. So we did, when I first came back in 2012, I did do both anteromedial temporal lobectomy and selective amygdala hippocampectomy, especially between 2012 and 2016. We did 24 AMTL and 16 selective amygdala hippocampectomies. At the end of 2016, we did a analysis of our patients, and we found that I had 87% angles 1 and 2 with the anteromedial temporal lobectomy, compared to only 56% angle 1 and 2 with the selective amygdala hippocampectomy. Of course, the complications in AMTL was much higher. I had close to about 8% complication rate, including verbal memory, naming, bitemporal quadrantenopia, which was quite common in this approach, compared to no quadrantenopia at all in selective amygdala hippocampectomy, but there was some patients with verbal and naming issues. When we reanalyzed it, the bitemporal quadrantenopia, as much as it is significant on a eye visual field test, it was not functionally limiting the patient. And looking at the outcomes here, 87 versus 56, since 2017, I've almost exclusively been doing anteromedial temporal lobectomy, currently with about 63 patients since 2017. We have got a 69% angles 1 and 9% angles 2, which is about 78% good outcome in these patients. We've also been doing some frame-based SEEG insertions. Again, both for patients with multilobar electrode insertions as well as bitemporal electrode insertions. These are almost frequently for patients who have got, who we are unable to localize, and we want to, and the MRI imaging shows bilateral temporal, mesial temporal sclerosis or atrophy or abnormalities. So in our series, we had 8 patients with bilateral TLE, and 6 of these patients underwent surgical resection. 5 of them had angle 1 outcome and 1 had angle 2 outcome, which is 100% angle 1 or 2. This is usually how we do it. So the standard method of bitemporal SEEG insertion is standard 6 electrodes, 3 on each side. Due to cost issues, we reduced it to simplified 2 electrode method, 1 on the right and 1 on the left, and it gave us a reasonably good outcome. As you can see, 100% angles 1 and 2. Recently, we did 2 cases with occipitotemporal electrode insertion, which tries to cover the whole hippocampal formation from the body all the way to the head. I think I'll skip this. Based on the surgical outcomes from selected studies, we actually, this has been studied multiple times in multiple papers, and the outcome varies from center to center, anywhere from as low as 58% for ATL up to close to 75%, both for ATL. Again, for selective amygdala hippocampectomies, it varies from about 60% to close to 70 odd percent. When compared end to end, corticoamygdala hippocampiectomy with selective amygdala hippocampiectomy, the general seizure outcome was similar. A couple of studies, McKenzie as well as Bate et al. Did show that cortical amygdala hippocampiectomy was better than selective amygdala hippocampiectomy, especially in children. This is a general outcome for temporal lobe surgeries. In appropriately selected patients, we would expect an angle 1 class outcome in 70 to 80% of patients at 2 years. However, this has been shown to drop to about 50% at 5 years. And this has been shown in multiple different systematic reviews and meta-analyses where it doesn't matter where the surgery was done, whether it was London, Melbourne, Philadelphia, India, China. They, for some strange reason, the outcome of temporal lobe surgeries always at about 5 years stabilizes at about 40 to 50%. And why does this happen? Causes of temporal lobe seizure surgery failures. It's probably due to incomplete removal of the causative lesion, incomplete mesiobasal resection, or sometimes bitemporal seizures, as well as frequently extratemporal seizures involving the frontal lobe as well. The complications due to epilepsy surgery. This was a very interesting paper published in journal Neurosurgery in 2014, which looked at 5,600 patients over 32 years. And they looked at it from 2 periods, 1980 to 1995 compared to 1996 to 2012. Just looking at the temporal lobe outcomes, we can see very clearly that there is a significant drop in the complication rate, both the transient deficits, which have dropped from 41% in the first period to 5%, as well as permanent deficits, which has dropped close to 10% to less than 1%. The other complications like wound infections, hematomas, and CSF related, they have dropped, but not very significantly. The more important one would be the permanent deficits, which have dropped from 10% to 1% currently. This goes to prove that temporal lobe surgeries are relatively safe in appropriately selected patients with a safe surgical environment. What about the other options I spoke about, radiofrequency ablation? Again, these are all developing approaches in that this has only been happening over the last 10 years. And we have seen SEEG guided radiofrequency improves epilepsy in 50% of patients with a seizure control of more than 50%. And it is a safe procedure with a very small complication rate of 1.1%. In UM itself, since 2016, we've been doing radiofrequency ablation, usually frame-based CT-guided ablation. We've had 9 patients, 4 with hypothalamic hematomas, 4 with mesial temporal sclerosis, and 1 with posterior focal cortical dysplasia. The 4 patients with mesial temporal sclerosis, 3 we were unable to localize. They were bilateral mesial temporal sclerosis. We were unable to localize, and we decided to ablate the region we thought was most likely the causative region. And we have had 75% angle 1 and 2. One patient failed the radiofrequency. This for a relatively semi-invasive procedure, this is actually a very good outcome in these patients, but this is only for a very limited group of patients. Radiosurgery, not much has been done in this region, and even worldwide, it's still a very developing field, but there has been some very encouraging signs that radiosurgery may be very useful for mesial temporal sclerosis and temporal lobe surgeries. Similarly, another exciting development has been laser ablation therapy or laser interstitial ablation. This has been widely being used in US currently, and they've already done more than 800 patients in the US in the past 5 years, and they've found reasonably encouraging results for both seizure outcome, which is similar to surgical resection, and complication rates, which is similar, if not less than surgical resection. So eventually, we may all end up doing something like this when this technology becomes available widely. Of course, cost is going to be a limitation because laser interstitial ablation is MRI guided, and the cost of actually doing the ablation therapy is quite prohibitive currently.
Prof, sorry to intervene, Prof. We are just running slightly behind time already.
Yep. Okay, I'm finishing my last slide. So
Okay,
coming
thank
back
you.
to the requirement for an optimum outcome in our patients, I just want to reiterate, it must be appropriate selection of patients, appropriate and concordant investigation, appropriate surgical approach, appropriate surgeon, especially a surgeon with safe experience and with adequate anatomical knowledge, and an appropriate team. I did not mention this earlier, but this is actually very important to have an appropriate team. This is my team in UMMC, and we work as a team, and without the team, I don't think we'd be able to provide any of the services I've been discussing about. And finally, thank you to the organizers for letting me share my presentation today. Thank you.
Thank you, Prof, for the very insightful talk. We shall leave the Q&A speaker. So without further ado, I would like Krishnai. He's a senior for the Royal Melbourne Hospital, and his subspecialty is actually in functional neurosurgery for deep brain stimulation and pain. So without further ado, I will have Dr. Krishnai to talk to us about asleep deep brain stimulation. Doctor, the floor is yours.
Dr. Woon, thank you very much for the kind invitation from all of you and for your moderation. Once again, a big thanks to AASME for putting this fantastic show. It's been certainly a feast with regards to the quality of talks that have come through. My interest is, I like most of us practice the whole spectrum of neurosurgery, but I have a specific interest in functional neurosurgery. And with regards to functional, I do mostly deep brain stimulations and also pain procedures. I just want to take you on a journey of what DBS is and what DBS can do in movement disorders, and what have been what I see as significant changes in how this has evolved over time. So DBS patients with Parkinson's can look like this, where you have a gait freeze, you have gait arrest, you have a significant festination, camptocormia, all of that. But at times it can even just look like that, just as a tremor. So that's a whole spectrum of what Parkinson's can look like. But why does it happen? Well, we are well aware that Parkinson's happens because of depletion of dopamine. And when it's depleted by more than 60 to 70% of what we require, it leads on to symptoms like akinesia, tremors. And of course, those are just the common physical manifestations. But we know that then it does progress on to psychological and psychiatric and other associated side effects as well. It is one of the most common neurological disorders that affects about 1% of the population over 60 and has a worldwide prevalence of about 120 cases per 100,000. Now, of course, we all recognize that different medical systems and different access to medical systems is quite variable, and hence why there is about significant variation in how the prevalence is reported. But interestingly for DBS, the American Association of Neurologists calculates that about 10 to 20% of patients with Parkinson's disease are eligible for deep brain stimulation. But most of my colleagues who do this type of work would agree that we certainly don't see these type of numbers coming through to have surgery. And there are many reasons for that. So the bread and butter, or the most common line of initial treatment of Parkinson's disease, is what is described as best medical therapy. And it's important to recognize that best medical therapy does not mean putting a patient on dopamine replacement medications. Like I said before, as Parkinson's progresses, it has a whole spectrum of symptoms that come along. And hence, in the ideal world, best medical therapy includes medication, which is actually a small component, but it includes the neurologist, the neurosurgeon, the psychologist, the speech therapist, a dietitian, occupational therapists, physiotherapists. I mean, it's a whole complement of people working together as a team to treat these patients. But when there is advanced Parkinson's disease, then the advanced options that are available include DBS, apomorphine infusion, and now MR-guided ultrasound is getting more and more popular. And certainly we also use the intestinal gels. Cell therapy and gene therapy are certainly research options and not yet into mainstream treatment. When we talk about DBS, DBS for Parkinson's disease, in the way we know it now, was ushered in by Professor Benebit. And this has been an established modality of treatment for over 20 years with a well-established safety profile as well as an efficacy profile in the well-chosen patient. Certainly hardware availability has been a friend, and the technological advancements in the wires and the battery that we have now has certainly changed the way we practice deep brain stimulation. So what is it? Well, it is a neurosurgical procedure that involves placement of electrodes into chosen spots in the brain, where we deliver stimulation through an implantable pulse generator in a reversible manner. And that is important because that also allows us to open up this sphere to research options, because you can have blinded studies then. Big question is, does it work? Well, it does, and it works really well in the well-chosen patient. So usual effects that we see from a DBS is patients getting on average between 4 to 5 hours of what is described as symptom-free or symptom-controlled period without dyskinesias. There is certainly significant improvement in the patient's ability to participate in activities of daily living and improvement in quality of life. Of note, in a patient who responds to subthalamic nucleus DBS, on average, there is about a 30 to 60% reduction possible in medication as well. Like I mentioned a few times in the previous slides, a selection, like for most surgical procedures, is the key. And that is why a multidisciplinary model is most important. Patients need to have a confirmed diagnosis of Parkinson's. And it might seem pretty straightforward, but then there are many mimickers of Parkinson's. And if those patients are selected for DBS, it ends in disappointment all around. So diagnosis is done, and then patients usually stay on their medical treatment, and they become candidates for considering DBS when they start getting less responsive or start getting adverse effects to the medications, or more importantly, or rather more commonly, patients start experiencing motor fluctuations, wherein there is an unpredictability of how well, how completely, and how long for the symptoms may be controlled on medications. This unpredictability, as you can see, causes significant problems for a patient. The main thing when working up a patient for deep brain stimulation is to absolutely be certain that the patient was, and continues to be responsive to dopaminergic therapy. Because when we hold a conversation with a patient, if it is someone who has absolutely no response to dopamine therapy, even for brief periods of time, when we do the dopamine challenge test, it's unlikely that they will have a great response to deep brain stimulation as well. Important to remember that the mindset and thinking of clinicians and referring doctors has to change, and this is not considered as a last option anymore. This paper, which reported the early STIM trial, clearly demonstrated that in younger patients who have early onset of motor fluctuations actually do better with DBS than continuing on medical therapy. So when considering DBS, two conditions that used to be laid down was that one, the procedure needs to be done awake, and second, microelectrode recording or done intraoperatively was mandatory. But what is the reason for that? The reasons are, one, we needed to sort of confirm indirectly that we were in the right place based on MER. And then with stimulation, we needed to be able to confirm that there is a good efficacy or good response. And this was all because we couldn't really see the target that well. It is important to remember that our imaging has evolved so much, as we all know, over the last 20 years, but DBS has been in place for longer. So is it valid that we continue the practices that we put in place when we did not have imaging of the kind of quality we have now? So this is a kind of images of which DBS used to be done, where forget the subthalamic nucleus, you barely can make out anything at all. But then we have these images where you can see the subthalamic nucleus, you can see the red nucleus, and everything is quite clear. So is there a need for intraoperative electrophysiology just to confirm that you're in the right place and that the procedure is working? What is the evidence? This is a paper that looked at a long-term experience that came from Richard Sherman's group, looking at microelectrode recording in subthalamic as well as GPI for DBS. And the important thing to note here is that in their paper, they found out that it is not the position of the best electrical activity where you got the best clinical response. So they were two very different things. So you choose a spot based on anatomy, and that seemed to be more valid than what you're choosing based on your MER. This is another paper which looked at what is the factor that defines your outcome. And the results indicated that choosing the right dorsolateral part of the subthalamic nucleus based on anatomy on T2 weighted MRIs seemed to be the best predictor of response. This is a paper that was actually looking at awake versus asleep DBS, but as a side part of the resulting reporting, they also reported about the number of passes that you require to get the right spot and what that means for the patient. So there was a significant difference in symptomatic or asymptomatic microbleeds and intracerebral hemorrhages, which were a reflection of the number of passes you made. And there is also some data available that indicates that the number of passes you do does seem to have an impact on the cognitive outcome following these procedures. So if MER is so good and microstimulation is so confirmatory of choosing and getting the best response, surely none of these patients ever have a problem in the future. Apparently not. If you were to go by this paper, which looked at 28,000 procedures done in the US, of which close to 90% were done with microelectrode recording, there was close to about a 1 in 3 electrode revision rate. So that's sort of, with all the bells and whistles of you're doing, it still has such a high revision rate. And half of these were said to be because of improper targeting based on anatomy. So that's significant. So what is an acceptable translational error when you place an electrode? Well, historically, it used to be between 2 to 3 millimeters, but current literature, whether you use the frame technique or the frameless technique, it has to be between 1 to 2 millimeters. And reported in literature and in our experience as well, if you do it with intraoperative MRI guidance, you should be able to get it under a millimeter. So framed versus frameless. On the right side is where your traditional Lexel and the CRW frame. And then you have the next frame from Medtronic. But what we use in our practice is the Starfix, which is a customized 3D printed frame, which is patient specific and is made by a company called FHC. There are a lot of literature comparing the accuracy, which obviously by now we know that it is the key in terms of getting good results. And technology has been the biggest friend of improving outcome. So when you combine accurate anatomical placement based on your MRIs, and then you're able to evaluate them on precise positioning with intraoperative CT scans, the outcome is much improved. And this has certainly changed our practice. Coming to the asleep versus awake argument. Yes, you get it right anatomically, and yes, you've done the CT scan, you've compared sort of your pre-operative planning and your intraoperative CT. And if you get it in the right spot, does it compare with the results of awake DBS? Apparently, yes. And in some papers, it's even reported that the results are possibly even a bit better, especially with language function, etc. So awake DBS is probably not as strongly indicated now, considering that you can do the same procedure with the same accuracy with equal or better outcomes as per the current literature. In our workup, we also use the PKG, which is the Parkinson's kinesiogram, which is basically a watch that we give the patient. So as you know, most of our assessment of responses in a majority of practices around the world is based on the UPDRS scoring and the motor scoring on the motor component of that, which is sort of valid and has been validated through, but it is a subjective assessment and not a objective or quantifiable entity. We find the PKG quite useful in that we use this on our patients for about 7 days before the surgery, and it gives us a lot of data in terms of dyskinesia time, bradykinesia time, what the summary of tremor is, and this is can be timed in terms of how much was the tremor changing and for how long after the medications were taken, and how much time does your patient spend immobile, etc. So we use this pre-op, and then we use this also on our DBS patients post-op, and gives us a good objective assessment of the response to the therapy. How we do it now, used to do it is on the left side, where we used to use the frame, but what we do now is with this frameless system. It's called the frameless system, but as you can see, it still has a frame. And the main benefits I see for this is that it is one, it's patient specific. Second, because of the way it's constructed, you can actually operate on both hemispheres at the same time. And this has an implication because we spoke about translational error before. And one of the major aspects that can contribute to translational error is loss of CSF, which indirectly is a reflection of for how long the dura is exposed and the CSF is draining out. So when you can do both hemispheres at the same time, you're also significantly cutting down your operating time. Another huge advantage is when we used to do it with the framed approach, when you put this patient in a CT scanner to do an image fusion, there used to be a lot of work we had to do to get good images without cutting out all the metal artifact. Now this material, because it is non-metallic, the quality of images is absolutely fantastic and the fusion's much better. So this is the MER, and this is what a subthalamic nucleus will sound like. We used to do this a lot previously, but we've sort of moved away from this a bit now. And this is what we do at the end of the procedure. So patients straight away wheeled into the CT scanner. And then as you can see, even before the final position is locked in, we do the intraop CT and do an image fusion straight away and get confirmation that we have put the wires in the anatomically acceptable position within 1 to 2 millimeters accuracy. And then we finish the procedure. There's, of course, a post-op image fusion done as well once the pneumocephalus and all settle. And then this is how things can change. So this is the same patient, sort of about close to 6 months after the initial surgery. So yes, surely we can say that, you know, on the right side, it's not perfect. But when you put these images side by side, you can see the remarkable difference it brings about. So thank you very much for your attention. And I hope I have been able to show you some evidence that DBS is effective, and certainly in Parkinson's patients, by making this procedure available to patients where they do not have to stay awake when someone's drilling into their head. It makes for a better patient experience, more acceptable to patients without compromising on the outcome. Thank you very much.
Thank you, Dr. Girish, for the very beautiful presentation. I think we have a question from my co-moderator, and the question is actually, is there any differences in surgical strategy for mesial temporal epilepsy versus neocortical temporal lobe epilepsy? And I think Prof. Varavan has already answered that in a Q&A session. Prof, do you want to add on a little bit more on that?
Basically, the question asks about neocortical versus mesial cortical. The thing with neocortical is, as long as it is lesional, removing just the neocortical lesion is safe. The problem is when it's non-lesional neocortical, at which point the identification becomes a little bit more difficult. Going in to remove just a non-lesional neocortical may actually leave the patient with residual seizures, and then you may have to come back in to remove the mesial cortical. So those are the kind of cases. Usually what I would do is I'll actually do a SEEG or a temporal EEG, temporal depth electrode, and measure the activity of the this one, or either that, or I do a electrocorticography guided resection. I hope that answers the question.
Thank you, Prof. Ms. Azmi, do you have anything to add on top of that?
Yes, obviously. Based on our short experience, we follow the MDT decision and preoperative workout. So usually, if a lesion, for example, tumor that you can diagnose preoperatively with MRI, for example, DNET and localized to the neocortex, you just need to address the lesion, which is neocortex. You do not need to resect the mesial component. But if it is other causes, for example, like hippocampus sclerosis, based on the data, some people do selective amygdala hippocampectomy versus ATL. I think Varavan also shows that local result. I think better to do ATL. I've been in many meetings, and the consensus is majority we go to ATL, main neocortex and mesial component resection, to get a better result in terms of epilepsy surgery. Even though the first one, selective amygdala hippocampectomy, seems to be very focused, minimally invasive, but the control rate of seizure is not as good as ATL. But of course, in adult compared to children, you have to do preoperative assessment by the neuropsychologist, testing, memory, all those things are very crucial. So pediatric slightly different because we don't have that ample to do that, but we depend on, interestingly, because my partner, Dr. Ahmad, like to do a lot of PET scan. Probably he's from Melbourne, so they do less invasive localization technique. And a PET scan, in our first few experience, we do routinely, and we see if the entire temporal lobe low uptake of the FDG, then we do ATL. You know, even though sometimes mesial temporal, what they call it, hippocampus sclerosis, the EEG maybe show some subtle changes, MRI also subtle changes, but interestingly, the PET scan shows the whole lobe is hypometabolism, so we do ATL. So that is give us a confidence. And for neocortex, I agree with Varavan, sometimes we do intraoperative ECOG. So it will guide you whether you have completely resect if you just want to focus on the cortical resection. And yes, depth electrode useful also if the lesion go deeper. So I hope that answer the question. We have two cases where you just do temporal neocortex resection because both are tumor case. And all HS in our series we do ATL, enteromesial. I hope that answered the question.
Thank you, Mr. Azmi. I think we have one more question from Prof. Zamzuri to Dr. Girish. This is in regards of the quality of the MER for the deep nuclei. Will it be affected by general anesthesia?
So no, the short answer to that is yes. I mean, it can affect it, but we've been sort of doing this sleep DBS for close to 5 years now. And it really comes down to having a good anesthetist who understands what your needs are. We need the patient to be asleep and comfortable, but there are many anesthetic protocols available around the world. Different people do different things. But in our setup, what we found is when they avoid sort of propofol and midas and all of that as part of their IV anesthetic protocol, the quality of MERs is still very good.
Okay, thank you, Dr. Girish. I think there's no more questions from the floor. And with this, I would like to conclude this session. And on behalf of the organizing committee and my co-moderator, we would like to thank you again, all the speakers, for their wonderful presentation. And with this, I pass the floor back to the organizing committee. Thank you.
So meanwhile, we shall proceed to the most important session, which is group photo of this section. So we hope all the moderators and whoever in the panelists who would like to join us. So count on Nadia, is it?
Yes, me.
Okay, Dr. Ahmad is there. Thank you for joining us. So let us know when should we smile.
Give me a second here. Let me pin Dr. Ahmad first. All right, okay. On my count. 3, 2, 1, smile. Okay, one more time. 3, 2, 1, smile. Okay, thank you.
Thank you very much.
Thank you, Girish.
Thank you.
Thank you, Dr. Azmi.
Thank you, Vairavan.
Thank you very much to our esteemed speakers and also to our moderators. So with that, we've concluded the second section, which is on epilepsy and DBS. Without further ado, let's move on to our third session of the day. The theme for this session is vascular neurosurgery, and the moderators for the first half of vascular neurosurgery session will be Mr. Dinesh Kumaran from Hospital Kuala Lumpur. So with that, I'd like to invite Mr. Dinesh to proceed with the session.
Thank you, Dr. Louis. Good afternoon, fellow speakers and participants. We now will start the vascular symposium. We will discuss and debate on the common vascular disorders in pediatric. The vascular pathology in pediatric age group is different from adult, and so do the management. Without spending much time, let me introduce our speaker for the symposium. Our first speaker will be Dr. Lim Mei Sin from Malaysia. Dr. Lim Mei Sin is a young neurosurgeon currently working at Hospital Kuala Lumpur, Malaysia. She will present on stroke in pediatric age group overview. Dr. Lim Mei Sin.
Thank you, Mr. Dinesh. Good afternoon to all who are present here today. And thank you for joining our Zoom webinar on this lovely weekend. I'll be presenting on stroke in pediatrics and overview. In this overview, I'll be discussing about WHO definition of stroke, the common clinical presentations and risk factors that come with it, the types of stroke in pediatrics, how do we diagnose them, and lastly, management in neurosurgical emergency. So kids do get stroke too. In fact, with an estimated incidence of 13 per 100,000 population worldwide. And by WHO definition, stroke is a neurological deficit that is caused by an acute focal injury of the CNS system, which is caused by the vascular cause, include a cerebral infarct, intracerebral hemorrhage, and subarachnoid hemorrhage that lasts for more than 24 hours. There are two ways to characterize pediatric stroke, either by age or the type. It can be hemorrhagic or ischemic infarct, and by age, 28 weeks of gestation to 28 postnatal days of life, we term them as perinatal stroke. And after 28 days to 18 years of age, we call them as childhood stroke. Arterial infarct accounts for at least 80% of perinatal strokes, and others such as cortical sinus venous thrombosis or hemorrhage. SAH and IVH would be more common in premature babies. Hemorrhagic stroke can come in the form of ICH, IVH, or SAH, and they make up about half of childhood stroke. Good news is prevalence rates for stroke in childhood in developed countries have decreased significantly, but only much more so for ischemic stroke as compared to hemorrhagic stroke. So in acute perinatal stroke in newborn infants, they present with focal seizures or encephalopathy. If in a delayed manner, they may present with early handedness or seizures. Childhood strokes are more apparent in their clinical neurological deficits, so they may present with hemiparesis and hemifacial weakness, and speech or visual disturbances, ataxia, others non-localizing symptoms such as headaches, altered mental status, and also fits. So the four common risk factors for stroke in adults, such as atherosclerosis, hyperlipidemia, hypertension, and obesity, do not necessarily occur in pediatrics. But atherosclerotic process that leads to ischemic stroke in adulthood may actually well begin in childhood itself. Proencephaly and intrauterine stroke have also recently been linked to a genetic mutation known as COL4A1. So there are several papers, especially important ones by AHA and ASA, that allow me to table up the risk factors that are associated with stroke in pediatrics. They can be divided into congenital acquired heart diseases, systemic hypertension, vasculitis, vasculopathy, hematological disorders, coagulopathies, and of course, to our interest, structural abnormalities of cerebrovascular system, and lastly, trauma. Ischemic stroke versus hemorrhagic stroke, how are they different? The ischemic stroke is dramatically higher in newborns, up to 6 times greater in children and then older children. Ischemic infarcts can be in the form of arterial or venous. Black and Asian children tend to have a higher incidence as compared to others due to risk factors such as sickle cell diseases, and of course, maternal risk factors that can cause ischemic infarcts, primary gravida, infections, emergency cesarean section, coagulation disorders, and of course, preeclampsia. Even their presentation may be different. At acute ischemic stroke, they present with focal motor seizures, epilepsy, asymmetric motor function, or early-handedness as compared to hemorrhagic stroke, where usually they are non-specific. 65% may come with seizures and almost all exhibit encephalopathy. I'll touch lightly on Moyamoya disease in acute ischemic stroke as it's actually quite prevalent and common in this side of the world. Children with Moyamoya disease may present with multiple transient ischemic attacks or silent infarcts, and the median age of diagnosis in pediatrics would be 7 years old. Imaging studies which are very important in the diagnosis of Moyamoya disease include MRI FLAIR and MRA, which are the gold standard to visualize the circle of Willis. And DSA may also help in the diagnosis of Moyamoya disease in pediatrics. And of course, this is a common classification, the Suzuki classification in Moyamoya disease. Ultimately, the management of Moyamoya disease in pediatrics will boil down to surgical revascularization, where we can be direct or indirect methods. With the goal in mind, we want to reverse the white matter changes, we want to improve the cerebral oxygenation, and we try to increase the cerebral blood flow while stabilizing the stroke burden. This is a case of a bilateral hypoplasia of ICAs who underwent a unilateral STA-MCA bypass, and intraoperatively, fluorescent dye was used to confirm the success of the anastomosis. And today, our interest will be on hemorrhagic stroke in pediatrics based on several papers, can be further divided into the causes of structural or hematological. Structural causes of hemorrhagic stroke in children can be aneurysm, AVM, AVF, cavernous malformation, and of course, spontaneous hemorrhage into tumor. Hematological causes can be inherited or acquired, bearing in mind that maternal risk factors, especially patients who have vitamin K antagonist medications during pregnancy, may also increase the risk of hemorrhagic stroke in pediatrics. So the diagnosis of stroke in pediatrics depends largely on the risk factors. Hence, routine thrombophilia testing is not indicated unless there are underlying risk factors. Imaging studies are most important to establish a diagnosis of stroke in pediatrics and can be done via ultrasound, a plain CT brain, MRI studies, MRV, MRA, and of course DSA. They present with either an acute SAH in a plain CT brain or even an acute subdural interhemispheric hematoma or an intraparenchymal bleed. So this is a common clinical presentation in our pediatric center. This is a case of an IVH or prematurity in a neonate born at the 2 weeks of gestation. As you can see, these are the ultrasound studies that shows hyperechogenicity within the lateral ventricles, which indicates blood clots in the ventricles. So a diagnosis of germinal matrix of hemorrhage was made, and it can be further divided into 4 grades based on the severity of the IVH. Again, another newborn of prematurity at a more severe age of 27 weeks of gestation with a mere birth weight of 800 grams. The child presented to us with obstructive hydrocephalus and clinically had macrocephaly. He underwent multiple types and stages of operations, including EVDs, ventricular subgaleal shunts, Omoya shunts, and even endoscopic lavage. Consequence of which he had collapsed ventricles instead, and a bilateral subdural effusion, and even an acute subdural hematoma. Eventually, it became an obstructive hydrocephalus. The child required a permanent VP shunt. Hypoxic ischemic injury is another common complication in neonates, And with this, it comes with an increased risk of ICH. And of course, with the risk of ICH, there's also an increased risk of neonatal seizures. In the diagnosis of HIE, we have to think of important MRI images, which includes a fast spin echo T2 weighted images, axial and coronal DWIs, apparent deficiency or ADCs, and of course the T2 gradient recall echo or GREs. This is a case of a child who was born with persistent pulmonary hypertension and the IVC, with a final diagnosis of HIE with multifocal intracranial hemorrhages was made. Vitamin K deficiency bleed, fortunately, is quite rare nowadays, thanks to our Malaysian guideline, whereby it's mandatory to administer vitamin K as a prophylaxis at birth. Unfortunately, we had a case of a 1-month-old baby who was diagnosed with vitamin K deficiency hemorrhagic stroke in the case where the parents actually refused the IM prophylaxis. So we'll move on to structural abnormalities in pediatric stroke. So AVM is definitely possible in pediatrics. In fact, non-traumatic spontaneous bleed in childhood, up to 75% of cases actually due to structural lesions, with brain AVM as the most common cause. Hemorrhage risk is up to 6% per year. Mortality rate is about 25% per hemorrhage, and diagnosis can be made either with CTA or MRA, depending on sensitivity, and of course, 90% sensitivity in CTA, versus a 1.5 Tesla time of flight MRA of 74% sensitivity. DSA remains the gold standard, as it is for the diagnosis of AVM in adults. In MRI images in diagnosis of AVM, we'll look at sequences such as T2 weighted images. We want to see the tangle of signal voids. Blood sensitive sequences, GRE and SWI, will be important to indicate a prior bleed. Time of flight or TOF MRAs with the hyperintensity will be used to distinguish the draining vein versus the traversing vessel. And of course, the important and famous Spezler, Martin, and Lawton-Young gradings would help in our guide to management. The optimal timing for DSA in pediatrics is largely unknown. Theoretically, it should be performed as soon as possible, especially in children with ICH of unknown origin. Based on several papers, especially by Elias and Lemley-Lifon, they find that DSA is still a low-risk procedure and often has high yield of examination in children. It carries 0% complication rate during the procedure and only 0.4% post-procedural complication rate. This is the case of a 9-year-old boy who presented to us with a first onset of focal seizure, had a plain CT brain at first, and showed a minimal IVH within the lateral ventricle. He was further investigated by MRI images and hence was diagnosed with a posterior parietal AVM. A subsequent DSA showed a right PCA supply, which drains into the superior sagittal sinus. So AVM management is not just about surgery versus non-surgery. In a broader sense, we have to think about genetic screening. Although most are isolated developmental lesions, there is some genetic association, especially when we're dealing with multiple AVMs and in conditions such as HHT. Parent counseling is very important, especially in the case of resected AVMs. 2.7% rate of recurrence in adult cases and up to 9.5 to 14 rate of recurrence in pediatric cases, with an average time to recurrence about 4 years. The higher rate of recurrence among pediatric AVM population is not fully understood, although we may need to entertain and explore the idea of different angioarchitecture as compared to adults. Several papers, important ones, by JNS Pediatrics and Pediatric Imaging, it shows a large series of pediatric intracranial AVMs with an overall radiographic cure of 96% who were treated surgically and only 6% for those in the non-surgical group. And this actually underscores the success and benefit of patients who were treated surgically in pediatric AVMs. The ultimate question, surgery versus non-surgery, depends largely on where is the AVM location, and if the risk of surgery outweighs the risk of observation, especially when we're dealing with large lesions and those located in eloquent areas. In time and age, multimodality therapy should be the way to go, although SRS and embolization therapy should be avoided as a standalone therapy. Surgical resection remains a first-line therapy in the majority of cases, carrying as 95% of cure rates. And of course, we have the controversial data in the Aruba trial, bearing in mind that the data provided for AVMs in children are still of surgical series. We'll move on to aneurysms in pediatrics. the question of, is it a nature or is it nurture? So this is still unknown, although it can be further divided into types such as idiopathic, traumatic, and infectious. This reflects the pathophysiology of formation of aneurysms in pediatrics. It starts off with the fragmentation of an internal elastic membrane and muscular layer, leading to inflammatory infiltrates, and of course, hemorrhage of varying ages, leading to the formation of aneurysms. Childhood aneurysms, they tend to arise from remnants of small vascular trunk that come from arterial bifurcations. These secular aneurysms arise from the stumps of vessel that usually disappear when the fetal cerebral vascular network mature to form the adult major arterial trunks. Therefore, childhood aneurysms tend to be larger, more complex shapes, and in the posterior circulation. As you can see here, this is an example of a fusiform aneurysm in the vertebrobasilar junction. Do we treat or do we observe? Aneurysms management in pediatrics is a bit different. And based on this very good and important paper, Intracranial Aneurysms in Childhood, a 27-year single institutional experience by Hetz, Navid, Sanai, and Lawton. By 2001, they had almost equal proportions of patients who underwent 45% endovascular therapy, another 45% microsurgery clipping or bypass, and only 10% were observed. Based on this, they concluded that the treatment of aneurysms in pediatrics depends on a good combination of both endovascular and microsurgery. We'll move on to cavernoma. They can present with up-ruptured or non-ruptured, and important images include CT scans and MRI studies. And how it's different from AVM and aneurysm, it will be that cavernoma lesions are actually angio-occult. Hence, MRI will be diagnostic. They will present as multilobulated appearance and blooming artifact on SWI due to the hemosiderin deposits. Genetic screening might be important, especially when we see multiple cavernomas on images and if there is an underlying family history of cavernomas. This is a case of a 5-year-old boy who had sudden onset headaches and recurrent focal seizures. Microscopically, cavernomas lack functional tight junctions, and macroscopically, they look like mulberry or raspberry with multiple blood-filled caverns and surrounding hemosiderins. And due to this, they give appearance of the reticulated T2 centers on MRIs and signal that reflects blood and thrombosis in the caverns. So the above case underwent cavernoma resection, and intraoperatively, we were guided by ultrasound images and also the IGS neuronavigation system. Macroscopically, the common raspberry or mulberry appearance of the cavernoma. We'll talk a bit of stroke mimics as they may have similar presentations as stroke, either clinically and radiologically. So stroke mimics are such as brain tumors, demyelinating diseases, infections such as cerebritis, abscess, traumatic brain injury, and include metabolic diseases. Clinical diagnosis is crucial. We need to have important strategies and diagnostic tools to distinguish stroke from stroke mimics. Reason being, stroke mimics may come with non-localizing symptoms such as headaches and altered mental status, and we might need to prompt an emergency physician to activate a stroke alert pathway. So this is a case of a child who came with us with acute headaches and acute hemiparesis. MRI study shows a bleeding tumor in the intraventriculars, and also, of course, as expected, intraoperatively, the lesion was very vascular. And of course, bearing in mind, infectious process that mimics stroke, cerebral abscess that mimics an ischemic stroke, and in infants, bones, meningitic acute subdural bleeds are also quite common. Management in acute ischemic stroke emergencies, most of all, symptoms control comes first. We need to control seizures, optimize oxygenation, correct the dehydration and anemia. Anticoagulants such as antiplatelet therapy, anticoagulants are rarely indicated due to the low risk of recurrence. Hyperacute stroke therapies, thrombolytics, and mechanical thrombectomy. However, no evidence for use at the moment. We'll move on to general management of acute hemorrhagic stroke. We need to first establish diagnosis. CT scans are very important as they are very readily available. MRA, DSA, whenever applicable. Important ABCs and medications such as antiepileptic. At antiepileptics, we need to correct important blood parameters, especially coagulopathies and vitamin K deficiency bleeds. BP control is most important as there are evidence that shows hypertension in the acute period after stroke are usually associated with worse outcomes. Surgery, surgical evacuation of hematoma or CSF diversion, ventricular drainage, and if it's needed, chance for progressive hydrocephalus. Hemicraniectomy in pediatrics is a life-saving operation, less than 1% of population that requires it with a careful selection of patients. However, large series of studies, children who receive hemicraniectomy, 95% survive. However, when you think about the post-operative sequelae, neurological deficits that may be permanent, ranging from mild, moderate, and severe. In conclusion, medical education is most important. We need to improve our knowledge, skills in diagnosis, and of course, the emergency management of pediatric strokes, especially in our frontline providers, pediatricians, emergency physicians, and pediatric intensivists. We need to think about better imaging techniques for early and accurate diagnosis of stroke, since the use of cranial ultrasound might be very important. We need to advance it. And due to the issues of delays, especially the need of sedations and MRIs and CT brains, younger ages might even preclude DSA. We need to narrow our knowledge gap in BP control and the role of hemicraniectomy, surgical clot evacuation, and CSF diversion in pediatrics. And most of all, cause of stroke is still a critical determinant of outcome, management, and follow-up strategies. And that's all for today. Thank you.
Thank you, Dr. Lim Mei Sin, for your comprehensive presentation. We will reserve all questions till end of this forum. So coming to the next speaker, our next speaker will be Dr. Ganeshwaran Durai Ramalingam. He's a senior intervention pediatric neuroradiologist. He is currently working at Hospital Tunku Aziza, Women and Child Hospital, Kuala Lumpur, Malaysia. His topic will be endovascular treatment in pediatrics. Dr. Ganeshwaran.
Thank you. A very good morning to all of you today. My name is Dr. Ganeshwara Lingam, an intervention radiologist in Hospital Tunku Aziza, Kuala Lumpur. Firstly, I'd like to thank the organizing committee for allowing me today to share my slides with you. All right. So where does a pediatric neurointerventionalist fit in the whole spectrum of diseases in a hospital? We are involved in the treatment of retinoblastoma, where we provide intraarterial chemotherapy. We're also involved in the management of intracranial and extracranial hemorrhages, be it aneurysms or AVMs. We're involved in the treatment of vein of Galen and dural fistulas. Also in craniofacial embolization, either as definitive treatment or as a pre-op embolization before surgery. And last but not least, in the management of spinal AVFs and AVMs. Before I go into a couple of cases, I'd like to present some overarching principles that I like to highlight before we go forward. In a pediatric age group, which is slightly different than the older age group, special consideration should be given to radiation exposure. As you know, there's the teratogenic effects of radiation. What more in the pediatric age group? Contrast dosage is also a very important thing, considering we're dealing with maturing renal system, and therefore we need to be mindful when doing procedures and injecting contrast. We usually set it at 2 mils per kg maximum dose, but however, sometimes with lengthy procedures, we might overshoot it a bit. Anesthetic time is also a very important consideration. As we know, the longer procedure, the more morbidity it entails. Another very important question that I get asked is vascular access. As you know, pediatric intervention is a slow growing field. It's not as advanced as, say, the adult intervention field, and therefore lots of our kits are actually manufactured tailor-made for the adult population, and most of the time we are using catheters, stents, wires that are meant for the adult population in pediatric age group. So be mindful of the vessel size that you're catheterizing and what it entails. So how do we reduce the risk of any complications? Firstly, systemic heparinization is very important. After a sheath is placed in, we ask the anesthesia to inject IV heparin, usually about 100 units per kg, and it's usually topped up every 1 or 2 hours. Secondly, heparinized saline is infused through our catheters to avoid thrombosis either stent thrombosis, sheath thrombosis, or catheter thrombosis. Again, these are not foreign to adult IR treatment as well. However, keep in mind, these are children and volume restrictions very important. I'll illustrate this point later in one of the cases. Thirdly, pediatric vessels are also very prone to spasm, and we try to avoid that by injecting some verapamil, and in smaller kids some nitroglycerin to treat the spasm that as and when it occurs. Another important factor is pump injectors or hand injections. So to get a nice, beautiful DSA image, pump injection is very much our chosen option in the adult population, where it gives you a fast flow of contrast, large flow of contrast with good pressure to fill up whatever vessel you're imaging to give you beautiful pictures. However, with the pediatric age groups, be mindful of the vessel size, pressure that you're going to inject, and therefore hand injection is probably a preferred option if pump injection can be avoided. All right, let's go into some of the diseases that we treat in our hospital. Intraarterial chemotherapy. Intraarterial chemotherapy basically is one of the options of treating retinoblastoma. It involves the superselective cannulation of the ophthalmic artery for the treatment of RB. The principle of such treatment is basically infusing high levels of drugs into the tumor itself without the excessive systemic toxicity that is involved in systemic administration of the drugs. What is the indication? Firstly, the contraindication. If there's extraocular involvement, IAC is not indicated in such patients. It can be used as a primary source of treatment, basically for native eyes which have not had any previous treatment. IAC is an option, but more commonly in our hospital, it's used for the more advanced diseases which are in group D or E. It also can be used in tandem eye lesions, basically infusing both bilaterally in one sitting, or it's used when all else treatment has failed and it's the last treatment before enucleation is the only option. A brief evolution of the treatment of IAC. It started off with the Japanese, who initially, again, with not having large catheters, they used to use a balloon catheter, where they place the balloon catheter just beyond the ophthalmic artery, and the balloon is then inflated and the drugs is infused through the larger catheter below it. As you can see here, it's not hard to see that the risk of a thrombus or stroke is very likely. Again, this procedure is done over 10 minutes. Balloon is inflated up, infusion over 10 minutes and deflated. Again, the risk of thrombosis and stroke is there, and it should be a factor before doing such treatment. With development of catheters and catheter technology, now we have much smaller catheters that can be maneuvered into the ophthalmic artery for chemo infusion. This is an example. This is an angiogram of a vertebral catheter parked within the ICA. And you can see the visualization of the ophthalmic artery here. And with successful placement of the microcatheter, as you can see, small little catheter here with a tip which is radio opaque. There's now enhancement of the ophthalmic artery together with a nice blush of the orbits. Once the catheter is in place, stable, you're in the right place, no spasm, no dissection, you can then give your medications. Again, as I mentioned earlier, with pediatric age groups, the vessels are small, and with recurrent treatments, rounds of IAC, the vessels may spasm, thrombus, or stenose, and therefore other routes need to be chosen. In this case, the IAC route was not an option, so we cannulated the ECA, and you can see here there's a hint of enhancement of the orbit. And after hunting as hard as we can, we see that there is actually supply to the orbits via a branch of the middle meningeal artery. And an EUA is then done 3 weeks later to see the progress or the response to treatment. On the left, you can see a large retinoblastoma, this large angry looking thing with large tortuous vessels. And post IAC, the tumor has shrunken and the tortuous vessels are not seen anymore. No procedure is without its complications. Here I present an 8-month-old baby who underwent IAC. Granted, it was a difficult cannulation. However, we managed to cannulate the ophthalmic artery, and the chemo drugs were infused. Patient was extubated well, discharged back to ward. However, 12 hours later, she developed seizures and weakness over the right upper limb. An MRI done showed an area of restricted diffusion in the right parietal lobe. As you can see here, this dark hypointense areas, patchy areas in the right parietal lobe and high parietal region as well, in keeping with reskin infarcts. Fortunately for this patient, and fortunately for me as well, patient resolved, her weakness resolved, and she's now off her anti-epileptic medications. As I mentioned earlier, we're also in the business of treating bleeders. Here's a case of a 1.5-year-old boy who presented with history of sore throat, fever, and difficulty swallowing with a left neck swelling. Strangely enough, he was actually planned for incision and drainage of what they thought was an abscess in a hospital nearby, except for anesthetic team who thought something was amiss as this mass was pulsating and ordered for a CTA. This is the CTA done, and as you can see here, there is this large extravasation seen. Enhancement is similar to the ICA on the other side, with a large hematoma of varying densities in keeping of varying ages. So patient was then proceeded for an angiogram, which you can see here is the left ICA and a large pseudoaneurysm seen here. This is a nice image because you can see there is no flow of the rest of the ICA with some reconstitution via the ophthalmic artery of the rest of the ICA and the intracranial supply. Also, the ECA anastomosis with the posterior circulation is also beautifully described here. As you can see, there is flow of the vertebral artery via the occipital arteries. So the plan was then to embolize and sacrifice that part of the ICA, but before that we need to confirm that there is good collaterals of the left ICA via other branches. And in this run you can see there is presence of an ACOM evident by the left ACA. However, we're still not convinced because you don't see good flow within the MCA, and we proceeded with an a posterior vertebral run, which then shows a very nice opacification of the MCA via the PCOM. So we were then convinced that it was safe to therefore embolize this diseased ICA. Here we have the catheter within the ICA, just proximal to the pseudoaneurysm, and after dropping a few coils, there's no more flow within the aneurysm sac. Patient was then treated with antibiotics and was discharged after a few weeks. All right, moving on to next patient, case of spinal AVF. We present a 2-year-old girl with sudden onset of loss of consciousness and bilateral lower limb weakness. An MRI at that time showed a large intraspinal lesion, which was diagnosed as a mass at that point, and the surgeons took her in for surgery. What they found intraop was lots of blood clots with large visible veins, and therefore no tumor seen. A repeat MRI then showed large intraspinal dural sac with multiple large draining veins. On sagittal image here, you can see a hypointense dural sac with flow voids originating from it extending superiorly. And on enhanced post-CAD images, you can see enhancement of the sac with large draining veins seen extending superiorly. Again, I stop here. The patient was then pushed for an angiogram and treatment as well. I'd like to pause on this image. As you can see, this is the sheet, the smallest sheet we have, which is a 4 French sheet parked within the common femoral artery and the tip within the external iliac artery. As you can see here, The sheath is about the same size as the external iliac artery, and you can see it is occluding, as you don't see any flow going down the legs. Again, I'd like to stress the importance of heparinization of the sheaths, IV heparin when you start procedures, to avoid any thrombotic event or gangrene event to the feet. So moving on to the embolization, here we have the catheter of vertebral catheter parked within one of the lumbar vessels, demonstrating the feeding artery, the venous sac, and the large tortuous draining veins. We then advance our small microcatheter. You can see this microcatheter, you probably can barely see the microcatheter within the sac, demonstrating the flow within the venous sac. And then we proceeded with embolization with 50% glue. You can see us filling the glue, filling up the sac, especially the draining vein, with some glue flying off in the draining vein superiorly. Post-embolization, this is a very good embolization of the sac, the proximal draining veins, and the supplying artery. Again, be mindful of the glue that have migrated due to the fast flow, and you do have some glue deposited within the lung. Again, very small, not causing any collapse, and no sequelae following this embolization. Moving on to intracranial aneurysms, I'd like to present a 6-year-old boy with infective endocarditis and mitral valve regurgitation. Interestingly enough, he was actually referred to our center for a large common femoral aneurysm. However, he developed a left frontotemporal bleed, and a left craniectomy was done to evacuate the clots. A CTA done following that showed a M4 saccular aneurysm, and this is the angio images. A distal M4 segment aneurysm on AP and lateral view. This was then treated with antibiotics for about 3 weeks. However, despite the antibiotics, the aneurysm still persisted, and therefore we proceeded with coiling off this aneurysm. As you can see here, we've deployed one coil, which did not fully embolize the aneurysm. Following that, after the second coil, there's now no more flow within the aneurysm. The 2 coils are here. A global ICA run also did not show any paucity of areas to suggest significant occlusion of a large vessel. 1 year later, MRI also showed no significant areas of infarct, just some encephalomyelitic changes over the tract of the shunt drain. So mycotic aneurysms are rare inflammatory lesions comprising less than 5% of all intracranial aneurysms. It's caused mainly by Staph aureus or Staph videns. It basically forms secondary to IE when cardiac vegetations are friable and are prone to septic emboli lodging in the intracranial vessels, usually their branches. Treatment, unruptured, can be treated with antibiotics and see whether it improves with the antibiotics. If ruptured and causing a mass effect, surgery is the mainstay of treatment to evacuate the clots. Endovascular treatment has its benefits in the sense that it decreases anesthetic time. There's rapid anticoagulation therapy that can be started post-op, and that reduces the delay for treatment of the cardiac lesion. I'm just going to move past to vein of Galen. Again, a 2-year-old girl presented with macrocephaly and hydrocephalus. Here's the image of a large draining vein with multiple collaterals. And this is the angio images showing supply of the vein of Galen via the PCAs bilaterally and the PCOMs. All right, this is a better image. In this case, glue therapy was employed. 80% glue was injected just proximal to the aneurysm, the venous vein of Galen. And following that, there was much improved flow to the posterior cranial fossa with reduced and sluggy flow within the vein of Galen. And in this image, the MRI post-procedure showed reduced hydrocephalus with no significant flow within the vein of Galen. I'd like to present another case of vein of Galen with varying degree of outcome. So the earlier patient, as you know, was a 2-year-old girl. This is a much smaller girl. Again, presented with seizure and loss of consciousness. Again, very similar. The PCA supplying the vein of Galen. Again, in this case, because of the high flow nature of the vein of Galen, this patient was treated with balloon occlusion. So a balloon catheter is placed just proximal to it, and then it is followed by either glue or some coils. So we proceeded to then coil or occlude 4 of the feeders, and this was after occluding 4 feeders. However, there still persisted this one large feeder, but we were then informed by the anesthetic team that patient was not ventilating well, and patient became unstable, and therefore we had to abandon the procedure. Chest X-ray showed that the lungs were not well inflated, and it was due to bilateral pulmonary edema. An ultrasound on table also showed that she had ascites, and this is likely due to overload, and this may be due to our aggressive flushing of our catheters and sheaths. Again, I like to remind myself and what I presented earlier that flushing is important, but over flushing may lead to morbidity. This was the images pre-embolization. You can see large ventricles with lots of white matter ischemia. Post-embolization, you can see that there is still ventricular megaly to a lesser extent, but the vein of Galen still persists. Sadly for this patient, before we could plan for next embolization, she passed away at home. So I'd like to illustrate these 2 cases because same pathology, one turned out very well and one didn't turn out very well. Looking back, maybe with this patient, we should have planned a more stepwise approach to treatment due to its multiple feeders. Again, Mr. Faz, Mr. Azmi will know what it is like in our hospital where ICU beds and OT time is a premium, and so we might have been overzealous with the treatment of this patient. Finally, I'd like to run through a last discussion involving the neurovascular stenting in pediatric age groups. It's a common question asked by the surgeons and the other IRs in the faculty. We have to understand that the aneurysms in peds and adults are very different in location, size, multiplicity, rate of spontaneous thrombosis, and the susceptibility to vasospasm. A few papers out there that describe vascular stenting, intracranial vascular stenting, but these papers are small and some of it are not clear of its details. A paper published in the Journal of Neuroimaging in 2016 tracked stenting done between 2007 and 2014. There are a total of 6 patients, some coils. Sorry, all right, sorry. So just in a nutshell, stenting is still out there. We haven't proved whether it's safe or not. Thank you very much.
Okay, thank you, Dr. Ganesh. Sorry for interrupting. Now we'll proceed to the next topic, aneurysmal SAH, coil or clip. Here we have Prof. Asra Al-Fawzi. He's a senior consultant neurosurgeon from Department of Neurosurgery, Airlangga University School of Medicine, Surabaya. He has an extensive CV and a member of numerous organizations. He's a clinician, academician, and also a medical entrepreneur. I'm proud to invite Prof. Asra Al-Fawzi to present his topic.
Okay, thank you, Dr. Tines, and always thank you, Azmi, and also my friend, Dr. Professor Zamzuri Idris, Dr. Azizi, and all Malaysian friends. Actually, I hope this conference will be, offline. But the situation still unpredictable. So I hope next year you can invite me again, trust me, and I will visit Malaysia directly. Okay, thank you, and I will start my presentation here. Let me share my slide. Okay. Sorry. I cannot see my. Okay. Okay, Dr. Tines, you already see my slide here clearly. Okay. I will start my presentation. As you know, I think it's more basic and very important for young neurosurgeon to know that coil or clip is still debatable, some controversy there, but mostly I will show the recent literature, recent report, and also research about this phenomena. So, yes, I'm not talking more about this. We already know about the ACH. It's about the rupture of intercalated aneurysm mostly. And the important thing also it's have some high morbidity because some complication intracranially, also with some systemic complication, including cardiopulmonary dysfunction. And many research, many large report also show how what is the best treatment of this kind of disease instead of open surgical clipping or endovascular neurosurgery. And also this is I think we know the global burden of this disease. You can see the incident of ASH, incident to be higher in Japan and Finland, we already know together. And interestingly, the prevalence of intercalated aneurysm is not found to be higher in Japan, Finland, but the risk of a rupture is higher. WHO Monica study report 30-day case fatality rate of 42%. Another study from Australia and New Zealand placed this number of case fatality rate too. Yes, the important is the risk of permanent disability is high among survivors, and the dependency rate is approximately 50%. So I think it's great morbidity with our patient. And of course, I already told you earlier that some patient maybe died or half occupied are left with some persistent neurological deficit, and some complication might be happen, such as hydrocephalus or delayed cerebral ischemia, and it's a great spectrum of this kind of disease that we have to treat comprehensively. And this is important too for young neurosurgeon to know that there is some risk factor for rupture of intercalated aneurysm, as mentioned by De Souza in 2014. The female Japanese and Finnish descent, as I mentioned earlier, smoking, hypertension, cocaine abuse, and also this is important also that posterior circulation aneurysm and giant aneurysm tends to rupture when for your SH. And we already know that the symptoms is very very clear, the worst stage of my life. So sometimes like in my country, mostly patient came in rupture case. So in my hospital, maybe more than 95% mostly in rupture case. So this is a it's not a good situation now. And this is our treatment modality in the last 5 years. Actually, the case actually is more than this. As you know that I mentioned earlier that most of our patient is rupture case. So the patient came with a delayed situation and also with very bad condition. So mostly about 30% case in my hospital will not treat it aggressively, I mean, for surgery or for endovascular treatment. We treat it in ICU with aggressive medical treatment, and also sometimes we only treat with ventricular drainage. If the patient getting better, so we will move forward to other modality treatment. But sometimes, mostly, patient didn't make it for after a couple of days treatment in the ICU. This are still our problem in Indonesia. This is our hospital. If you come to Surabaya, this is the second largest hospital in Indonesia and the largest number of beds available in Indonesia until now. We are the top referral hospital for eastern part of our country in Indonesia. And of course, we built a team. All the case for aneurysm, we discuss which is best treatment. So Dr. Iwan is my endovascular guy. Actually, he's a dual neurosurgeon. So actually, we best team to decide which is the best treatment for our patient. And yes, we already know about the the algorithm if we face with S8 patient. So mostly in our hospital, in the emergency setting, we already take a CTA first, and then we can know the cause of the aneurysm. For some such as MC aneurysm, sometimes we treat definitely by clipping only with CTA. But for complex or another complex aneurysm, we have to perform DSA. But DSA is not available for emergency setting in my hospital. So we wait for next day to to perform DSA for a patient with SH. And we already know that there are many grading for severity for SH, AASNS grading, facial grading to know the to examine the CT appearance of SH, and also WFNS grading system. Actually, in my hospital, we very popular using the AASNS grading in our for nurse and also for resident. Actually, but we can use all this kind of grading system. And yes, this is the very devastating complication that sometimes give a bad prognosis to our patient. And we have difficulty to manage this, especially with sometimes patient came with delayed for refer. So we can do much about this, but if we can treat earlier the patient and to to occlude the aneurysm, so we can freely treat the patient with with good neurointensive care in our ICU. And yes, this is from the article. So that I will not talking more about this, but actually there were research about which is the best grading system to to measure the prognosis of the patient, the best treatment with this grading system. You can see here with clinical score, with radiological score, and also with clinical and radiological score. You can see here sometimes for clipping, they say that vasograde can be more effective, compared with choline to predicting DSA and pro outcome. So yes, all the research still happening now and still going on, but we can wait for how is the result of this the best grading system for for each situation. And of course, I will talk about this coiling as clipping. The number of coiling procedure is now increasing, but I will show you the result of the recent article and also our experience in my hospital. You can see here from the table 3 the choices of technique of integral aneurysm. So endovascular coiling is more for posterior circulation aneurysm, for basilar location, and of course intracavernosus segment, elderly patient, and patient with comorbid condition. But for surgical clipping, so yes, MC aneurysm, also giant aneurysm, wide neck, younger patient, and some rupture aneurysm case. Yeah. And this is very important. I want to show you comparing the guideline from American Stroke Association guideline and also a European Stroke Organization guideline. Actually similar, but some items a little bit different. But as you know, for some item I will highlight it is in European Stroke Organization guideline. In the last item, you can see that elderly patients should not per se be excluded from treatment decision. Whether not to treat depend on the clinical and physical condition of the patient. So another thing that the same recommendation is, if technically amenable to both endovascular coiling and neurosurgical clipping, so endovascular coiling should be considered first. So you can see here the European Stroke Organization, so more more detail about the decision or whether to clip or coil depends on several factors related to 3 major components: the age, the procedural competence, and also logistic. And yes, we can see here the opposite of the earlier guideline. I will write down here about the aneurysm are not suitable for endovascular coiling, such as giant aneurysm, wide neck, fusiform aneurysm, and also aneurysm at certain anatomic locations, such as arterial bifurcation, and also rupture aneurysm with mass effect. So another thing that not suitable for surgical clipping, such as dislocation and patient with comorbid condition, also patient with SH and massive brain edema. And this is an example from our experience at my hospital. This is female 36 years old, consulted from obstetric and gynecology department after postgravid patient. I mean, after giving birth, and then he complained of a severe headache, and the CT scan and also the SSO, you can see here the rupture IC aneurysm, and we decided to perform a coiling procedure in this patient. And this also the posterior circulation aneurysm. So we prefer to do by the endovascular procedure. So another thing, this is male 56-year-olds, good high-NS grade with rupture IC bifurcation aneurysm, like usual. You can see multilobulated aneurysm opening widely the severe fissure. You can see directly all the nerve, and you can see the important thing is many branches, many perforator we have to secure there. So yes, you can see both the dome of the aneurysm. So you can see the first aneurysm there. You can see I secure the perforator and branches not to occlude in that area, and another part of the nicely we can occluded the neck of the aneurysm. So yeah, you can see here totally occluded and patient is good. And also, I show you another case, for MG aneurysm that I already mentioned earlier, that mostly MG aneurysm will goes to clipping surgery. And in this case, I will show you the case of S8 patient with fracture right MG aneurysm, quite large aneurysm with bifurcation there. So we have to construct the parent artery with the clip. So you can see we don't have to open all the dome because this rupture one. We have to see the neck is enough. We identify our perforators and M1 there, and then we can nicely clip the neck of the aneurysm. Yes. Yeah, the parent artery and branches is secure, so you can see the total occlusion of the aneurysm. So yes, this is important article too, that how we can we compare the assumed risk of neurosurgical clipping and also the corresponding risk of endovascular coiling. So we can see here the statistical analysis. So if the lower score means better quality of life, the lower score of endovascular coiling should be better. So you can see here for outcome, mostly corresponding risk of endovascular coiling is better. But in another result show that the rebleeding post-procedure or rebleeding post-procedure up to 10 years and complication from the intervention, this show that the endovascular coiling is not good as much as clipping procedure for rebleeding issues. And also this paper showed the poor outcome, death or dependence in daily activity. You can see the comparison between the coiling and clipping here, 1 year until 10 years. You can see here. Okay. And then, yes, this is a very important too, that a very interesting result of this study, that for additional therapy, I mean, for, in SAH, there are many spectrum of, complication like hydrocephalus or some hematoma that make some mass effect to the brain. So, some, clipping is favorable outcome, yeah. Also with coil embolization with hematoma removal is result with favorable outcome. But for some criteria here that not statistically independent of favorable outcome, you can see here coil embolization only, coil embolization with TSF drainage, so coil embolization with TSF drainage in hematoma removal. So I think this is a report from an article. We can analyze this research and how to apply for the management of AH in our hospital. And this is a very important to how to manage SAH patient delayed with early treatment of SAH. You can see here that mostly delayed hospital admission patients are at an increased risk of cerebral infarction. Nevertheless, state-of-the-art neurointensive care treatment can result in a good clinical outcome. So, earlier treatment is better. So yes, this is for elderly patient. So the interesting is greater independence was observed in older patient after microsurgical clipping than after endovascular coiling. So this is also show the percentage of patient undergoing clipping and coiling in the 3 time period. I think it's 30 years, you can see the number of clipping is getting less. Yeah, 78% and now only 21%, but the number of coiling procedure is increasing. Yes. Also the hospital mortality, and how about the anterior circulation and posterior circulation outcome here. And this is, in the COVID pandemic, we can see that some patient can be, have aneurysm, and then because of COVID, it's easy to rupture. So we have to manage this very carefully, because there's, two diseases in one patient. And this is our experience that doing surgery in the COVID pandemic. This is a case of rupture choroidal artery aneurysm here. Just so this is the last, I think the last slide. So you can see always the sharp dissection of the surgery, and you can see there's ICE there, and then just near the neck of the aneurysm, we have to be careful. Always cut sharply, and then we have to identify the choroidal arteries there, just temporary clips. Now we have to secure the choroidal arteries. This is the choroidal artery, very important part. Even small artery is very important. So now we can clearly know the neck of the aneurysm, and then now we just nicely clip the neck totally. So there is we can secure the choroidal artery. Make sure with the ICG there, you can see the choroidal artery there. And this is the summary. I think surgical clipping or endovascular coiling of the rupture aneurysm should be performed as early as feasible in the majority of patients to reduce the rate of rebleeding after ACH. In cases where the aneurysm appears to be oculi effectively treated either by coiling or clipping, coiling is the preferred treatment. Although there is a paradigm shift towards coiling embolization, but still treatment should be considered individually. Okay, terima kasih. Thank you very much for your attention.
Thank you, Prof. Asra, for your comprehensive presentation. We will reserve all questions until end of this forum. So next, without further ado, I will introduce Dr. Liu Bun Seng, a senior neurosurgeon from Hospital Sungai Buloh, Malaysia. He has an extensive CV, and he is also a member of numerous organizations. He is also a recipient of numerous scholarships. He will be presenting to us on restoration of laminar blood flow in clipping of saccular cerebral aneurysm. Dr. Liu. Dr. Liu?
Hello, can you hear me?
Yes, Dr. Liu.
Thank you, Dr. Dinesh, for the kind introduction, who is currently a vascular and spine surgeon in Kuala Lumpur. First of all, I would like to thank the organizer for the kind invitation, especially the AASNS and also KL Hospital, and special thanks to Mr. Azmi Alias with the kind invitation. Today, I bring your attention to a lighter topic, although we have a very extensive topic over the past 2 days and very educative. I bring your attention to a restoration of laminar blood flow in the clipping of saccular aneurysm. This is my study. So the indication for surgical clipping of cerebral aneurysm are very well described in many literature, and the disruption of the laminar blood flow within the bifurcation due to the formation of the saccular aneurysm can be improved following restoration of original vessel configuration by surgical clipping. And let me bring your attention to a paper published in 1972 in the Stroke Journal by Professor Maggot. He did a study on the hemodynamic importance of the geometry of bifurcation in the circles of Willis, which using a glass model studies, and where he use the term critical Raynaud number, a number which turbulence developed in the glass model of the bifurcation was measured. And this Raynaud number was actually first coined by Professor George Stokes in 1851. And what important about this Raynaud number actually is a constant, which are direct proportional with the mean velocity, diameter, and also density. And also it was proportional with the viscosity, and it can be used in the blood circulation of several circulation. And then laminar flow occurs at low Raynaud numbers, where viscous force are dominant and is characterized by a smooth, constant fluid motion. And turbulent flow occurs at high Raynaud number and is dominant by inertia, which tend to produce chaotic vortices and also flow instabilities. And Raynaud number were calculated for the parent trunk using the measured mean flow rate, the diameter of the tube, and also viscosity and density of the fluid or blood at that temperature. What is important is the angle of bifurcation on which resulting flow profile, other parameter of flow Raynaud number and geometry are kept constant. Let us look at this graph produced in this paper. As you can see, there's two lines there. One is on steady flow, one is a versatile flow, which represent cerebral blood flow. And down there on the x-axis, you can actually see the different angle at 0, 45, 90, 135, and 180 degree. And you look at the critical Raynaud number, it simply means that, for example, let's look at the versatile flow at 45 degrees. It simply means that around 1,000 to 1,500 critical Raynaud number, turbulent flow will occur with that degree. And you can see that when the bifurcation angle is getting higher, the critical Raynaud number getting lower. So with a constant Raynaud number in a given person, hence the increasing angle between two vessels will actually increase the chance to have turbulent flow with a constant flow that in that particular patient. And again, with the formation of aneurysm, you can see that in the graph, the critical Raynaud number even go lower at the given angulation between two vessels. And with that means that the more turbulent flow with the constant Raynaud number in that particular person. And again, enlarging aneurysm tend to increase the angle between two vessels, and that would actually cause more turbulence. At the same time, the aneurysm itself also will cause more turbulence flow. And hence, the complete obliteration of the aneurysm will improve Raynaud numbers, and correction of the angle between the branches, which was worsened by the aneurysm formation, can be achieved purely by surgical clipping, by remodeling the vessel, and cannot be achieved by a coiling of the aneurysm. And here I bring you attention to the same, and you can see on the right side, with the RA number of 500, we saw a constant flow between two bifurcation with angle of 90 degrees. So when the Raynaud number increased to 1,500, and you can see actually turbulent flow since in these flow models. And with the formation of an aneurysm, even at the RE number of 500, the turbulent flow was observed. And in enlarging aneurysm in this model, it shows that more turbulence was seen with the same Raynaud number. And how about there is an asymmetry between distal vessel, one is larger and one is smaller. And with both boundary injection and axial and boundary injection, you can see actually turbulence flow tend to occur more in the larger vessel. It suggests the dilution due to washers that more likely to appear in a larger branch than a smaller one. And here the clipping allowed correction of the wall configuration and allowed larger flow, which means larger RE before turbulence occurs. And clipping may also reduce the angle between two branches, and they have same effect as above. The effect to the blood flow within the non-dominant distal vessel following clipping aneurysm have never been described. Here, this is the cartoon model, and you can see that in the bifurcation with RE more than 1,000, only we get turbulent flow, otherwise we get laminar flow. But with the aneurysm formation over time, it increases the angle between two vessels, and even at the lower RE, that we more turbulent flow in this patient. But however, with clipping aneurysm, we can see the correction of the angle, and hence it reduces the turbulent flow and improve the laminar flow, hence have a better brain perfusion post-clipping. Here, let me introduce to you on a wall shear stress, which are the dynamic tensile force caused by viscous fluid that move over a solid material surface. There's a blood vessel. And it's actually a tangential friction force in the vessel wall and induced by the blood flow. So in the context of versatile fall, wall shear stress magnitude can on each element within the circle cycle with cardiac cycle, because there's a systolic and diastolic pressure. So we usually use a time average wall shear stress in our study. And in the endothelial layer of the inner vessel wall, cell reaction occurs when the hemodynamic force are acting on the vessel wall induced by the wall shear stress. And this vessel remodeling occurs usually due to high wall shear stress. This is a hypothesis or theory used to explain the aneurysm formation over the vessel, especially in the bifurcation. And how about the aneurysmal growth? The mechanism responsible for the growth of ultimate rupture of the aneurysm, we have two main schools of thought. One is high flow effect and one is low flow effect. The high flow theories claim that abnormal high wall shear stress cause excessive production of nitric oxide, resulting in a lower local arterial tone owing to a scarcity and apoptosis of smooth muscle cell and a wall remodeling. And for low wall shear stress, also was theoretically causes a dysfunction in the flow-induced nitric oxide, which resulting in the aggregation of the red blood cell and accumulation and adhesion of the platelet and leukocyte, which in turn cause edema damage and inflammation, leading to localized degeneration of the aneurysm wall. And this is caused by localized blood that is stagnant within the wall of the dome of the aneurysm. And based on our observation, most of the time that aneurysm growth are due to a low wall shear stress rather than high wall shear stress. But definitely there's no argument regarding the formation of aneurysm due to a high wall shear stress. And here I report two cases to be presented, which illustrate the effect of clipping of basilar tip aneurysm to the blood flow within the posterior cerebral aneurysm. The effect of the clipping to the blood flow and also the blood volume within the non-dominant vessel also was studied. Both cases was from Fujita Health University, Bantana Hospital, Nagoya, Japan. Thanks for the case and courtesy from Professor Yoko Kato for sharing this case with us. And before we go to the case study, let me bring your attention to the normal blood flow rate of vessel in the cerebral circulation. At this study, we phase contrast MRI to determine the flow rate done by this author. For PCA, it was around 51 to 58 mil per minute for cerebral posterior circulation of PCA. And how about the size of the PCA? Another study done using a CT angiogram by another author, which found based on a different age, also different gender, is approximately about 2.2 millimeter with plus minus 0.4 millimeter for PCA. Let us go to our study. I have a 55-year-old female with incidental finding of anterior superior pointing basilar tip aneurysm, which are measuring about 7 millimeter. However, due to the finding of narrow distance between the perforator and the aneurysm sac, she was referred for microsurgical clipping. And what we found in this study is the left P1 segment of the posterior cerebral artery was dominant with a diameter measuring 2.4 millimeter compared to a smaller one on the right side, 1.2 millimeter. And definitely the flow rate are higher in the left side with 52 mils per minute compared to only 5 mils per minute in the right side. So this is a computational fluid dynamic study that we did for this patient before surgery. And you can see on the left lower part show yellow color over the dome, which show high wall pressure. Usually high wall pressure indicating the risk of a rupture. And you can see in the upper left side, there's a low wall shear stress within the aneurysm, as I mentioned earlier, which promote aneurysm growth. And you can see the big image over the right side, which shows the wall shear stress vector. And you can see a lot of convergent vector around the neck. and the flow rate different between the left and right, which are higher on the left, and also larger diameter on the left compared to the right. And down there on the middle, you can see actually the washer stress streamline, which actually show you can see a lot of turbulent flow when you go to the near to the neck of the aneurysm and worsen even within the dome of aneurysm. And this turbulent flow actually impact the brain perfusion for that particular vessel. And post-clipping, what we found in our CFD study is there's an increased diameter of the right segment of the PCA to 2.2, which increment by 83.3%, and blood flow volume was increased from 5 ml per minute to 47 ml per minute. And we also found the angle between 2P1 also noted to be slightly reduced after clipping. And you can see this CFD post-clipping. You can see now the diameter of the right side noted to be larger compared to pre-clipping, and also improve in the blood flow. And you can actually see that with the obliteration of the dome, now there's a reduced wall pressure within the bifurcation and still remain low washer stress. What importantly is you can look at the washer stress streamline. There's improved laminar flow after the clipping. And if you do direct comparison, on the left side is before clipping, and right side after clipping, you can see that improve in angulation between two bifurcation, increasing in size of the non-dominant vessel post-clipping, and improve blood flow rate on the non-dominant vessel. Let us bring you to the second case illustration. A 56-year-old lady with a history of grave disease 20 years ago with incidental finding of multiple intracranial aneurysm, namely basilative internal carotid artery, choroidal, and medial cerebral artery aneurysm, was diagnosed in 2012. During that time, the basilative aneurysm was measuring about 4.2 times 6.2. But 4 years later, in 2016, it noted to be enlarged to 5.8 and 6.2. Hence, she was subjected for microsurgical clipping. Before that, the CFD study again showed left dominant of P1 with size diameter measuring 2.2 compared to 1.4 millimeter on the right side, and flow rate of 26 mils per minute on the left side compared to the right side only 8 mils per minute. And this is the CFD study of the vessel. Again, you can see that very high wall pressure comparing to the parent vessel and distal vessel of both P1, which a high risk of impending rupture, and a low washer stress within the aneurysm sac. And you look at the washer stress vector, there's a lot of convergent vector near to the neck of the aneurysm, and the turbulent flow within the aneurysm and near to the neck of the aneurysm. And this post-clipping CFD study actually shows there's increase in the diameter of the right P1 segment of the PCA from to 2.1 with increment of 50% and improvement of blood flow from 8 ml to 11 ml per minute. And this is the post-operative CFD, and you can see actually the wall pressure is much reduced post-clipping, still remain low washer stress, and what importantly is the improve of the washer stress streamline. The laminar flow have been restored, and there's no more convergent vector, and this is much improved after the surgical clipping. Here we do a direct comparison between pre-op and post-op, and you can see that the laminar flow is much better after clipping, and the angulation between 2P1 have improved and with a larger now right P1, which are initially noted to be as non-dominant. So the angle between the bifurcation of several vessels increases with circular aneurysm formation. The formation of aneurysm, which resulting in the increment in the angle between two vessels, will create more turbulent flow even at the similar flow and diameter of the vessel. The enlargement of the aneurysm sac will also cause more turbulent flow even at the similar flow and the diameter of the vessels. The effect of increased blood flow to the distal vessel following reconfiguration of the vascular bifurcation with restoration of the laminar flow to the surrounding brain tissue have yet been studied. Clipping of basilative aneurysm improves the laminar flow as shown in these two case studies. Clipping of basilative aneurysm reduces the angle between two branches of P1. As conclusion, the clipping of the basilative aneurysm improves the blood flow rate and the blood flow volume in the non-dominant distal vessel. Therefore, clipping of cerebral aneurysm improves the brain perfusion of the brain parenchyma supplied by the vessel of the vessel brain located distal to the location of the aneurysm. Hence, the clipping of the basilar tip aneurysm reduces also the angle between two distal vessels, and we expected to restore the laminar flow and even improve the cerebral perfusion. Hence, another indication besides risk of impending rupture is to improve brain perfusion by reconfiguring the vessel to its original state, which improve the blood flow rate and less turbulent flow. A follow-up quantitative study on the effect of the clipping of cerebral aneurysm to the brain perfusion is needed to further verify this finding. So with that, thank you for listening.
Thank you, Dr. Liu, for your presentation. It was very academical. Now we come to question and answer session. We don't have any questions from the attendees, but we have some questions.
Excuse me, what happened to my presentation? Am I doing it?
After this, Prof. After this.
Okay, right, all right. So we'll be discussing all that.
Yes, after this.
Okay, all right, okay.
Thank you, thank you. So back to Tinesh, you have any further question in your session?
Yeah, a few questions, but can be answered anytime, either now or even after. So one is, when do you treat a residual neck aneurysm during your follow-up? When do you treat a residual neck aneurysm? Another one is early intervention in whether it's less than 72 hours or late intervention or more than 11 days in a ruptured aneurysm case to prevent the window of vasospasm. And another one is management of multiple aneurysm in SAH, wish to treat and wish to follow up. And last question is it safe to start the dual antiplatelet in during subarachnoid hemorrhage for stenting or stenting assisted coiling? So these are the questions. If you can answer now, or we can answer also at the end of session 2. Is for the panelists. And
yes.
Professor?
Yeah, I have to answer now.
Yeah, you can.
Yes, I will answer not all the questions because of time, but for the residual neck aneurysm, yes. Of course, we have to, treat optimally the aneurysm with totally occluded without, rest of the neck aneurysm. But sometimes it's difficult for some complex or some, difficult area of the aneurysm. So we have to left some, residual neck. And of course, they are not the modality where we can make some wrapping in that area, and then we can observe and see the progress with annually make some radiological evaluation. Of course, if the neck of the aneurysm is getting larger, so yes, we have to treat this to prevent another complication of rebleeding. And for early intervention or late intervention, yes, of course, in SAH we have to try to make earliest treatment to reduce the complication for rebleeding. And for clipping surgery, it has some some limitation if the patient came with with massive brain edema. So this is a very challenging situation that sometimes we have to wait for a couple of days. But usually we can try to reduce this situation with try to make the extraventricular drainage or lumbar drainage first. So sometimes it's helpful. But sometimes, we can see if very massive brain edema, so we have to wait. But in this case, maybe endovascular coiling should help. So this is very important, management that we have to make some collaboration in our center with our friend in the endovascular expert to solve this problem. I think that's all for education, Dr. Tines. Thank you.
Okay, thank you, Dr. Asra.
Yes.
Dr. Liu, anything to add on? Dr. Masin?
No, nothing.
Okay, if nothing much, on behalf of the organizing committee, we thank all the speakers for these sessions.
Boss, can we proceed with a photo session? Okay. If everyone's ready on my count, yeah? Smile, 3, 2, 1. Okay, one more time. 3, 2, 1, smile. All right, thank you.
Thank you again, all. Dr. Asmi,
Thank you, Asra.
Dr. Tines, Professor Misra. Thank you for joining us. Thank you.
Thank you again to our esteemed speakers and also our moderator for the first session of the vascular talk. We shall proceed without further ado to the second half of the vascular neurosurgery talks, which will be moderated by Dr. Muhammad Aidil and also Dr. Muhammad Shahiran. Without further ado, I think Dr. Muhammad Aidil and Dr. Shahiran, they are both here. So let's proceed to the second session.
Hello and good day, everybody. So for the second session, for vascular session for today, I will be the moderator and along with Dr. Muhammad Aidil. So without further delay, I would like to introduce our first speaker for the second vascular session. I think a well-known neurosurgeon, Professor Basan Kumar Misra. He's been with us since yesterday. So he's the head of Department of Surgery and head Department of Neurosurgery in Hinduja National Hospital and MRC, Mumbai, India. I think without further delay, I would like to give the floor to Prof for his presentation.
Thank you. Good afternoon. Thank you, Asmi, and thank you very much for giving me this invitation and opportunity to share some of our thoughts with our colleagues. This is a beautiful program you have done, and thank you very much for continuing this education. So I will be talking on microsurgery of giant aneurysms, and I will share with you some of our experience. There is no conflict of interest. As you know, giant intracranial aneurysms have problems. They have wide neck, they have involved branches, perforators, thrombus, atheroma, calcification, complex anatomy. So why treat it? Unfortunately, if you don't treat, the natural history is disastrous. Left alone, in about 2 years, most of them either become disabled or die. So they need treatment. It's important that they are treated. They're actually worse outcome than a glioblastoma. So if you're operating glioblastoma, there is no reason why you should not be treating giant aneurysms. And unlike the common belief that giant aneurysms are thick walled, calcified, they don't bleed, the risk of subarachnoid hemorrhage in giant aneurysms is more than the common garden saccular aneurysm. So they need treatment. What about coiling, endovascular treatment generally? Generally, in aneurysms, there are 4 prospective randomized trials in the literature which has been published. One was the ISAT, of course, changed the paradigm of aneurysm treatment in the world. The 1-year results were better, but not at 5 and 10 years, except for deaths in the endovascular arm. BRAT was published in 2019, Journal of Surgery, no difference in the outcome at any time point. FINISH, no difference. Lee study, no difference. And this is the BRAT study. Not only there was no difference, but the crossover with the people who were in the endovascular arm to go over to the microsurgical arm was more than 1/3 of the patients had to be treated by microsurgery because endovascular treatment was not appropriate. Similarly, the retreatment rate was much higher in the endovascular arm, and the complete obliteration rate in the endovascular arm was also much less compared to the microsurgery arm. And if we talk about the giant intracranial aneurysm, it's endovascular treatment. You see, this is published in 2016, flow diverters. At 2 years, there was no complete occlusion in 16 patients of giant aneurysms. And if you do the diffusion weighted MRI images, there's 62% evidence of ischemia after endovascular treatment of giant aneurysms. And so the risk in the endovascular treatment of giant aneurysms is not less as compared to the microsurgery. So microsurgery, there is no question, it's more definitive, more durable, there is no question about that. There is a higher morbidity. So you need to change that. If you can reduce the morbidity, then probably microsurgery would be the preferred treatment for intracranial aneurysms. So some of the basics we need to follow. In my practice, we do more skull-based approaches today for aneurysms than in tumors, paradoxically. Because skull-based tumors give you space, whereas aneurysms does not give you space. So every extra millimeter of bone drilling give you that space to reach the parent artery without retraction of the brain. And retraction is the cause of major problem, post-op contusion, morbidity, and so on. So OZ approach is one of our workhorses, especially in complex giant aneurysm, posterior circulation aneurysm. So it is necessary for the young neurosurgeon to master all these skull-based techniques. Important to have, again, wide opening of the sylvian fissure so that you avoid a CSF, you drain, and even in a edematous acute aneurysms, once you drain that out, without sacrificing the veins, you can have a wide exposure and you don't need to put any retraction, as you can see in this. Similarly, the revascularization is one of the mainstays in many complex aneurysm treatment, and this is not going to go away. It doesn't matter how developed the endovascular arm is. So the young neurosurgeon is advisable to go to the lab and master this technique. This is going to help you in the long run. Now, sylvian fissure opening is an art, and sometimes it could be very difficult, especially in a ruptured aneurysm, and especially if you're operating after 7-10 days, because it's all clot there, and it takes quite a few, times. It takes time to dissect it, and the perseverance, with a lot of patience, you need to open up the sylvian fissure. And one of the techniques which helps is irrigating the saline inside the flush it out, and then you can open up and it becomes easier to open up that. So that patience, without sacrificing the veins, opening up does help to reduce the morbidity and have a wide opening without producing contusion to the brain. So that's very important that you have the patience. The other basic is temporary clipping, adenosine, and that can help. Now, this is an aneurysm, giant aneurysm which has burst. This is the area which has burst. Now, we put temporary clips, as you can see. These are ICA, inferior wall aneurysm. We have put temporary clip proximal and distal. But in these aneurysms, these large giant aneurysms at the skull base, where they perforated, it is stuck to the skull base. So in spite of my temporary aneurysm, I need to release the fundus before I can put clips. And when I do that, it ruptures, and it's invariably it ruptures. And in spite of the temporary clip, there is significant bleeding. And this is where the adenosine helps, and we give injection adenosine, which gives you 20 seconds about time to put patties there. You see that patty there. So we block that area of the bleeding and then put a suction over the patty, not without the patty. Now you have a good feel. So now we have to take off the temporary clip, because then I am going to put fenestrated clips. Now the bleeding is stopped because I have packed it, not because of adenosine. Adenosine has given me time to put that back. And then multiple fenestrated clips with the clip blades parallel to the parent artery. It's a typical way we do this inferior wall aneurysm or ICA. Multiple clips, and you can see both from proximal to distal. And then we do the ICG. We see the ICA is pulsating nicely, and this is the post-op CT angio. And in all these patients complex, we always do a DSA, because post-op CT angio is not enough to say that the vessels are intact. This is another technique which is a very useful technique for proximal ICA aneurysm. Now we have explored in the neck. The ICA is occluded in the neck. Distally, we have put a clip, and we have occluded the temporary clip. Now, when we suck it out, you will see it will collapse. You see that is sucked with collapse. So that helps us to put clips. So this is the Dulles suction technique from the neck. And you see that we have, I'll skip some of the video. There's still some, we thought it we have taken care of, but their aneurysm was still filling. So we put back the temporary clips again, and we put more clips. Again, same problem. When we do that, it bleeds because the base, the fundus is stuck to the skull base. So we need to release that before we can have complete occlusion, which we achieved finally. And we also see use fluorescein, and fluorescein is a useful adjunct to see the perforated small vessels are better seen with fluorescein angiography than in ICG angiography. So we use both as complementary tests. The other adjunct is endoscope assistance, which helps you, getting the perforator seeing after the clipping. You see, we have this a PCOM giant aneurysm which we have clipped. Now we are trying to see if the perforators are all right, the parent PCOM is all right. So we are going to put an endoscope there. Microsurgery we could not. So now we've done the ICG, we see that. But we were still not very convinced about the normal vessels. So we are going to, I think, now put the endoscope. And this is important. Now you put the endoscope to see that's the third nerve there. There's the temporal lobe. There's the perforators nicely seen that. So it's very important to use this as an adjunct. We don't use endoscopic microsurgical clipping, but use it as an adjunct. It's a beautiful tool for that. So the various ways you can exclude the aneurysm by clipping. There are multiple different types of clipping techniques, fenestrated clips and double clipping technique, the fenestration taking care of the parent vessel. And there are various exclusion options you can have. You can have flow diversion, you can insight to anastomosis, and so on. So I'll give you some of the examples from very, very simple treatment to complex treatment in giant aneurysms. This is a giant aneurysm. On the right side, you do the balloon occlusion test. Patient tolerates. He's a 70-year-old gentleman. This is a very simple treatment to occlude the carotid in the neck. You don't need to do a bypass. He's an elderly fellow. Bypass is a major procedure. So we just occlude the right ICA in the neck, and that's about it. Takes care of the patient without any problem. A little more complex patient. This is a man in his late 50s. Was all his vessels are diseased. The right ICA, the left ICA, the posterior circulation, all these are dolichocephalic. The patient presented to us with visual compromise because significant thrombus inside the right ICA aneurysm. This is dolichocephalic artery. So we actually were not sure how best to treat this because all his vessels were diseased. So we observed him for some time. Over a period of 1 year, his progressive loss of vision, mainly on the right side. So he forced us to do something. And so we did a high flow right radial artery bypass graft from ECA to M2. So you bought him some time. The vision got stabilized, but he is going to have problem. In fact, he did have worsening over a period of 2 years after that. But because all his vessels are diseased, but we got him some time. This is another example where microsurgery, the way to go, endovascular treatment failed. This is a man post-traumatic pseudoaneurysm from the cavernous carotid, which had burst into the sphenoid sinus, and he presented to us with right side blind, left hemiparesis, altered sensorium, and multiple epistaxis. So we asked our endovascular colleagues, they couldn't do it because there was a fracture segment lying in the wall of the pseudoaneurysm. So they were worried that the artery will give way when they put a flow diverter. So we had to go in, and again, the same treatment. We did a high flow radial artery bypass graft, standard technique, ECA to M2. And here you cannot just ligate the ICA in the neck. You need to do trapping because it's pseudoaneurysm, because from here, it can go back to the pseudoaneurysm, it can still bleed. So you need to trap, unlike the previous one where only ligation in the neck was sufficient. So this is a very interesting young man to another unit because of this giant 8-centimeter ICA blowout aneurysm, which had burst into the subdural compartment, producing an acute subdural hematoma. He had a decompressive craniectomy, survived, was sent to us for definitive treatment. And we did the CT angio. You can see that here. This is the giant aneurysm. He also had unruptured basilar top aneurysm. So we advised him treatment. He ran away till after 1 year, he came back with progressive hemiparesis and headaches, intractable headaches. So again, the same treatment, ECA to M2, bypass graft, again trapping because we had opened the aneurysm in the middle cranial fossa, decompressed because the aneurysm was 8 centimeter, the arterial graft was not sufficient. So we had to decompress to the middle fossa of the aneurysm and then put a radial artery bypass graft. And for the basilar top aneurysm, unruptured one, we sent for endovascular treatment, but it failed because the PCA was coming out from that. So we did again the skull base approach and we clipped it. So the basilar top again was clipped. You can see that here with multiple clipping technique, what called aneurysmography. We sacrificed the PCOM because it was ending in the aneurysm, and this was after 2 stays, 2 different times, after 6 months of the first surgery, before the patient was discharged. There was no deficit, and the patient was discharged without any deficit after this 2 stage treatment. What about an unruptured large or giant ophthalmic aneurysm? The standard of care today, mostly in the North America at least, is a flow diverter. This is a good form of treatment, especially for the unruptured aneurysm. It's a good form of treatment, but this is not without risk. This is one example. We are seeing more and more of these patients. There's an ophthalmic aneurysm in Mumbai, was treated appropriately. One of the endovascular colleagues here, and very nicely treated. The aneurysm was completely occluded. The vessels, parent vessels were intact. But 3 months down the line, the patient presented to me with progressive visual compromise. You can see on the MRI significant edema of the optic pathway, and it's extremely difficult to treat it. So we are seeing more and more this patient. This is another patient who was treated in another city with a giant ophthalmic aneurysm again, flow diverter, multiple stage treatment. He came with visual compromise and finally landed with hemiplegia, bedridden, and aneurysm was still filling. So this you can see, right hemiplegia, there is some improvement in facial asymmetry, but he was bedbound. So flow diverter is not without risk and is not a panacea. One has to remember this. So when you see a patient like this, the lady in her late 40s presented with visual compromise, 4 centimeter aneurysm, ophthalmic, unruptured, completely circulating, this producing a mass effect. So we do a protective bypass and do the aneurysmography clipping because this takes care of the mass effect immediately, and the patient has immediately after the operation visual improvement. And if you put any form of endovascular treatment, the visual compromise remains, and sometimes when it gets thrombus, they can be worsening, like what I showed you in the examples. Now, this is a child, 2.5-year-old child, was treated by me 11 years back. The child came with altered sensorium. He had gross hydrocephalus, heavily thrombus, calcified, giant basilar top aneurysm. These were the circulating components. This is the thrombus and calcium component in that. So we did a shunt. The child became asymptomatic, became normal completely. So we didn't know really what is the best way to do it. We asked our endovascular colleagues. This was in 2010, I think, 11 years back. And they put 17 coils. The aneurysm was well occluded. But unfortunately, over the next 48, 72 hours, the patient rapidly deteriorated went on to the ventilator. We did a scan. The shunt was working. And patient started extending. So we didn't have a choice to go for a OZ approach, extensive skull base approach, and decompress the aneurysm and clipped it. He had a very stormy postoperative course. At 1 year, he was mobile. At 5 years, he was going to school. He had some motility problems, and there's a 5-year MRI. And last year, he came back, 11-year follow-up, aneurysm occluded. Patient is intact, mild hemiparesis, some ocular motility problem, but otherwise completely functional. Brainstem is okay. The patient is fully functional. So this is some of the things which we need to do it when there's a thrombus, heavily thrombus calcified. Now, some few months of that child, we saw this adult, similar patient, giant thrombus, basilar top aneurysm. This was a surprisingly easy aneurysm. We did the same operation, the OC, extradural enterocraniotomy. This is a posterior craniotomy intradural, drilling of a few millimeter of the posterior cranium to give you that space to access to open the aneurysm because the neck had no thrombus. The thrombus was all in the fundus. So we could put 2 multi-curved titanium Yasargi clips and occlude the aneurysm completely. This is the PCA branch of PCA. You can see the ICG, PCA, right PCA branch, the left PCA, and this is the post-op immediate CT angio. Again, every time we do a complex or giant aneurysm, we need to do a post-op DSA. CT angio is not sufficient enough to give you that information. The DSA, you see complete occlusion of the aneurysm without any compromise. He had partial third nerve paresis, but 3 months he was absolutely intact, no deficit neurological. This is 3 months follow-up in my clinic. Same procedure. So another aneurysm, giant and multiple aneurysm, bilateral MCA aneurysm, patient presented with coma from the right MCA, ruptured aneurysm. This is thrombus, this is circulating component, all the vessels coming out from the MCA bifurcation. Again, this is an aneurysm which cannot be treated by endovascular means. So we treated it in acute form, and patient, of course, remained with hemiparesis, but came back after 6 months for the repair of the left side unruptured MCA. So the right side had ruptured, which you took care with multiple. You see, there is a complete art form there, because you need to have an architectural clipping to have a complete occlusion with preservation of the vessels. As you can see, all the vessels are intact, both sides, and aneurysms are taken care of. This is another unusual form of treatment. Again, ICA, fusiform aneurysm. The anterochoroidal and the PCOMs are coming out from the aneurysm. So this is where we do what is called vertical stacking. Unlike the common garden clipping in the inferior wall aneurysm, when the clip blades are parallel to the parent artery, here the clip blades are perpendicular to the artery. Now I'll skip all that, most of it for the time constraints, but you do the anteroclinoid drilling. We had to have temporary clip in the ICA, and then we put multiple fenestrated clips with the clip blades perpendicular to the parent artery, so that you can spare the PCOM and the anterochoroidal between the clips. So we do that, and I just wanted to show you the, and once we have done the clipping, we opened up the aneurysm, we see the ICG, and then once we are happy, we see the anterochoroidal. Is very critical that we see all the perforators and the choroidal, and you can see the perforators there, very wet seen with the fluorescein angiography. So we put some slivers of cotton, because these are diseased arteries, and we put some glue, and this is how it looks post-op DSA. You can see the blades all perpendicular to the parent artery, and the artery is taken care of. Now this was a patient with subarachnoid hemorrhage. Very similar patient, another one we had without subarachnoid, sorry, that is the next one. This is without, this is an unruptured on the right side, that was on the left side. Now when we did that same tip technique, vertical stacking, there was some aneurysm which was left. There was a question, what happens when you have some residual aneurysm? Now this one, when unruptured aneurysm, fusiform, so we observed it for some time. This is which we have learned for endovascular please. They talk about 90%, 95% occlusion. We talk always about 100% occlusion. But when there is an unruptured giant aneurysm, it may be worthwhile to follow it up rather than doing something. And this has completely disappeared over a period of time. So this is this is a CP angle tumor. It was presented with a giant vertebral aneurysm, 3 centimeter. So we did a far lateral craniectomy, and then we take care of the aneurysm there. You see that? I will skip some part of the videos. This is the whole thing is circulating. So I have accessed the proximal distal vertebral artery, temporary clips, and then once we have put the temporary clip in the vertebral artery proximal, so we coagulate the wall and we suck it out. It collapses like a cyst because it's completely circulating. Then we dissect the wall of the aneurysm from the brain stem, like you dissect a tumor, a cyst from the brain stem. And then we put multiple clips. Once we have put enough clips, we thought we have taken care of, and we cut it and we open the distal temporary clip to see if it is occluded. But when you open that one, you see it ruptures. Why it ruptures? Because the fundus is still stuck to the brain stem, and that's a problem with all these giant aneurysms. Once it is stuck to the base skull or some brain structure, you need to release that. So we released it, more clips, and then we see that the vertebral artery is intact. Critical to see the pica is intact. We do the ICG, and the vertebral, we see that pica is intact, and then the patient, of course, this had a recurrence after 10 years. We are following every second year with angiogram. He has now had last year recurrence, which we have sent for endovascular treatment. So lesson learned, old-fashioned clipping occludes most aneurysm. So this is a combined approach. This is a giant distal aneurysm in a young patient. Endovascular treatment failed. Very short clip. Again, you see this is a very thick walled unruptured aneurysm. but no clip would sit there. So I'm putting a bayonet forceps to hold the neck, make a neck so that multiple clips could be put and similar. So, but we had to leave a little bit because the anterochoroidal was getting compromised. And then after the clipping, we did the angiogram. You see there's a residual. Started off with this. This was left, was sent for endovascular clip. And this is the last slide. Last trick in our trade. There's a child from Bangladesh, 3-year-old child with subarachnoid hemorrhage, basilar top, all the vessels coming out from the basilar bifurcation. So we took care by the hypothermic cardiac arrest. Some of these aneurysms still don't have an answer. So this is, we have published in this year, our giant aneurysm experience of 147 cases. People who are interested can access that. So what helps? Technique and technology, the skull-based approach, bypass, adenosine cardiac arrest, and some of the technology. Of course, very, very important for the young neurosurgeon to go into practice, but it's very important for the neurosurgeon to have perseverance because there are going to be complications. So we have to have guarded optimism. So I think the flow diverter is not a panacea. We have to individualize. Old-fashioned clipping, a disappearing act, can occlude most aneurysms, and microsurgery is going to stay. But we're going to have complications, problems. So we need to introspect some time. Before I close, invite you to the Skull-Based World Congress in Rio and our Continental Congress. Thank you very much for your attention.
Thank you. Thank you, Prof, for the very impressive talk. We have been giving us a numerous amount of cases, and I think we can learn a lot from his experiences from this talk. So I think we keep the questions in the Q&A session after this. So I would like to our next speaker, which will be from Japan, of Emergency Medicine, Fujita Medical College, Bantani Hospital, Nagoya. So he's a licensed emergency specialist of the Japanese Association for Acute Medicine and a critical care specialist of the Japanese Society. So his topic today will be concept and evaluation of cerebral blood flow by Japanese emergency and critical doctor. So I think it's a pre-recorded session, so I leave it to the admin to continue with the.
Nadia, we can't hear.
Give me a second, yeah.
Okay, thanks.
Asmi, there's still no sound.
Yeah, we can hear from the control room. I asked them to redo back because the video moving, but we can't hear. But in the control room and the seminar room, it can play. So let us check back.
Hello, Dr. Azmi. There's the option over the screen up there, play from the computer sound.
My name is Hideki Tokuyama. I'm an emergency physician and intensivist in Japan. I am very honored and happy to be invited to give a lecture today at this AASNS educational course. I would like to express my gratitude to all the staff of this course and wish for the success of this conference. Thank you for taking time.
This is the Bantan Hospital where we work. We emergency physicians examine and treat a patient brought in by an ambulance crew and walk-in emergency patients, and manage critically ill patients who are hospitalized. There are currently 5 of us, and this is the ICU where we mainly work. As general physicians, we do not examine individual organs, but the whole body, and we seek to find the best management for our patients. I will discuss the concept and the evaluation of cerebral blood flow as we Japanese emergency physicians. This is very famous graph of the autoregulation system of cerebral blood flow. As we all know, in normal person, the minimum cerebral perfusion pressure is set at 50 mmHg, and then cerebral blood flow remains constant to some extent even if the cerebral perfusion pressure changes. The cerebral perfusion pressure is mean arterial pressure MAP minus intracranial pressure ICP. Our goal is to maintain the cerebral perfusion pressure at 50-70 mmHg at all times. This red line shows the relationship between MAP and CBF in acute injury states. In acute injury states, most notably traumatic brain injury and subarachnoid hemorrhage, cerebral blood flow is frequently reduced to level approximately half of normal, and autoregulation is impaired. Mean arterial pressure that might be tolerated in normal subject may reduce cerebral blood flow to critical low levels. The CBF varies with the level of ICP. The higher the ICP, the lower the CBF will be. So we need to predict the level of ICP. Methods for ICP monitoring can be divided into invasive and non-invasive approaches. There are several ways and locations to insert the ICP sensor. Of the invasive methods, ICP monitoring using an external ventricular drain is considered as the gold standard, not only for its accuracy, but also because it additionally serves cerebrospinal fluid drainage. Unfortunately, the insertion of ICP sensor is not yet popular in Japan. We emergency physicians don't have that skill, so we often use the non-invasive approaches. The question is how to estimate intracranial pressure. But in general, there is no highly accurate method of examination. This is the BMJ report on physical and head CT findings in the presence of increased intracranial pressure. It shows the sensitivity and specificity of pupil, limb movement, GCS, and CT findings, with gold standard finding being ICP of 20 mmHg or higher. Although the pupil findings have excellent specificity, the sensitivity is low, and motor posture and GCS are also inaccurate. The CT findings on bedside system absent and compressed have good sensitivity but poor specificity. As the CT findings are also not reliable in terms of accuracy, we use the optic nerve disk diameter to estimate the ICP. Let me tell you about that optic nerve disk diameter. This section describes the ONSD that we use to estimate intracranial pressure. First, we show the anatomy of optic nerve and optic nerve sheath. As shown here, the subarachnoid space along the dura mater surrounds the optic nerve and extend up to the optic nerve disc. In other words, the effect of intracranial pressure extends to optic nerve disc. ONSD is also indirect reflection of intracranial pressure for this anatomical reason. We will talk about techniques for ONSD measurements. The echo machine uses a linear probe. The echo probe is applied over the closed eyelid, and if the patient is unconscious, we will check where the eyeball is located beforehand. In this way, the optic nerve will be depicted behind the eyeball. Freeze the echo image at well-depicted position and then measure the ONSD. The measurement location is optic nerve system 3 meter posterior to the top of the papilla. However, there are a few points to keep in mind. Since ultrasound produces heat in the bone, the eye surrounded by the bone may be affected by the heat, so the echo irradiation time should be as short as possible and the measurement should be done with a stereo image. In Japan, ultrasonography equipment that meets these specific criteria is allowed for ocular use. Here are the ONSD data for intracranial pressure measurement. In a study by Kimber et al., ICP sensors were inserted and the relationship between the actual measurement by ICP sensor monitoring and the ONSD was examined. 38 ocular US were performed on 15 individual patients. The results are plotted on graph figure 1. And figure 2 shows the box plot on ONSD for patients with ICP greater or less than 20 mmHg. The box represents the interquartile range. The box on left for data with ICP less than 20 mmHg. The mean ONSD was 4.4 mm. And the box on the right is for data with ICP greater than 20 mmHg. The mean ONSD was 5.4 mm. The arrows curve for these results is shown in figure 3, and the area under curve is 0.93. ICP 20 mercury was used as a cutoff value. 5 milli ONSD or more result in 88% sensitivity and 93% specificity. 4.5 mm ONSD or more result in 100% sensitivity and 63% specificity. Here is the meta-analysis data of the ONSD. This figure shows the area under curve of the ROC curve for each study, and the overall area under curve is 0.94, indicating that ONSD is very useful tool for intracranial pressure measurement. The ONSD also reflects intracranial pressure in real time. Intervention is suctioning of the endotracheal tube to evacuate sputum in intubated patients. Ultrasonography of the ONSD was performed, and ICP measurements were recorded simultaneously before, during, and after this procedure. The first measurement was recorded 30 to 60 seconds prior to cleaning the tube. The second measurement was obtained during suctioning, and the third measurement was performed 30 to 60 seconds after the procedure. Remarkably, the ONSD changed before, during, and after the intervention, as did the ICP. This is a study showing change in ONSD before and after lumbar puncture in a total 84 patients, 66 with normal ICP and 18 with elevated ICP. The spinal fluid was drained by 3 to 4 milliliters. It can be seen that regardless of the base ICP value, the ONSD shrinks with drainage of only 3 to 4 milliliters of spinal fluid. Here is our strategy for patients with suspected intracranial hypertension with impaired consciousness. If the ONSD is less than 5 mm, we assume there is no intracranial hypertension and aim to maintain a mean arterial pressure of 70 to 90 mmHg. Unless the ONSD is greater than 5 mm, in which cases we consider the possibility of intracranial hypertension. If the ONSD is greater than 5 mm, we consider the possibility of intracranial hypertension and then measure regional cerebral oxygen saturation with INBOS. I am sure many of you are already familiar with INBOS, but I would like to briefly introduce it to you. INBOS measures tissue oxygen saturation (TOS) by measuring oxidized and reduced hemoglobin through near-infrared light. INBOS can measure regional cerebral oxygen saturation in the frontal lobe. This value correlates positively with jugular valve venous oxygen saturation (SJ/O2), and a decrease in this value may be due to a decrease in CBF or a decrease in SaO2. We believe that when regional cerebral oxygen saturation is decreased, if there is no problem with arterial blood gas, CBF is decreased, and we should first make effort to further lower ICP and review the target value of MAP. In some cases, the indication for decompression craniotomy should be discussed with the neurosurgeon. Here are some thoughts on regional SO2 as measured by INBOS. The normal value of regional SO2 is around 60 to 80%. The upper table shows the normal state, i.e., the brain's oxygen demand and supply are in balance. The lower left table shows a state in which regional SO2 drops to 60% or less, i.e., oxygen supply to brain is insufficient, which is caused by low cardiac output, or low oxygenation, or low cerebral blood flow. Table on the lower right shows an elevated regional SO2 level. This indicates a state of decreased oxygen consumption in the brain due to brain damage, etc. This is the INBOS monitor screen showing the regional SO2 value split into left and right. In cases of low regional SO2 as measured by INBOS, if arterial blood oxygen saturation is normal, CBF is considered to be decreased. Except in cases of low blood pressure, effort should be made to lower the ICP. The way to do it is head elevation at an angle of 30 degrees. Administer mannitol, hypertonic saline, transient hyperventilation, aim for PCO2 of 30 mmHg, sedation. And if the patient is not synchronized with the ventilator, we use neuromuscular paralysis. The indication for surgical intervention will also be discussed with the neurosurgeon. Finally, we would like to conclude by again presenting our strategy for a possible increase in ICP. For ICP estimation, ONSD can be repeated due to its high sensitivity and specificity, as well as its real-time simplicity. INVOS allows for non-invasive assessment of cerebral blood flow. Thank you.
Thank you to Prof. Hideki. It's a great talk, and it's quite refreshing to hear about neurosurgery from a different perspective, especially from a emergency physician and intensivist. So I would like to apologize for the initial technical glitch initially. So I think without further delay, I will present our next speaker. Otherwise, it's a well-known speaker to every of us. She's Prof. Yoko Kato, is a professor in neurosurgery from Department of Neurosurgery in Fujita Health University, Japan. She's been awarded. She's the first female full professor of neurosurgery in Japan, and without further delay, we proceed with her presentation. I leave it to Debbie.
So it is my great pleasure to be invited the wonderful meeting of the webinar joint AASNS educational course and the second KL Neurosurgical Emergencies 2021. I want to thank you very much for the chairman of the conference, Professor Azumi, and his best team. Wish a very successful, fruitful meeting. So today my talk is a recent treatment of cerebral AVM. So I thank you so much, Dr. Imat, and also Vladimir make such a wonderful anatomical committee meeting. So this meeting focused on how much Professor Franco Salvadai, who was the president of the World Federation for many years. So during his presidency time, I think many things has advanced and many things has changed for improving of the developing countries, especially the education and also the situation of the country itself. Once again, I want to thank you very much, Franco. Of course, you can guide and advise us in the future, of course. So this is the typical AVM and direct surgery. So I will show. So this is the right temporal AVM, 51 years old female, associated with a large aneurysm. This is a kind of a pedicle aneurysm on the IC. The AVM located the right temporal. So now we can see already the draining vein and also the nidus, some part of the nidus. So at the beginning we check the ICG. Then we get the main feeding vessels. So then we place the temporary clip and already the blood reaction of the nidus flow. So followed by we decided to the dissecting the surface and also cut the main obvious feeders. So the step by step, then we remove the nidus from the normal parenchyma. Just we decided to which side we need to reflect of the nidus. So the small fragile vessels should be treated, should be coagulated before we cut the final feeders. So the very precise of the parenchymal resection of the nidus is very important. This is almost the end of the surgery, but still some flow we can recognize the draining veins. In most of the cases, final feeding vessels is behind the draining veins. So we coagulated the draining vein, then we cut the final part, the main draining vein. So this is very ordinary the resection of the nidus. So this is another case, the left frontal AVM grade 2, 53 years old female. So this is the angio, and before we cut the dura, the ICG performed. Then this is for 800. Then we can draw the draining vein on the cortex for preventing of the injury of the draining vein at the beginning of the surgery. So then step by step, we cut the feeding vessels. Then we check the flow 800, how degrees of the flow of the AVM. So the getting decrease of the intranidal the flow. So this is a step-by-step reduction of the nidus flow. Then we can see the onyx. It is very high visible. It's one of the advantages of the onyx. So this is the final stage. So the AVM has so many issues to be discussed, but high grade AVM and also the eloquent AVM is one of the main topics. So as for the eloquent cortex surgery, so I want to share with you. So what is eloquent cortex? So those parts is eloquent lesions. So about mapping, so the currently most reliable method is direct cortical and subcortical electrical stimulation by awake craniotomy. So this is the most reliable method to detect the eloquent lesion. So this is a schematic drawing. Is preoperative. We do the functional MRI and DTI, and also the intraoperatively we can check the neuromonitoring, so intraoperative MRI and the neuronavigation and the wake direct stimulation. So this is a functional MRI, and this is the DTI. So DTI is based on the diffusion of protons in direction of the fibers. So this is the clinical aspect. So special margin grade 3-4, the so-called high-grade AVM. So if the asymptomatic patient, the observation should be the best. The symptomatic patient, the endovascular, the embolization, followed by the radiosurgery or direct surgery. So what is a high-grade cerebral AVM? So this is a spectral margin grade 4-5, the large, deep, involved elegant lesions, substantial surgical morbidity, and the indication of surgery will be following the previous hemorrhage, existing permanent neurological deficit, aneurysm association, and step phenomenon, still phenomenon, and suggest observation for the young age patient. So there are five modalities: endovascular and microsurgical resection, and radiosurgery observation, and also the combination treatment. So multidisciplinary approach is achieving cure of the treatment, endovascular treatment for reduction neither size before microsurgery or radiosurgery. The open surgery, this is still gold standard of the treatment, especially small nidus. Endovascular treatment, this is adjunct of the treatment. For surgical nidal reduction, the flow reduction is main purpose of this treatment. Radiosurgical treatment for inoperable or high grade of AVM. So this is how we can treat of the AVM with open surgery. So just we can check the MRI, and this is a 3D multifusion imaging, so the vein and the nidus, and also the feeding vessels. So how we can embolize these nidus. So this is the one feeder, another feeder, and the three feeders. So this is one very unexpected bleeding case during the embolization. So this is the onyx. Sometimes when we use the onyx, it should be very careful because the onyx is very slow injecting and plug and push vessel. So it's most of the case the onyx comes with a draining vein. So that is the big reason why the nidus bled. The patient had the mild hemorrhages, but it improved completely. So this is we resected the nidus immediately after the bleeding of the nidus with embolization. So high function OR is so many good devices for 800 ICG, navigation, monitoring, function MRI, tractography. So already I am shown. So this is a very perfect the hybrid or the high function OR. So this is a Pro 800. So this is exactly the same phase. This is a draining vein. So it can be the orange. The orange means it's the feeder, and in between the feeder and the draining veins. So we can see the intensity diagram. So draining vein can be in the middle of the feeder and the draining vein. So elegant lesion already I talked. The risk of the permanent neurological deficit is 40% for highly eloquent AVM, the pre-central cortex, basal ganglia, and brainstem. The 18% for less eloquent AVM, postcentral cortex, occipital lobe, and the dominant temporal lobe, and the corpus callosum. The 3% for non-eloquent area. So adjunct items to improve outcome of the eloquent AVM surgery is interoperative neurophysiological monitoring and the MRI DTI and the flameless stereotactic navigation. So the monitoring is very important when we do surgery of the eloquent or functioning cortex. So the motor mapping and speech mapping, the MEP. So these are the very fundamental the monitoring for elegant lesions, the treatment. So this is motor mapping. The disadvantages during the resection, increased precise detection at the cortical surface. And this is all you know, the MEPs. And also the speech mapping is important. So ABM near Wernicke area, and ABM near Broca area, and ABM near angular gyres. So as for the radiosurgery, they need more marginal dose, and also the volume staged radiosurgery is the newer strategy I will show you. It divides a large ABM into 2 or 3 smaller portions, treated at the separate stage, enabling each portion to receive a higher dose. So this is the staged nidus radiosurgery. So microsurgery is effectively to reduce the mobility as salvage technique after radiosurgery. So firstly, that we give the patient with the radiosurgery followed by the microsurgery. This is one of the new techniques. So this is the first time, and in between the first, second is wait 3-4 years, and the second, third wait 3-4 years. So then finally the nidus became much smaller comparing from the beginning. So this is the new treatment paradigm for high-grade ABM. So the staged embolization and or staged radiosurgery and the reduction of the flow and microsurgical resection. And this is after radiosurgery downgrading the volume of the nidus and followed by the microsurgical resection. So this is a flow treatment of the high-grade ABM. So this is surgery and embolization only, and this is a plans the single or volume stage radiosurgery. So this comes with a cure or incomplete reduction of the spectral margin grade, and followed by the surgery, and followed by the observation. So this is the microsurgery after the radiosurgery. So this is it has a very good result. Almost disappear of the nidus. We can recognize it with just method. So cure rate is over 80%. Surgical mobility mortality rate is 18.8%. So finally, the future diagnostic and therapeutic strategies of brain ABM. So this is a molecular and cellular biology of the ABMs. So it's a congenital static lesion and the sporadic cause, the growth, remodeling, and the regression, the rupture event. The new genetic, molecular, and cellular factors have been demonstrated to be involved in the process of the formation, growth, and rupture of ABM. How can biology impact the potential future management? So risk of the ABM rupture, one is genetic, the mutations, intranidal aneurysm, exclusive deep venous drainage, and the restricted venous outflow in the deep or infratentorial location. So this is a schematic drawing. It's the molecular and the cellular biology of the ABM. The expose of the abnormal, the high flow plus shear stress, and smooth muscle cell and the brain and the cellular cell, constant proliferation and the remodeling. So this is the four cause of the ABM nidus become large. So this is a genetic And this is experimental therapeutics and formation and the growth and rupture. So many factors and so many causes can ABM enlargement. So molecular and cellular biology associated with the syndromic ABMs. So sometimes we can experience about the HHT or CAMS. So ABM formation. So this is a single nucleotide polymorphism, SNPS, and also the TGF beta. So, and also the endocrine ENG is a glycoprotein located on the cellular surface, crucial for angiogenesis. So as for the ABM growth and rupture, the role for inflammation and the extracellular matrix remodeling. Macrophage and the neutrophils tend to invade ABM tissue. So matrix metalloproteinase play a key role in the growth and rupture of several ABMs. The brain endothelial cells have a higher proliferation rate with a reduced apoptotic response to inflammatory mediators. Multiple mechanisms, including inflammation, remodeling, and BEC abnormalities, contribute to tendency to rupture. So, about ABM treatment. Currently, the treatment is open surgery and radiosurgery and endovascular treatment. But completeness is endovascular is 30%, and also the radiosurgery is about 40%. So microsurgical resection is currently recommended for special Pons class A or special Martin grade 1 or 2 ABMs. In combined treatment, special Pons class B or special Martin grade 3. The palliative treatment, special Pons class C or special Martin grade 4 and 5 ABMs. So new treatment idea is a new cellular and molecular biological therapies are under development. So aims to radiosensitization and the vascular targeting and the remodeling therapies. So understanding of the regulatory factors and the pathways is very important. That is modifying the natural history away from rupture. So experimental therapy, so many drugs is appearing. So tetracyclines, doxycycline, and VEGF, the focal hyperstimulation delivered by an adenovirus vector showed in inhibition of the MMP9 messenger RNA expression. Thrombospondin 1 is another important drug. So this anti-angiogenetic therapy, thrombospondin 1, and also the VEGF-A antagonist, and bevacizumab is a very popular one. So this is pictures how the ABM has rupture. So in brain ABM, there is a hyperproliferation of the endothelial cells, green, and the focal area of the vascular smooth muscle cell, the blue, the proliferation and the degeneration are also noted. The thinning of the basement membrane, pale yellow, and the vascular smooth muscle cell degeneration contribute to the destabilization of the vascular wall. So this can be happen as a rupture of the ABM. So in conclusion, in understanding the complex cell biology, physiology, hemodynamics, and flow-related phenomena of AVMs is critical for defining and predicting their behavior, developing novel drug treatments, and improving the endovascular and surgical techniques. So, of course, for the moment, the main treatment, the tree is 3 categories, but we should think about the very basic, the research for preventing the increasing of the avian virus itself. Offers conservative observation for younger patients with ruptured high-grade AVMs and long life expectancy. Once there is a rupture or high risk of rupture, the surgical morbidity associated with the downgraded AVMs is reduced to that of post-radiosurgical, preoperative, supplemented the post-emerging phase. So sometimes we think about the radiosurgery, especially the large or the diffuse type of the nidus. You can give the radiosurgery in Dubai, especially in between the 2-3 years. That is one of the options for such a very difficult type of the AVM. Thank you for your listening.
Thank you very much, Prof. Basan Kumar Misra, Prof. Hideki Tokoyama, and Prof. Yako Kato. I hope everyone enjoyed this excellent presentation. Now there will be a slight changes in our sessions. I would like to invite firstly Prof. Yako Kato, followed by Prof. Hideki Tokoyama and Prof. Basan Kumar to give some remarks on current cerebrovascular sessions. Prof. Yako Kato, the floor is yours now.
Thank you. Is it some remarks?
Yes, Prof.
Okay.
Comments, anything. Thank you for joining us.
I'm so sorry because there's so many overlapping in the webinars. So, but I can be the catch up here the last moment. Thank you very much, Asmi. It was a wonderful meeting. Especially maybe the meeting, the many of the participants is not only the neurosurgeon but also the emergency doctors, I think. So even as a neurosurgeon, we always learn and study of the basic emergency techniques, I think, and we can share not only the doctors but also the emergency nurses. So we can work together. And also today's, I recommend Dr. Tokuyama. He's the chairman of the emergency medicine of the Fujita Health University. Yesterday, just we had one case of the organ transplantation case under the brain death. So I think those issue is under the control of the neurosurgeon and also the emergency doctors. So in the future, in the more and more important area of this kind of the meeting, I think. Thank you very much for Asmi, so organizing such a wonderful meeting. I'm very honored to be invited, and also I'm so thankful to share the knowledge with other Basant and also Tokoyama, of course, the others. Thank you very much.
Thank you very much for Yoko Kato for spending your time despite you having a concurrent webinar at the same time. We appreciate your time and your sharing experience. Thank you.
Thank you very much.
Now, can we have Professor Hideki Tokoyama, if you are online? Okay. All right. In case if you're online, you can after this. Now, I would like to invite Professor Basan Misra to give some comments, probably about overall this course, and also any advice to the young neurosurgeon especially, and maybe established neurosurgeon for in terms of education and especially in your special topic in cerebrovascular disease. Professor Basan Misra.
Thank you, Asmi. Can I just make a couple of comments about Professor Kato's talk before I go on to the general remarks, if it is okay?
Yes, yes, please.
Thank you, Professor Kato. It's a pleasure to see you. I think it was a recorded presentation, right? I mean, after that you joined it, right? Okay. So a couple of things. One thing about the radiosurgery, we have some experience with that. You talked about the staged radiosurgery after, after 3-4 years repeat. We have some experience with the advice of the Pittsburgh group of staged radiosurgery at 6 months. We do one volume, and either it is staged volume or reduce the dose and give the whole volume, and then again after 6 months, or give a sectorial AVM and then do it again after 6 months. So we have a small experience. The occlusion rate, obliteration rate is about not very high, but 50%. But our overall AVM occlusion rate from radiosurgery has been about 75% plus. So and that is one. The second thing about after the Aruba study, we do not advise any intervention, radiosurgery, microsurgery for special Martin grade 4, grade 5 AVMs anymore. Unruptured grade 4, grade 5 AVM, we don't advise any treatment anymore. So that's a change which has happened. We used to do stage radiosurgery, embolization, surgery, radiosurgery, combined treatment, and so on for these high-grade AVMs. But today we do not advise. So that has been a change in our practice since the Aruba, because there are medical legal implications, and of course the data doesn't support any intervention at this stage. So that's something I would like to say, and then Professor Kato can comment, and then I can go to the general comments.
Just a second. So, Basan, thank you very much for the nice comments. I don't have not so much experience about after radiosurgery, the direct surgery. Do you have any? Do you see any change, any difference? Those modalities. How do you think about?
Yeah, no, I think what I agree with were comments, what you said, that once the radiosurgery is done and the volume becomes small, it becomes a low-grade AVM and you can operate. We have a small series of post-radiosurgery, a small residue or failed radiosurgery, which we have operated. And the part of the AVM is the part which has been obliterated. We have also checked histologically. There is, proliferation there, and sometimes the problem is, even if the AVM is obliterated, there is a lot of edema around it. There is a lot of swelling around it. So the patient is symptomatic because of the edema, though they have not ruptured. So we have also gone in and operated some of those because they produce such a mass effect as a tumor. We have a few patients, not very large, but a few patients where we had to operate because of the mass effect or a cyst formation. Post-radiosurgery AVM. So these are completely occluded AVMs, or a small circulating component is only there. But it is much easier to operate those patients post-radiosurgery than in a high-flow AVM before radiosurgery.
So you want to recommend the
it's a very small experience.
Sorry. So maybe your recommendation is firstly radiation, followed by the surgery sometimes. If the AVM is large.
AVM is large. If it is grade 3, we do multimodal treatment. We could probably do embolization, sectorial, and then radiosurgery, and then microsurgery. That's one option. Or only embolization and radiosurgery, or the ones which have failed radiosurgery over, say, we wait for 3 years. Now, if the AVM has gone down significantly, wait 1 more year. If there is no change in the AVM, we would go advise microsurgery.
Thank you so much. Very nice advice. Thank you so much.
Asmi, can I give you some general comments? Yeah, thank you very much for this education course. It's a fantastic course, very, very high level of presentations. I really enjoyed it. Many of those I heard it. Some of them I could not, because Saturday is our full operating day. So in India, it's 6 days a week. So some of them I could not, but it's very good. Well, may I take this opportunity to inform you that we would like to increase the educational activity in our continent. I have now the privilege of becoming the chairman of the WFNS Foundation. So we would like to invite you, Asmi, and other one, two there, our continental president. Yoko, of course, is a very, very strong supporter and been a foundation backbone. But we'd like to have in Asia more, at least the postgraduate training centers, if not full training centers. What it means is you can support young neurosurgeons from different countries to come here to center, support them at least lodging and boarding, and if you can give some scholarship, it would be nice. So we would like to request you to please let me know if you people are interested. There are many centers with big volume of neurosurgery today in our continent. So if you would like to have some postgraduate training centers, please do write to us, and we would like to support that. And if somebody wants to have a full training center, there are some criteria which has to be fulfilled, and we can look after that. The other thing which as the foundation chair, we are responsible for supporting young neurosurgeons in underdeveloped areas or developing countries to support with instrumentation. And we have some plans of mentors. We have some plans of voluntary neurosurgeons committee, where senior neurosurgeons who are either retired or just before retiring, who have reduced their work, who are available to support departments in our continent. Please do write to us. We would like to take it forward, and we'll be very happy to be part of these education programs in many parts of the world, especially in our continent. Thank you.
Thank you. We all support you.
Thank you. Thank you, Yoko. Of course, you are backbone. You are backbone of the foundation. Yeah.
Thank you. Thank you.
Thank you, Professor Basan Misra, Professor Kokato, and the rest. So on behalf of the Department of Neurosurgery, Hospital Kuala Lumpur, and the local organizing committee, I would like to take this opportunity to thank everyone. So we have 33 speakers, 18 moderators. We covered 16 continuous academic hours without stop. There was no any break at all for 2 days, 37 scientific presentation, and we were joined by a complete 500 online registration. Of course, the numbers fluctuating on and off from 57 countries. So this is, I think, very wonderful. So I would like to thank AASNS, and I would like to thank the entire crew, IT, technical, which actually our registrar and our young specialists and our medical assistant. They are all doctors and medical staff, none from any IT technologies or expertise. So it's a DIY kind of courses, but it went well. So we also apologize for any shortcoming, like a video hiccup and so on, and for taking your time. So finally, I would like to invite Professor Xiaowan Tiu, the president of the AASNS, to give his remarks and in the closing ceremony, and probably promote the next AASNS Congress in 2022. So Prof. Xiaowan Tiu.
Thank you, Asmi, and thank you, Basan, Yoko, and everybody else who have been here to make this a really, really wonderful course and meeting. And I think it does show the standard that we have around Asia to actually bring this. And of course, Asmi, we need also to thank John Bennett, who has graciously helped us to, push this, streamline this meeting live stream across the YouTube and also Facebook. And I think, this wonderful technology is really, this pandemic in some ways it's affected us very much in terms of workload and things, but actually in terms of education, it actually helps us to push the borders even further, so that actually many people across the world can actually listen. And best of all, even if you have missed some of this, meeting, part of the meeting, you can still now go back to YouTube and actually, go through some, and sometimes actually it's worth learning, going through the talk a second time, because then you learn much more. And this is really the reason why, the AASNS and even the other organizations, the World Foundation is there, because we need to push the education of neurosurgeons. We need to bring neurosurgery to a standard where patients around the world will actually have access to very good quality neurosurgical care. And I think that's what we are all here for, and we should never forget, you know, in spite of sometimes there's a lot of politics, sometimes there's a lot of rivalry, but in reality, we're here because we chose to be doctors, we chose to be neurosurgeons for a reason, to help people, and therefore let's not forget that's our ultimate end. And the association societies are here to help you to improve your skills, whether it's actually just through didactic lectures, through webinars, or actually through a fellowship and teaching you. Right? I mean, we'll try to make that available, as Basan has said. The WFNS Foundation is there for this purpose, and certainly in Asia, right? It's not just we don't have a lot of rich countries. We do have, but we also have a lot of countries that actually are still quite poor, are developing, and there's a need for us to bring neurosurgery so that patients in this part of the world will get access to really, really good quality neurosurgical care. Now, if you allow me, let me just share my screen to talk about the neurosurgical meeting that's coming up, and that's the Congress of Neurosurgery, AASNS, and the next one is going to be in Jerusalem, as many of you have heard. It's going to be from the 6th to 8th of September, and let me see what else. Yeah, so I mean, Jerusalem is not difficult to get to. It's on the western part of Asia. Right? There are many direct flights there. I know also that in a way, there's an elephant in the room, because there are many Asian countries, unfortunately, that do not have this diplomatic relationship with Israel, and so that may be a problem, especially for people in Malaysia, possibly Indonesia, who may not be able to go to Jerusalem. But I understand from our Jerusalem colleagues that Israel is open to people attending conferences, but of course, you probably need to find a way, get permission from your country to leave. Don't want you to get into trouble if you're not supposed to go. But hopefully, because of educational reasons, right, we should all have a chance to go. So hopefully things will happen in the correct way. But you can see there are lots of things in Jerusalem. It's actually taking a walk through time from the ancient to the modern, the beautiful countries, a lot of the archaeological things as well, and of course the very good food down there, right? And other nice places to go. Even the Dead Sea, you can go and float there and so forth. Okay, so the important dates are this, right? The abstract, it's going to be started. I think it's already started. Just check the websites. Right? Submission by March. The registration deadline is in June, and then regular registration deadline in August. Okay, that's it for that. Hopefully that itself will entice you a little bit. But like I say, there is this elephant in the room that we all need to look out for. So thank you very much, Asmi, and the whole organizing committee for actually putting up this wonderful course. And thank you for all the speakers who have taken the time to spend this time here. Thank you.
Thank you, Professor Siawantiu. Now it comes to the last part, which is the most important thing, is photo. Yeah. So, so we have to document, I think the most enjoyable session. So please on your video, and we will document it as our method of physical attendance. So count on Nadia, is it?
Yes, Mr. Azmi, on my count.
Okay, just say it and when to smile.
All right. Okay, everyone ready? 3, 2, 1, smile. Okay, one more time. 3, 2, 1, smile. All right.
Thank
We're
you.
all good. Thank you so much.
Okay.
So, thank you, everybody.
Very much.
Have a rest
everybody.
of the good
Well done,
week,
well done.
and take care. Asmi, thank you so
Bye.
much again.
Thank you.
Bye, Basan. Bye,
Bye,
Yoko.
bye, 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 everybody. Bye, Wanchu, bye, Yoko, bye, Asmi.
Bye.
Thanks.
Bye.
Asmi, thank you very much.
Thank you,
For the last
Brother
moment. Thank you.
See you
Congratulations,
again.
as always.
Thank you.
Thank you. Thank you. See you soon.
See you soon, very soon. Thank you, Liu, Nadia, Aidil, Waipeng, Priya, yeah, Dinesh, Zinli, Prof. Eka, Shuyi, Azhari, and everybody watching us from YouTube, Neurosurgical TV, as well as Zoom. So till we meet again in future meetings, so stay safe and keep in touch. Bye-bye.